17th century. So there was a painting which was found in 17th century. There was a lady fainting. This was painted by Pietro Longhi in 1744, and paint was named as the faint. The faint. So syncope is it's not a new word. It's a word which is derived from the Greek. It means that to cut short or to interrupt. So that is the meaning of a syncope. So syncope is not a new terminology. It is present in the history itself. So how do you define a syncope? So to define a syncope, there should be a transient loss of consciousness, which should be associated with a loss of voluntary muscle tone, and the onset should be relatively rapid, and the recovery is spontaneous, complete, and prompt, and the underlying mechanism is a transient global cerebral hypoperfusion. So these 5 points should be there to say that the patient has a syncope. There should be a definite loss of consciousness, there should be a loss of voluntary muscle tone, the onset should be rapid, and the recovery should be prompt and complete, and the underlying mechanism is global cerebral hypoperfusion. That mechanism is also important, that it should be a global cerebral hypoperfusion. Suppose seizure, it is not due to a global cerebral hypoperfusion. So what is the difference between syncope and sudden cardiac death? In syncope, patient wakes up. In sudden cardiac death, patient doesn't wake up. So that is the difference between the syncope and sudden cardiac death. So this is what it's very, very important. So if you miss a syncope which can cause a sudden cardiac death, then you may lose the patient. So syncope and sudden cardiac death are almost same. Only thing, the patient wakes up in a syncope, and one in a sudden cardiac death, patient doesn't wake up. So who should evaluate a syncope? Syncope, lot of time there are a lot of confusions, whether a cardiologist or a neurologist or an electrophysiologist or a psychiatrist or a general physician, who should evaluate the syncope? So basically, a syncope should be evaluated by a good general physician, and adequate referrals has to be made to not miss any causes which can cause a sudden cardiac death. So there are, how do you differentiate a syncope from a pseudo syncope or syncope mimics? So usually syncope and seizures come close hand in hand. How do you differentiate? So basically, when you see it's an epileptic seizure, there will be there is a chance that if it's a tongue bite, then it more goes in favor of a seizure. If the duration, if it is lasting more than minutes, then it goes in favor of a seizure. If it is for seconds, then it's a syncope. And if there is a post-ictal state, post-ictal confusion or a memory deficit which is occurring for a longer duration of time, then the most probably the diagnosis is a seizure when compared to a syncope. And if there is an urinary or incontinence, then it is more of a seizure. And patient, if the eyes are open, then it's more like a syncope when compared to a seizure. And fatigue is very common when in a seizure when compared to a syncope. So what are the syncope mimics? So lot of conditions can mimic a syncope. A transient ischemic attack, a hypoglycemia, everything can mimic a syncope. So syncope mimics can be differentiated based on whether there is a loss of consciousness or there is no impairment in consciousness. Loss of consciousness can be due to metabolic disorders, intoxications, or transient ischemic attacks. Patient can malinger a syncope. There can be a pseudo syncope. So these are all syncope mimics. So we have to differentiate as true syncope from a syncope mimic. So that is very, very important. When you take a very good history, you can differentiate a syncope from a syncope mimic. So these are some of the causes which can cause a syncope mimic. So whenever there is a transient loss of consciousness, that can be due to a traumatic or a non-traumatic. When it comes to a non-traumatic transient loss of consciousness, it can be due to a seizures or an epileptic syncope, or it is psychogenic, or whatever causes which I told now. So we are not worried about other causes of transient loss of consciousness, and we are not worried about the neurological causes of transient loss of consciousness. We are worried about cardiogenic causes of syncope. So what is syncope? The syncope epidemiology is 6% of the hospital admissions are due to syncope. 3% of the emergency department visits are due to syncope. 12 to 40% of young adults present with a syncope. and 6% of the incidence increases greater than 75 years. Most of the elderly individuals will come with an intertrochanteric fracture. What we will do, we'll fix the fracture and send them, patient will again have a fall. So we have to find out what is the cause for the intertrochanteric fracture, whether it's associated, if there is a frequent fall, whether there is a syncope, and we have to analyze. So syncope has a bimodal distribution. Initially it is present in 20 to 40 years of age, and it increases with the age, and it is more present greater than 70 years of age. So this is the age of first faint. Age of first faint can be around 15 or 20 years, and age of first faint can be at 65 years. So what is the basic pathology behind the syncope? Syncope I already mentioned in that 5 points. It's due to a cerebral hypoperfusion. There is a transient low in the blood flow to the brain. So what is the cause for the transient blood flow loss? So it can be due to a low cardiac output or low peripheral resistance. These two are the basic mechanisms behind the syncope. So low peripheral resistance, low cardiac output, based on this they classify the syncope into 3 types. One is a reflex syncope, and other is an orthostatic postural hypotension, and next one is a cardiac causes of syncope. These 3 are only major causes of syncope. So when we say it is a reflex syncope, then it comes under vasovagal syncope, situational syncope, a carotid sinus hypersensitivity. These all falls under the reflex syncope. Then we have an orthostatic postural hypotension, and then we have a cardiac cause of syncope. So basic pathology being low cardiac output and a low peripheral resistance. So what happens normally when you are lying down and standing up? What will happen? There is a peripheral venous pooling. Whenever there is a peripheral venous pooling, what will happen? There will be there is a relatively low blood flow in the left ventricle. So what will happen? There will be an increased sympathetic outflow. So that will increase the heart rate and stroke volume, and the heart rate will increase and will compensate for that. This is what is the normal reflex mechanism. So whenever this reflex is inappropriate, whenever you are having you are standing from the sitting posture, you are having a peripheral venous blood flow, what happens? The heart detects, heart pumps against a very low cardiac output, and then what happens? The heart senses that senses some impulses to the brain, and the brain, instead of increasing the sympathetic, it decreases the sympathetic and increases the parasympathetic. It will cause hypotension and bradycardia, and patient will have a syncope. That is the basic mechanism behind the syncope. So there are a lot of theories which are put forward for defining this reflex syncope or neurocardiogenic syncope. These are basically an empty ventricle theory and a baroreflex dysfunction theory. So what happens? There is an excess venous pooling, there is a decrease in the ventricular volume. So whenever there is a decrease in the ventricular volume, the heart starts contracting faster. So there will be an increase in ventricular inotropy. So what happens? The cardiac mechanoreceptors are activated. It sends the impulses to the medulla. So whenever these cardiac mechanoreceptors are activated, they will cause a sympathetic inhibition and a parasympathetic activation that will ultimately lead to hypotension, bradycardia, and a syncope. This is the basic pathophysiologic mechanism behind a neurocardiogenic syncope. So as I said, the first classification is a reflex mediated syncope. That can be a vasovagal. Vasovagal is usually patient long-term standing, and when patient goes in for fear, patient sees the blood, when patient experiences severe pain, post-angiogram patients, these are all a vasovagal syncope. And situational syncope. Situational syncope, this patient will typically complain, whenever I cough, I develop a syncope. Whenever I micturate, I develop a syncope. Whenever I defecate, I develop a syncope. These are all classical examples of a situational syncope. Then we have a carotid sinus syndrome. This is nothing but there are some carotid receptors which are present inside the near the internal carotid artery. When these are excessively acting or excessively stimulated, when the patient suddenly turns his head, then these carotid receptors gets activated and patient can have a syncope. These 3 come under a reflex mediated syncope. Then there are syncopes which can occur due to orthostatic hypotension. This is very common. So whenever the patient is lying down, he feels better. Whenever patient stands, there is a significant drop of BP and patient developing a syncope. So orthostatic hypotension can be due, most commonly is due to drugs. Most of the drugs we are using can cause an orthostatic hypotension. Then there can be a autonomic dysfunction secondary to diabetes. Diabetes, peripheral neuropathy, and autonomic dysfunction can cause a syncope. diabetes, peripheral, then in case of amyloidosis or severe peripheral neuropathy secondary to alcoholism, kidney failure, these are all the secondary causes of autonomic dysfunction. There are also some of the causes of primary autonomic failure which can cause a syncope. The third cause we are more worried and we have to identify are the cardiac causes of syncope. So the cardiac cause is basically whenever there is a structural abnormality in the heart that can produce a syncope. Any disease can produce a syncope. Coronary artery disease, acute MI can present as a syncope, pulmonary embolism can present as a syncope, aortic dissection can present as a syncope, anything can present as a syncope. Typically for an LV outflow tract obstruction, for example, severe aortic stenosis or hypertrophic obstructive cardiomyopathy, RV outflow tract obstruction, anything can produce as a syncope. So first, you have to rule out the cardiac disease, whether that could get a structural heart disease or any arrhythmias, either it is a tachyarrhythmia or bradyarrhythmia, any arrhythmias can produce a syncope. So these things you have to keep in mind when evaluating a syncope. So whenever you're evaluating a patient of a syncope, you have to think of these three causes. One is a reflex cause, the second is a orthostatic hypotension, and third is the cardiac causes of syncope. So when you compare in the general population, the most common cause of syncope is reflex syncope. They contribute almost 45% of the syncope. The next being orthostatic hypotension. They contribute about 20 to 25%. In about 25 to 30%, we will not be able to find out the cause of the syncope. There are unexplained causes of syncope for 20 to 25%. Cardiac syncopes contributes only 5 to 20% of the individuals, and these patients we have to be very careful. So there are three lines here. Three lines. This red line is the cardiac cause of syncope. The syncope patients initially presenting with syncope are followed up to 10 to 15 years. What it has been found that the cardiac cause of syncope has associated with a higher mortality in follow up in 15 years. So survival with and without a syncope, 6-monthly mortality of greater than 10% in a cardiac syncope. So whenever patient comes with a syncope, it's our primary responsibility to rule out a cardiac cause of syncope. So how can we rule out these all? So syncope evaluation is not that easy as you think. If it's an myocardial infarction, you do an ECG and echo and enzymes. It's easy to identify, but syncope is a symptom, and it has a wide number of causes for syncope, and it's very difficult to identify the exact causes of syncope. So we have to make our effort to find out the probable cause of syncope. So every patient with a syncope, the first and foremost thing we have to do is a history taking. History taking will give you 30% the causes of syncope. So history is very, very important. History taking is very important. And then you have to check his BP. That is very, very important. Then you check his baseline ECG. And there are certain tests of autonomic function. You check whether the patient has an orthostatic hypotension, and check for his routine Holter or event loop recorder. These are all the investigations to find out the cause of syncope. So what is that is we should know which syncope is a good syncope and which syncope is a bad syncope. That means bad syncope means we have to evaluate up to the extent to come to the diagnosis. So if there is a red flag signal, has to be first monitored. So whenever the syncope event is associated with a lightheadedness, sweating, nausea, and a sudden unexplained after long standing in a crowded places, after a meal, triggered by cough or micturition, when the head rotation, these are all suggest that it could be probably a reflex syncope, and these fall under the low risk category. So any syncope is associated with exertion, syncope that is present while sitting or patient while lying down, these are all suggest that we are missing something. So new onset chest discomfort, breathlessness, abdominal pain or headache, and a sudden onset of palpitations followed by syncope, these are all suggest that the patient has some other cause for a syncope. So if there is a family history of sudden cardiac death at a young age, and the syncope will be very short, a syncope in sitting position, in these patients what we have to evaluate further. So you have to look at his past medical history. If any patient with a previous coronary artery disease or a cardiac disease comes with a syncope, then mostly the cause would be from the heart only. So previous history of any structural heart disease or coronary artery disease should be looked for. And when you are examining the patient, if the BP is less than 90, or if there is a persistent bradycardia, or if there is unexplained murmur, these are all red flag signs we have to evaluate further. So all patients of syncope should have an ECG. Most of the time the ECG is normal. So ECG yield of a diagnosis in a syncope is less than 1%. So whenever the ECG shows a signs of an acute ischemia or signs of second degree or third degree AV block, when there's a slow AF or persistent sinus bradycardia, or there is a bundle branch block, or there is a sustained and non-sustained VT, or there is you suspect a pacemaker dysfunction, or you suspect a Brugada syndrome or long QT, these are all high risk features in an ECG, and then you have to be alerted and you have to refer the patient for a cardiologist or an electrophysiologist. So this is the same thing in a different format. So whenever there is a history of structural heart disease, syncope during exertion, syncope while supine or sitting, syncope without prodrome, palpitations at the time of syncope, inadequate sinus bradycardia, SVT or paroxysmal AF, ECG suggestive of any other disorders like ARVC or Brugadas, you have to be very careful. So neurally mediated syncope, I told it is a absence of cardiac disease. Patient will have a repeated episodes of syncope, and usually associated with a patient in a crowded places, hot places, associated with nausea, vomiting, and when head rotation also patient will have a syncope. So this is orthostatic hypotension. The history will be patient after prolonged standing or standing after exertion, postprandial hypotension. These are all associated with the orthostatic hypotension. The main common causes in elderly with orthostatic hypotension is diabetes and Parkinsonism. So these are the basic investigations. We do an ECG, echo, treadmill, and if necessary, if there is any changes, you go for an angiogram. And you have the basic autonomic functions. You have a continuous ECG monitoring like Holter, then you can go for an implanter loop recorder and electrophysiological study. These are the investigation which are available for syncope evaluation. What are the basic autonomic tests? This test we can do in the bedside itself to find out which is the cause of a syncope. So I think you can ask the patient to stand. Doing a Valsalva maneuver or a deep breathing in a clinic is not a difficult procedure. Doing a carotid sinus massage is also easy. Doing an ambulatory BP monitoring is also easy. Doing a table testing is also easy when you have a hospital setup. So basically these things can be done in hospitals to find out the, at least by doing these autonomic functions, we can find out syncope causes in at least 50 to 60% of the individuals. So what is this active standing test? You make the patient lie down, check his BP, ask him to stand for 3 minutes, check his BP. So if there is a drop in systolic BP greater than 20 millimeter mercury, and if the drop in diastolic BP of greater than 10 millimeter mercury, then it suggests that patient has an orthostatic hypotension. So within 3 minutes. So, or if the systolic BP drops less than 90 millimeter mercury, then it suggests that the patient has a orthostatic hypotension. Whenever the patient has an orthostatic hypotension, you have to evaluate for orthostatic hypotension. What causes this orthostatic hypotension and how to treat that. So syncope treatment is not important. Syncope diagnosis is more important. So this is a Valsalva maneuver. So whenever what is Valsalva maneuver? You expire against a closed glottis. So what happens in a patient with a situational syncope? When you see here, this is a BP chart. So there is a drop in BP of greater than 30 to 50 millimeter of mercury while doing a Valsalva maneuver. So this is a basic autonomic function you can do. You can ask the patient to do a Valsalva maneuver and check his BP, and if it drops, then it may suggest the patient has a situational syncope. Carotid sinus massage. Where is the carotid sinus? So carotid sinus, what we have to do is you have to locate the carotid artery and you have to massage it for 5 to 10 seconds, and you have to monitor his ECG. So it's better to do in patients, in younger individuals. If an older individual, if a patient has a already previous history of cardiac disease or a stroke, it's better to avoid. Don't massage the two carotids at the same time. So whenever you are doing a carotid, if there is a 50 millimeter of mercury drop in systolic BP, or if the 3-second asystole, then it suggests that patient has a carotid sinus syndrome. That carotid sinus is overacting. You stimulate the carotid sinus, there is a 50 millimeter drop in BP and 3-second asystole. That means the patient has a carotid sinus syndrome, and this will give you the exact diagnosis of carotid sinus syndrome. So this is the same thing. You do a you have an asystole or a drop in BP of greater than 50 millimeter mercury. These responses are classified as two responses: vasodepressor. If there is only BP drop, that's a vasodepressor response, and if there is a heart rate also lows, then it becomes a cardio inhibitory response. Then we have a head up tilt test. Head up tilt test is nothing but you need a table with a foot plate. That's it. You make the patient lie down and you make the patient stand, and you measure the BP and the heart rate. You keep the patient lie down for 10 minutes. You have certain protocols by which you can do the head up tilt test. So these are certain protocols which are available, Italian protocol. So suppose if there is no syncope, you can stimulate the heart by giving NTG or isoprenaline. This can give more amount of syncope. These are all certain protocols which are available. So basically what do you check? You check whether there is a vasodepressor response or whether there is a cardio inhibitory response. Vasodepressor response means there should be a falls to less than 80 millimeter mercury or falls to more than 10% from the peak of the systole. What is the cardio inhibitory response means similar. There will be an asystole for lasting for 30 seconds, or the heart rate should fall less than 40 per minute. When the heart rate falls less than 40 per minute, or if you have a asystole for 3 seconds, that means that's a cardio inhibitory response. And if the BP drops less than 10% from the peak or less than 80 millimeter mercury, then it suggests that the patient has a reflex syncope. So there is something known as POTS. POTS is nothing but postural orthostatic systems. Then we can monitor the ECG. We can monitor the ECG by Holter, post event recorder, continuous loop recorder, or we have an insertal loop recorder also available. So this is an implantable loop recorder. In certain patients, the syncope comes once in a year or once in a 6 months. It's very difficult to find out the syncope cause in a Holter or an event monitoring. In these patients, you can implant this inside the chest and you can find out whether patient develops. So this can be kept for 3 to 4 years in the chest. So this will tell you whether what is the exact cause of the syncope. There were certain studies by this implantable loop recorder. What they have found that almost 46% of the patients exact cause by implantable loop recorder versus conventional therapy. So EP study. In case EP study is usually indicated if the patient has a greater diagnostic value, if the patient has a structural heart disease. If the patient has a heart disease, LV dysfunction with syncope, then EP can induce a VT and we can implant an ICD. So if the patient has it's a lesser diagnostic value into the patient without a structural heart disease, useful diagnostic observations are if you can induce a monomorphic VT, or if the sinus node recovery time is greater than 3000 millisecond, if there is an inducible SVT with hypotension, if the HV interval is greater than 100 millisecond, or pacing induced infrarenal block. These are all findings we can find out by a EP study. So there are certain limitations with an EP study. EP's findings should be consistent with the history. They are less effective in assessing bradyarrhythmia. So without structural heart disease, the positive findings will be present in only 15 to 17% of the individuals. So this is the diagnostic yield of the history and physical examination will give 25 to 30% of the patient's exact cause. Insertable loop recorder will give you almost 43 to 88%, while other tests, the Holter test, ECG, these are all only 2%. Tilt table can give you around 11 to 87%. EP study can, without structural heart disease, can give up to 11%. So I'm not going into the treatment aspect. Treatment is very easy. Whenever if it is a reflex tachycardia, reflex syncope, you treat that. When it is a orthostatic hypotension, you treat that. Whether it's structural heart disease, you find out finding the cause in syncope is very difficult. So to conclude, syncope is a common symptom. Cardiac causes of syncope are associated with higher mortality. So we have to find out the cardiac cause of syncope. Good history gives diagnosis in 35% of the patient. High risk and low risk stratification is a must based on the history, physical examination, and the ECG. Basic assessment of cardiac autonomic function should be done. Implantable loop recorders, electrophysiological studies should be considered in recurrent unexplained syncope. When indicated, pacemakers and ICDs should be considered. Thank you.
So there is a nice talk on evaluation of syncope by Dr. Calvin. So any questions from the audience?
We encourage enthusiastic participation. If any doubts, kindly clarify in this arena.
There is no question from the audience. We will move on to the next topic.
Next topic is medical and interventional treatment for TR, tricuspid regurgitation, by Dr. Shivakumar Ratnavel. I'm honored to introduce Dr. Shivakumar Ratnavel. He is interventional cardiologist at Meenakshi Mission Hospital and Research.
The next topic is medical and interventional treatment for tricuspid regurgitation by Dr. Shivakumar Ratnavel sir.
Respected Chair and friends, happy to be part of Calvin. Keep engaging us every year. This is third year, and I'm supposed to give the first talk. He quickly filled the gap. I think syncope, he gave an exhaustive talk and more important topic there than my talk. My talk is being a tricuspid regurgitation, which is quite rare, but I won't say it is it's not an uncommon disease. And as a medical student, tricuspid disease is the one the medical student picks up easily and can boldly present it as a pansystolic murmur, which is well heard, and Carvalho's sign, prominent venous cardigan, TR, all that. So we can't forget those medical student memories for this TR. With this preamble, let me move on. The topic given to me is basically what are the medical options available for tricuspid regurgitation. As an interventional cardiologist, the therapy is now widening as a structural intervention. We have a TAVI for aortic stenosis, we have transcatheter mitral valve replacement and a transcatheter edge-to-edge repair for mitral disease, and we have transcatheter pulmonary valve replacement too. So in that context, what is there available as a whole lot, and as an interventionalist, what is available for tricuspid regurgitation as a transcatheter approach. So it is not an uncommon, there is an increased mortality. Medical management in the form of the hope is only diuretics doesn't going to change the mortality. Whereas the other way, when you refer the case to a surgeon, quite advanced disease sometimes, because this disease particularly picked up late by the clinician, or there are comorbids which may not an ideal candidate for a surgeon to go and operate. But the real challenge in this disease is timing the intervention, whether it is surgeon or interventional cardiologist. Timing the intervention is the real key. There is no clear data on that. So if you look at this particular slide, sorry for the slide is slightly on the duller side. So before referring to a surgeon or to a cardiologist, interventional cardiologist, you have to try medical therapy with the diuretics and SGLT2 inhibitors, particularly when the preserved ejection fraction. When the ejection fraction is dropping, like in LVEF, when the EF is low, here also RNA MRA beta blocker can do wonders. Following diuretic challenge and these GDMTs, you can reassess the echo. If the TR is coming down, then you can leave him on conservative management. And patients with the TR where there is significant pulmonary hypertension, better to assess the pulmonary hypertension. If it is significant, right heart catheterization. If the pulmonary vascular resistance is more than 4 Wood units, on the cath table, give a vasodilator challenge, look for the vasodilator response, If you think it is chilly, which is something around a whole lot of TR, the pulmonary hypertension related TR, either it could be a pulmonary parenchymal disease or pulmonary vascular disease, which is somewhere around 20%. They don't do well, either with a surgeon or with the interventional cardiologist, they don't do well. But at least working with them, doing some vasodilator tests, we can increase the scope for therapies like ambrisentan, phosphodiesters inhibitors, or some of these can be milder form of pulmonary vascular parenchymal, but overt form of TR related issues. So they can even get improved with interventions, provided if you understand the pulmonary hypertension basic pathophysiology. And sometimes there is RV dysfunction. Before venturing into offering a therapy, we need to work on this RV dysfunction. The RV dysfunction can be easily picked up by echo, by the TAPSE score. If the TAPSE is very poor, they are not the right candidate to start with. We need to do something for the RV function to improve before intervene. Similarly, when they have a AF, try to convert the AF either pharmacologically or cardiovert, and after reversing into the sinus rhythm, again reassess the TR. If the TR is regressing, then wait. And if there is associated LV dysfunction, left-sided heart disease, try to fix the left-sided heart disease. And if there is device related, see now the longevity has increased, elderly people are getting more pacemakers, CRTs, ICDs, all these leads are going through the tricuspid valve. They can, 10% of the TR is now, they are called the CAED TR, cardiac implant electronic device related TR. Either we have to revise the lead or we have some other options which I will discuss later. Then a whole lot, 90% of the time it is a secondary TR. The secondary TR could be ventricular secondary TR or atrial secondary TR, 10% primary, another 10% is lead related TR. The primary TR is the one related to the primary valve apparatus, either the leaflet or the cardia or the muscle. Basically the LA size, RA size, everything will be normal. Even tricuspid annular will be normal, RV function will be normal, PA pressure will be normal. Pure valve related TR. Generally it's a good case for surgeon. Ventricular secondary TR is the one typical which see majority 50% of the time, where there is a LA size is more than RA size, RV is dilated, there is leaflet tethering, there may be an annular dilatation, PA pressure may be more than 50, LVEF may be on the lesser side. Atrial secondary TR, or you call it as ITR, isolated TR, this is a very unique TR, like atrial MR, there is atrial TR. Predominantly right atrial dilatation, tricuspid annular dilatation, RV function is normal, RV systolic pressure is normal, LVESB is normal. These are also again good candidates for either surgeon or for the catheter based interventions. As I said earlier, pacemaker related TRs, either we have to revise the lead or we have to do a heterotopic valve implant, which I am basically, this talk is sponsored by one particular industry. They have a unique options for this. It's called as caval valve implant. Instead of targeting the tricuspid valve as such, you are going to put some device in the, which I will discuss later. So this is very important. We all know the interventional clinical cardiologists give a good idea about the diastolic function, LV, EF, all those LVH. So they are more concentrating on the LA, LV. The most forgotten chamber is RV. It's a passive chamber, but it is not an unforgiving chamber. So a lot of ways we can assess the RV function. The simple way is TAPSE. TAPSE divided by RV systolic pressure. If it is less than 0.46, then it's a bad case. Similarly, RV stroke volume minus TR volume divided by RV end systolic volume. If it is less than 0.4, again it's a bad case. PAPI, pulmonary artery pulsatility index. It's a very good, easy to assess. RV systolic pressure minus PA diastolic pressure divided by RA pressure. If it is more than 4, it is a good case for intervention. And RV free wall longitudinal strain. It is again, every echo machine has a strain. You have to just put the strain in the lateral wall of the RV at the basal, mid and apical level. Get to know the RV strain and RV function. Then RV end diastolic area minus RV end systolic divided by RV end diastolic, the so-called RV fractional area change. Again, if it is less than 35, they don't do well. So any case of given TR, whether it is primary or secondary, because I said this disease to begin with in an advanced form, late recognized, RV dysfunction is part and parcel of the disease. There is RV PA uncoupling. RV is down, but still PA pressure is high. We don't know this RV after the intervention going to reverse. So how to know this? Until otherwise you do a dedicated assessment of this RV function by various means. At the end of the day, once I relieve the symptom, once I fix the issue, the RV has to come back. The tricuspid annulus should regress, RA should regress, RV should regress, TR should regress. Above all, the PA pressure should come down. If that doesn't happen, then you are offering a therapy whether by surgical means or catheter means will be a futile. That's why I'm just spending on that. There is a tricuspid regurgitation impact outcome score, very simple score based on age, baseline creatinine, NIHA class, associated lung disease, resting heart rate, severe TR. If it's on the higher side, then again the 10-year mortality when you allow them on natural history is very bad. This is another clinical score before referring to a surgical repair or replacement, whether they will do post replacement just by the clinical risk score we can predict. So cases on the lesser age, without lung disease, preserved ejection fraction, early NIHA class, not a redo, not an emergency surgery, they may do well. So this is what I was talking about, RVP uncoupling. Cases where there is a discordance, clinically very bad sick patient, but echo parameters are looking milder or moderate. Clinically, patient is very stable, looking very less symptomatic, but PA pressure is very high. So there is a discordance between clinical assessment of the TR and echocardiographic assessment. So how to fix this? Which is right? Your clinical judgment or your echo parameter? I think sometimes we have to push this table to the cath table. We have to do a right heart catheterization. Right heart catheterization very simple. RA pressure, RV pressure, PA pressure. You will get some idea. You can give vasodilator challenge as I said earlier. Following vasodilator challenge and oxygen, giving oxygen for 10 minutes. If the pressures are dropping, RA, PA, pulmonary capillary wedge pressure, everything is dropping, then it is a reversible PA. Similarly, baseline pressures are okay. Asking the patient on the cath table to elevate the leg for some time, 10 times. Now the pressures are going up. That means exercise related augmentation of those cases need some therapy. So to a nutshell, having diagnosed clinically, having assessed the RV function, having undergone some right heart catheterization, not in all cases, some selective cases when there is a discordance between the clinical assessment and echo assessment, these are all the options available. Transcatheter valve repairs, transcatheter edge-to-edge repair. This basically interventional cardiologists picked them from mitral regurgitation. They started doing this, nothing but Alferi repair. Alferi was a surgeon who used to do the leaflet anastomosis. Just he will suture the two leaflets, but he gave up, which interventional cardiologists saw that. They started doing transcatheter base, which worked very well on the mitral side. Why not the same thing in the tricuspid also? Now Abbott has a dedicated trick clip which can do wonders, but we need to figure out the right case. Another is transcatheter valve replacement. This is orthotopic, exactly where there is a problem. Tricuspid valve is in problem. Go and put a valve there, transcatheter one. There is a Edwards system called Evoque valve, and there is a transcatheter annuloplasty again by Edwards. It's a cardio band. Just put a sinus in the annulus. The annulus can shrink and TR can come down. There is another heterotopic, which is, I'm going to focus little bit on that because there is an Indian player in this, which is called as CAVI. Instead of targeting the tricuspid valve, we are shifting the tricuspid valve to a different place. We know that SVC and IVC are draining blood into the RA. If you keep two valves, one in the SVC and one in the IVC, now we are suppортaging the native tricuspid valve. We are shifting the tricuspid valve into two different places. Now that will filter the reduce the TR and symptoms may improve. It's called as CAVI, heterotopic transcatheter valve implant. So as I said earlier, it is not an uncommon disease. Get diagnosed little late. Comorbids are there. Surgery is of course a class 1 in young people with preserved ejection fraction. Associated left heart disease again is a good option. But when an elderly comorbid secondary TR where surgeon cannot offer much, definitely transcatheter, particularly mall co-opting leaflets, huge tricuspid annular dilatation where the interventionalist can do something. And these are all the various options. As I said, annuloplastic cardioband and tricuspid trick valve repair. There is another system by Pascal also, and valve replacements, as I said, trick valve. Tricuspid valve is a very unique valve among the all valves. This is the largest valve which has 3 leaflets, anterior, posterior and septal leaflet. It has chordae tendineae and papillary muscle. The weak point of tricuspid valve is septal leaflet. It has, even though it has 3 leaflets, only 2 papillary muscle. Septal leaflet is the one which is getting attached to the septum without papillary muscle directly to the septum. This make this valve by unique because of the septal leaflet without papillary muscle as a weak link. That is why infective endocarditis as a primary or a RV dilatation, annular dilatation, the septal leaflet immediately gives up. So you will be seeing every echo, there will be some amount of TR, even otherwise also. Little bit left-sided diseases, mild LA dilatation, mild LV drop, uncontrolled hypertension, you have a TR now. So tricuspid valve, the weak link of septal leaflet suddenly gives up, which starts as a mild TR as a response to left-sided disease, then it becomes a torrential, then subsequently becomes this TR begets the TR. So this is the only place where we not only qualify TR as mild, moderate and severe, there are other 2 terminologies, massive TR and torrential TR. These are all the ones, severe, massive and torrential, where definitely medical therapy is not going to work, and it is a more apically placed valve, more anteriorly placed valve. It's a unique, as I said, largest of all. We need to have some, this is the one place where this cavity that is already pacemaker lead in place, we cannot disturb that, or the tricuspid anomalous is so hugely dilated where even a tear is not possible, surgeon also cannot fix it, where just shifting the valve into the 2 cava can be a solution. The symptoms could be generalized anasarca, edema, ascites, congestive hepatomegaly, and well, when there is associated left-sided valve disease, AF and advanced Niga functional class, the prognosis is poor, and one should make sure you fix the left-sided problems, you improve the baseline heart failure, you make sure baseline LV function is not that bad. This already I talked about, types of TR. And there is a heart team decision making is always useful. As I said earlier, you bring in your surgical colleague also in discussion. Sometimes it could be a good case for a surgeon, isolated primary TR, leaflet pathology, post endocarditis. It could be a good case for him. Whereas advanced age, COPD, left-sided heart failure, but not in a severe form, mild EF drop, mild LA dilatation, but overt TR, which can be fixed by the interventionalist also. So I think heart team discussion involving your surgical colleague and finally right decision in a right patient will be the great approach rather than individual decisions. So patient selection will be symptomatic patient, EF should be more than 30%, life expectancy should be more than 1 year, and there should not be an untreated left-sided disease like severe AAS and all you should not take, severe MR and all you should not take. The left-sided disease should be under your control. It should be a simpler form of disease. There should not be a cirrhosis, there should not be an overt renal disease. And this is very important. In echo, V wave in IVC and SVC should be more than 50 mm Hg. TAPC should be more than 12. Not you cannot take a worst RV dysfunction. PA systolic pressure again should be less than 65 mm of mercury. So severe pulmonary embolism, very poor TAPC, and V wave in IVC, SVC less than 15. Because we are shifting the valve to in another place where we should have active response from that vena cava. We cannot take already plethoric IVCs and SVCs. So basically this works by avoiding the reflex from the caval system to further down and reduces the filling of the RV and reduces the TR, and thus how patients gets improved. This is how finally it looks like. One biological valve in the SVC, another in the IVC. And I will quickly take you through one. This is the basic system, nitinol frame, biological bovine pericardium, three leaflets sutured. One is the IVC frame, another is SVC frame. The SVC is the one which has a long skirt, IVC is the one which has a short skirt. And this is a dry tissue technology, so durability is excellent. This is basically the device port. Every case of TR, when you have decided for a CAVI, that is caval implant of this system, you should have a proper CT angiogram, and CT will now tell us assessment of the IVC size, SVC size, based on which you will be taking up these valves. This is an SVC valve available in different sizes, IVC valve is available in different sizes. The procedure is done in cath lab, under general anesthesia, under transesophageal echo. It's a transvenous approach in the groin, either the right groin or left groin, and it's a 20 French system. Finally, either you upfront proglide, venous proglide will close the access, or you can have a figure of 8 suture at the end of the procedure. I'm not going very detail of this. Very simple procedure. Any procedure on the right side of the heart should not cause much problem because you are not puncturing the septum. You have to just keep a wire in the SVC and take the valve and deploy one. This is, I will quickly take you through. And this one, first he is traying the access, then he is doing a venous proglide. I think for a general public, these are all not much. And interventional cardiologists know what is proglide. And basically, they have to keep a wire in the top of the SVC and keep a catheter in the right pulmonary artery. And this is the limit of the SVC valve to land. And the same catheter now bring it to the hepatic vein. This is the surface marking for the IVC valve. And subsequently, you deploy both the valves. This is an Indian experience. All the cases are typical cases where already patient had undergone some CAED. This is probably a CRTD device, multiple leads across the tricuspid valve. Patient ended up in TR, symptomatic, heart failure. Now the wire is in the SVC, another catheter in the right pulmonary artery, which is the catheter in the pigtail in the right pulmonary artery serving as a marker for the upper device, that is SVC device. The belly should stay above the pigtail, which is now in the PA, and the lower end of the valve, that is the proximal portion of the tric valve, is at the SVC-RA junction. Some part of the nitinol frame will be extending into the RA. That's not a problem. The belly is just above the pigtail catheter in the PA. That's the landmark of SVC-RA and SVC the upper part. Then the same pigtail catheter, you put it in the hepatic vein, which serves as a marker for now IVC valve, and then you deploy. Very simple procedure, very predictable result. You can have a fusion image. Fusion, if you have a Philips lab, you can have a fusion image. That is, you can bring in your CT and fluoro can be both merged. All will give an idea about all the structures. Then you can say work and deploy the valve. So to conclude, dear friends, TR is not an uncommon disease. Majority, 90% is secondary TR, primary is 10%, lead-related TRs are quite common. CAVI is the one which is definitely an option in a previously undergone pacemaker or ICD which has disturbed the tricuspid valve, where now you cannot offer much to the basic tricuspid valve. We are shifting the valve to the SVC and IVC. It is a nitinol frame biological valve made up of bovine pericardium. Very easy procedure, CT assessment, deploy the valve, one in the SVC, one in the IVC, and patient improving. Right case selection, judgment, RV function assessment, and CT planning will take you the day well. Thank you, one and all.
Thank you, Dr. Shivakumar. Any questions?
You have to discuss with the EP consult first. If you can revise the lead, after revision of the lead or dislodge the lead, reposition it, sometimes they are telling now, if you are putting the multiple lead, they are taking the help of now TE also. They are predicting the future TR. That is option A. But sometimes you don't want to, because they have offered these leads for a very CRTD
My
like that.
question is, if you put the trick valve and then if you want to do something about the lead, is it possible?
After the trick, yeah, no possible, no, because you are going to go through the valve again. You can work on. It is just it's a native tricuspid valve. We just shifted to the IVC and SVC. You can work on.
You can't take out the lead.
You cannot. You cannot. I don't know. But the primary idea of not to
If-
disturb
if-
the earlier lead.
Like if something happened to the pulse generator and you want to change it,
I think should be possible, because you are going to work through the valve and you are going to get into the RV. Ultimately, you have to enter into the RV. Nowhere it is going to prevent your entry into the RV, because the valve is just shifted heterotopically. I think that should not be a problem. I think that's a great question. Sometimes you may have to force to change the leads even after the cavity. His question is, after the cavity, is it possible? The answer is yes, it is possible.
Just I wanted to know what happens after these valves are put in IVC and SVC. What happens exactly to the original tricuspid valve?
Yeah, that's become dormant. That becomes dormant. Unlike left-sided valve interventions, right-sided interventions are very notorious to cause thrombosis. So they should be on lifetime anticoagulants. They need a very periodic follow-up. Valve thrombosis is quite common. Maybe you have to choose one antiplatelet and one Novak also, or VKA.
Thank you, sir. Next we call Dr. Shanmugasundaram. The topic is electrical storm.
Electrical storm, refractory VT. What do I do? By Dr. Shanmugasundaram, sir.
Good morning, everyone. At the outset, I would like to thank Dr. Calvin for discussing about electrical storm here. So we know the arrhythmias are more dangerous, and in fact, ventricular arrhythmias are even more dangerous than atrial arrhythmias. So when it occurs in quick succession, the patient will be at a very high risk of developing sudden cardiac death, and as rightly predicted by majority of the studies, when you have a frequent ventricular arrhythmias closely separated in a day, the risk of dying suddenly increases to almost 20-30% as compared to those patients who had occasional ventricular premature complexes. Yeah.
As a token of appreciation and gratitude for the valuable academic contribution, and I request our moderators to felicitate our speaker, Dr. Shivakumar Ratnavel, sir, with a memento, please. Thank you, sir. We shall now continue with the...
Thank you. So electrical storm, by definition, a patient should have at least 3 episodes of ventricular arrhythmia within 24 hours, which requires something to terminate the arrhythmia. On the other hand, there is yet another terminology called clustered ventricular arrhythmia, which the patient will have at least 2 episodes in 3 months, which is though not as dangerous, but definitely needs some sort of modifying the therapy. Majority of this patient will have underlying structural heart disease. It can be either ischemic or non-ischemic. And the most common arrhythmia is going to be a monomorphic ventricular tachycardia. The incidence depends on the at-risk population. When the patient had already an episode of VT and had an ICD in situ, the incidence of storm is going to be as high as 10 to 30%. On the other hand, if the patient doesn't have any episode of VT in the past and still device is there for primary prevention, the incidence is going to be 4 to 7%. Clustered VAs, two arrhythmias coupled within 3 months occurs in nearly 1/4 of the patients who are having an ICD. The presence of CRT device, which we know reduces the incidence of heart failure hospitalization, also reduces the incidence of arrhythmia. So that means that any patient with wide QRS and recurrent heart failure should be offered a CRTD device to reduce not only the incidence of heart failure, but also reduce the incidence of arrhythmic risk. The VT storm, or so-called electrical storm, increases the risk of sudden cardiac death by almost 3.5-fold. There are certain terminologies which we need to understand. The most important thing is what is a non-sustained VT and what is sustained VT. Sustained VT is anything lasting for more than 30 seconds or which requires an intervention to terminate. Non-sustained is anything less than 30 seconds or even couple of 2 or 3 beats occurring in quick succession lasting for less than 30 seconds. We call it as non-sustained VT. Monomorphic VT, the morphology of VT will be the same throughout the episode. On the other hand, polymorphic VT, the VT morphology will keep on changing like it happens with any hypokalemia or hypocalcemia related ventricular episodes. VF, will not be able to see any typical QRS morphology during the arrhythmic episodes. Pathophysiology, you need to have an underlying substrate. A substrate can be an ischemic or a non-ischemic cardiomyopathy with scar in the myocardium. The myocardium can be a simple subendocardial scar which can precipitate arrhythmia, but more commonly it is going to be a transmural scar involving all the 3 layers of the heart muscles, resulting in precipitation of ventricular arrhythmias. And there should be some external precipitating factors in the form of a fresh ischemia, which is going to be more common, or some sort of electrolyte imbalance like hypokalemia or hypocalcemia, or sometimes the drugs which can again provoke the QT prolongation, which will precipitate a polymorphic VTVF. And there should be some disruption of autonomic nervous system. Typically the sympathetic drive goes up and the vagal system comes down. So when there is a sympathetic overactivity in the presence of a vulnerable myocardium, superadded by a precipitating factor, the patient will land up in electrical storm. They can have monomorphic VT, which is the most common arrhythmia, which can be easily diagnosed by a single QRS morphology throughout the VT episode, or it can even be a primary VF, which typically happens in the presence of acute ischemia, or it can be a mixed VT-VF, which happens in a patient who had a pre-existing cardiomyopathy, or it can be a polymorphic VT, which typically happens in patients with a congenital arrhythmogenic myocardium or associated electrolyte imbalance. So this is a typical example of a monomorphic VT. You can see the ECG morphology remains the same throughout the arrhythmic episode. This is a typical example of a polymorphic VTVF where you can see a typical change in QRS morphology. Every single beat is different as compared to the previous beat, and VF is very easy to diagnose where you will not be able to see a typical QRS morphology at all. At-risk ECGs, you can predict the occurrence of electrical storm in at-risk patients based on their 12-lead ECG. Any patient with ischemic cardiomyopathy with wide QRS, we know the definition of wide QRS, anything more than 120 milliseconds is abnormal, with some irregularities, slurred QRS, notches, typically indicates that the patient has a scarred myocardium, which puts the patient at risk of developing VTVF. So ischemic cardiomyopathy, wide QRS with notches or slurring typically indicates that the patient has risk of a sudden cardiac death. On the other hand, a typically normal myocardium by echocardiography, a typically normal 12-lead ECG, but intermittently when you see this J point elevation or saddleback appearance in lead V1. This typically happens with middle-aged men. So we can diagnose Brugada syndrome based on this dynamic ECG patient. So this will not be consistent. It can be even intermittent. Whenever some episode happens, for example, fever or hyperthermia, they can have this type 1 pattern, which predispose them to develop ventricular arrhythmias. J-wave syndromes or long QT syndromes, where you can have a prolongation of the QT interval, corrected QT interval more than 440 milliseconds. We have almost like 8 to 10 types of long QT syndrome, but the most common type is type 1, type 2, type 3. It has a bimodal distribution. It occurs predominantly in young individuals, less than 15 years, where the girls are more at risk of developing VTBF than boys, and after 40 years. So anything in between this middle age group, they are at lesser risk of developing ventricular arrhythmias, but these extremes of age are at risk of developing VTBFs. J-wave syndrome, this was not recognized previously as a marker of sudden cardiac death, but of late, what you have noted that if you have an inferior lead J point elevation or a global J point elevation without ischemia, this will predispose the patient for developing idiopathic VTBF. So this is this famous epsilon waves which happens in arrhythmogenic right ventricular dysplasia. Otherwise, the left heart will be absolutely normal. There will be some dilatation of right ventricular outflow tract by your transthoracic echocardiography, but the ECG and cardiac MRI will give you the definitive diagnosis of this arrhythmogenic right ventricular dysplasia. This is often a very subtle finding which we should not miss. The patient will be having a very occasional ventricular premature complexes, but this VPC typically falls on the vulnerable phase of the myocardium. What is that vulnerable phase of the myocardium? So if the PVC is fall on the peak of the T wave, we can see the PVC typically falls on the nadir of the P wave. So if it falls on that vulnerable phase, this will precipitate into a ventricular fibrillation. This we call it as R-anti phenomena. So when this happens, definitely the patient will have a VTBF very soon. So be careful and treat the arrhythmia whenever you are seeing a short coupled PVCs which falls on the peak of T wave. So how to manage? Differentiate the rhythm into VT and VF. See whether the patient has a pulse or not. So if it is a pulseless VT, pulseless VF, the most important thing which you have to do is re-establish the rhythm by giving a synchronized DC version. In VT, you'll be able to give a synchronized DC version, but VF, since it is an undulating baseline, you have to go for a non-synchronous defibrillation modality. So once you revert the arrhythmia, probably you can go for subsequent corrective measures. But if you're not able to revert the arrhythmia by DC version, continue the CPR and give additional drugs like amiodarone, lignocaine, phenytoin, magnesium sulfate. These are the most commonly used drugs which can be quickly given at the bedside to revert the arrhythmia. So if the defib is not reverting it, give the drug, continue the CPR, again give the defibrillation, probably at a higher voltage to revert it. We know majority of the patients will end up in circulatory collapse. They'll have a hemodynamic compromise and they may need some mechanical circulatory support. It can be a simple IABP which can be quickly inserted at the bedside. Sometimes it can be even costly devices like Impella, ECMO or left ventricular assist devices. So acute management depends on the underlying predisposing factors. If the patient has an electrical storm with associated structural heart disease, which in our setting is typically an ischemic cardiomyopathy with a scarred myocardium, obviously the first drug is to give amiodarone and look for the hemodynamic compromise. If the patient is hemodynamically stable, probably you can continue amiodarone. If it is not working, we can top up with quinidine, but quinidine is not easily available everywhere. So what we often do is, if it is not working with amiodarone, we'll try to add lignocaine. We know the dose, it's going to be 1 milligram per kg bolus, followed by 1 milligram per minute infusion. Sometimes you can even give a top up of 0.5 milligram per kg bolus dose. And you can go up in the infusion rate from 1 milligram to 3 milligram per minute. So if it is not working, we often try to use this phenytoin. You know, it is a good anti-seizure medication, but it is also a good membrane stabilizing agent. It stabilizes the sodium channel of the myocardial cells, which is going to give an excellent arrhythmic protection. So majority of the arrhythmias which will not be reverted with amiodarone, which will not get reverted with our lignocaine, sometimes will get reverted with eptoin. Obviously, if it is continuing, then we have to go for catheter ablation, which I'll be discussing in the last part of the topic. In patients with primary electrical disease, which includes Brugada syndrome, long QT syndrome, short QT syndrome, or catecholaminergic polymorphic ventricular tachycardia. So amiodarone may not work because it is again going to prolong the QT, which will again precipitate polymorphic VTVF. Rather, what we do is we'll start the patient on isoprolol, which is probably a wonderful drug for patients with Brugada syndrome. None of the other drugs will work for Brugada syndrome except for isoprolol. Start the patient at 1 milligram per minute infusion, and then probably you can go up titrate and titrate it based on the heart rate. So once you increase the sinus rhythm rate, probably the incidence of arrhythmia will come down. So you can top up the patient with IV magnesium, potassium, and if there is an underlying precipitating cause like hyperkalemia or drug toxicity, try to treat that underlying reversible causes. In some patients with idiopathic VF, especially middle-aged female, where there is a short coupled PVCs precipitating polymorphic VF, verapamil also sometimes helps in reducing the incidence of VT stop. In patients with an ICD in situ, sometimes you can get inappropriate shocks because of supraventricular arrhythmias. The ICDs are meant to detect ventricular arrhythmia. The lead will be primarily positioned in the right ventricular apex. It rightly detects the ventricular arrhythmias in more than 90% of the patient. But in nearly 10% of the patient, sometimes the atrial arrhythmia with a fast ventricular rate will be miscalculated as a ventricular arrhythmia, and this will give repeated shocks. So this can be easily diagnosed by analyzing the intracardiac electrogram which the device will give. So go through the intracardiac electrogram, classify it as a supraventricular arrhythmia or a ventricular arrhythmia. If it is a supraventricular arrhythmia, it is a wise decision to switch on the device for time being and give amiodarone or other drugs which can treat the supraventricular arrhythmia, and then do a reprogramming. The device is like a mini computer. You can always do a reprogramming to make it detect the supraventricular arrhythmia appropriately and give only therapy for the ventricular arrhythmias. Sometimes in patients with monomorphic VT, especially if it happens at a rate of 140 to 150 rate, we can do what is called as overdrive pacing. So what we do is we'll put a temporary pacing catheter either from the neck or from the femoral vein and pace it at a higher rate. For example, if the VT rate is 110 or 120, pace at 130, that will terminate the arrhythmia. This happens in majority of the patients with scar-related ventricular arrhythmias. So most patients with ischemic cardiomyopathy will have a scar-related ventricular arrhythmia. And in this patient, if you are going to overdrive pace the ventricle at a rate slightly higher than the cycle and VT rate, for example, if the VT rate is 120, you have to pace at 130. If the VT rate is 130, you have to pace at 140. When you overdrive pace the ventricle, that overdrive pacing will suppress the arrhythmia. Another most important but often underutilized step is the stellate ganglion block. This can be easily done at the bedside. Probably our anesthetist will be able to help us, or even we can get the help of a radiologist to localize the site appropriately. We have to just localize a carotid tubercle and insert lignocaine just to check whether it is working or not. We just have to give adequate anesthetic medication in and around the stellate ganglion. So first we give lignocaine to see whether it is working or not. Suppose if the lignocaine is suppressing the arrhythmia, then we'll top up with the bupivacaine. You know bupivacaine is a long-acting drug. So it works for almost like 10 to 12 hours. So you can give repeated injections. If it is working, if it is suppressing the arrhythmia, then probably we can get the help of a cardiothoracic surgeon to give a sympathetic denervation procedure. This works in majority of the patients with the long QT syndrome, especially in kids where you don't have any other option. Probably you can ask for the help from the surgeon to do a sympathetic denervation. This can be easily done with even VATS where they have to just denervate the sympathetic ganglion, and it works brilliantly well for majority of the primary electrical disease where it's going to have, it will be a polymorphic VTVF. Then comes the role of catheter ablation. So catheter ablation has a strong say in the management of electrical shock. When a patient has an acute myocardial infarction, we go for a primary PCI to salvage the myocardium. Similarly, when the patient has an electrical storm with monomorphic VT or even a polymorphic VT degenerating into VF, when you modify the substrate, when you ablate the scar precipitating the arrhythmia, the patient will do well. So this can be considered as an equivalent of doing primary PCI for patients with acute myocardial infarction. Just give you some examples. A old inferior MI presented with a recurrent monomorphic VT. It was very incessant. He had almost 5-6 shocks within a span of 6 hours. So we had to take the patient for a primary VT ablation. So if it is a scar-related arrhythmia, the first thing what we do is we'll try to induce the arrhythmia in the EP lab. If he is hemodynamically stable, majority of the patient with a borderline LV function, any EF of more than 40%, they'll have some sort of a stable VT. So this will allow us to map the ventricle during arrhythmia to create a colorful picture like this. So what this color says, basically this color will say how the arrhythmia is propagating inside the ventricle and where exactly the arrhythmia is coming from. So once we know the exact site where the arrhythmia is coming from, we can just give simple burns over that site, and you can see the ECG down there. When we are ablating, the VT was getting terminated. So this is a wonderful therapy when the patient can tolerate the arrhythmia. We can easily map the ventricle quickly within a matter of 5-10 minutes to get the circuit, VT circuit, and if we know the exact site where to ablate, it will quickly terminate the arrhythmia. This will salvage the patient out of the VT stop. But some of the patient will not have a stable arrhythmia to map. So this particular patient had a old QRBB interval LV with a severe LV dysfunction. So with this poor LV, definitely he will not tolerate any VT induced in the cath lab, EP lab. So we tried inducing the VT, the patient was sinking, so we had to decivert and revert the patient back to sinus rhythm. But what we did was, we can do the voltage mapping of the ventricle. So what does that voltage map means? Basically, we try to map the ventricle to look for scar. When you get the scar distribution, this will give an indirect clue of site of arrhythmia origin. So then we will try to ablate around the site of scar to modify the myocardial substrate. So once you modify the substrate, we'll again try to induce the VT. So if the VT is non-inducible, that means that you have done some justice for the patient. Remember, in both these cases, though we have successfully ablated the arrhythmia, either during the ventricular tachycardia or by doing scar modification, but still we have to put an ICD, because whatever best we do for scar VT, still the patient will have some future arrhythmias which needs to be taken care of by the ICD. Some VTs can occur even after revascularization. The so-called revascularization induced ventricular arrhythmias may not be benign, but it sometimes may be incessant. So this particular patient had a scar, so though he had undergone the PCI for all the vessels, but he was throwing VT continuously in the ICU after the PCI. So we quickly get a cardiac MRI done during an interim period, where we got to know that the infralateral segment of the left ventricle was scarred. So we quickly mapped that segment. We got a focal point where the arrhythmia was coming from. We quickly ablated it, and that resulted in termination of the arrhythmia. So again, though this was a very focal point, but since the patient has a scarred myocardium, definitely ICD was warranted, and this patient was undergone the ICD. So far we have targeted the endocardial sites. So any scar in the myocardium because of ischemia produces either a subendocardial scar or transmural scar. When it is a subendocardial scar, we can go via the femoral artery, aorta, cross the aortic valve, enter into the left ventricle to map the ventricle. But in patients with a transmural scar, the VT can not only comes out of the endocardium, but it also can come out of the epicardium. This is even more true with patients with arrhythmogenic right ventricular dysplasia, where the right ventricle will be completely scarred, and you often have an epicardial exit of the VT. So when you have done some work on the endocardium, but still the VT is coming, then probably you may have to go for epicardial access. Getting into the epicardium without pericardial effusion, getting into the pericardium without pericardial effusion is not that easy. You have to be very, very methodical in getting into the pericardial space. So this patient had a dilated RV with no pericardial effusion. So we're just giving a small contrast injection through a spinal puncture needle. So this helps a lot. The lumbar puncture needle will help us in giving a small contrast with the coronary guide wire to get into the pericardial cavity. Once you puncture the pericardial cavity, then the job will be easy to map the epicardium to look for scar and do some scar modification and correct the scar, and then probably again these patients will need an ICD implantation. So to put it in a nutshell, electrical storm, though it is dangerous, it can be still manageable. So drugs are the first choice. If drugs are not working, we can go for a catheter ablation, which can give as good as results as doing a primary PCI for acute myocardial infarction. Thank you very much.
Thank you, Dr. Shanmugasundaram. One doubt I wanted to ask about this overdrive pacing. So after overdrive pacing, the arrhythmia is terminated. How long will you keep the pacing catheter? You will start some drugs and maintain it till then?
So usually the arrhythmia recurrence usually happens in the first 24 hours. And at that first 24 hours, the first 8 hours, in fact, there was a study which quoted that the recurrency of ventricular arrhythmias, the most common time duration is within 8 hours. So we tend to keep the catheter for at least for 24 hours, give some disease modifying treatment. For example, either you can load the patient with amiodarone or correct the electrolyte imbalance, or take the patient for a catheter ablation. If you don't have any other choice, just load the patient with the drugs, keep waiting for 24 hours, then probably you can take out the TPA catheter. Thanks.
In the absence of pacing, you start isoprenal therapy.
Yeah.
Slightly increase the heart rate. Many times get suppressed.
Yes, sir.
Whenever you need not go for overdrive pacing call. I have tried. I am not very, not bad in experience. This is just in your experience, the so-called stellate ganglion to block the sympathetic nervous system. Put him a ventilator.
Yeah, that should be the first thing, sir. That should be the first thing.
That is going to no. A good anesthetist will block the sympathetic nervous system. Nowadays, many modern anesthetics are there.
Yes.
So Lokanwala used to say that the ventilator will do two things. One, hypoxia, the relief. One is a good knock of the sympathetic nervous system. Adequate sedation is the word used by Lokanwala.
Yes, sir. The first thing to do when the patient has electrical storm is intubate the patient, paralyze the patient, knock him off completely, put him on ventilator. So that reduces the sympathetic rate to the maximum. So only if it is persisting, then only we will do all this stuff. So, but the foremost thing is to knock the patient completely off, put him on a ventilator and completely paralyze him, reduce the sympathetic rate. That should be the first step to do. I agree with you, sir.
Regarding this increase in the heart rate, without pacing isoprenal.
Yes, sir. Isoprenal, in fact, that is the most important drug in patients with primary electrical disturbance. But patients with a polymorphic VT, so this monomorphic scar-related VT, the rate you cannot achieve such a high rate with isoproterenol alone. When you give an isoprel injection, the rate will go up to probably 120, 130. But with the bolus, it can go up to 180. Again, it will come down to 110, 120. You cannot achieve a very high rate with isoprel infusion alone. The rate can be increased from 80 to 110 or 120, but a rate of 140, 150 consistently cannot be achieved.
Even with 10 increase in the beat itself can
sir.
change.
Yes, sir. That depends
That's
on
Oxford textbook medical emergency says like that.
Yes, sir. That depends
10,
on the,
10, even 10 beat increase.
Yes, sir. That depends on the underlying VT rates. Suppose if the VT rate is 140, then we need to have a heart rate of at least 150.
But overdrive, you can fix the rate. Suppose 140, you want to fix 160, you can fix at 160 by temporal replacement. That's the advantage. It's predictable, but with the drugs, it is unpredictable.
Thank you for a thought-provoking and engaging presentation that stimulated valuable discussion, sir. I now request the moderators to felicitate our speaker, Dr. Shanmugasundaram, sir, with a memento. Thank you, sir. I now request Dr. Calvin, sir, to felicitate the dedicated moderators. To Dr. Venkatesh, sir, thank you for chairing the session, sir. Dr. John Christopher, sir. Thank you for chairing the session, sir. William Osler once said, "Medicine is a science of uncertainty and an art of probability. Together, let's turn possibilities into certainties through knowledge." With that, let's move on to the next session on acute coronary syndromes. We have 3 lectures for this session. To chair this session, we have 2 eminent doctors. Let's welcome Dr. Jayashilan, sir, Managing Director and Senior Consultant Cardiologist at JK Hospitals, Nagarkoil. Sir has a career spanning years of unwavering commitment to patient care and clinical wisdom. We welcome you, sir. Nextly, we have Dr. Joseph Ranjit Jayashekaran, sir, Trustee and Senior Physician at Jayashekaran Medical Trust, Nagarkoil. Sir is also a Fellow of the College of Chest Physicians and with specialized training in critical care, and also Fellow of the Royal College of Physicians, London. It's a privilege to be having you with us today, sir. Welcome, sir. Over to the moderators. The first topic is acute myocardial infarction and cardiogenic shock. Dr. Madhavan, sir.
Very good morning. So first of all, I must congratulate Dr. Calvin and his team of doctors as staff for organizing such a wonderful CME program. So I'm sure it's going to be a real impact, create a real impact to all the people who are actually attending, and especially to the PGs and other people. And so today, we're going to have 3 important challenging topics going to discuss by experts in their own fields. And to briefly talk about the subjects, the topics, I request my co-chair to say a few words. And about Dr. Madhavan, well, everybody knows about him. He's a very eminent cardiologist and also and also a great speaker. He is from Madurai. And with these few words, I hand over the mic to Dr. Jayashilan.
You can proceed with the talk.
Thank you, chairpersons. Good morning to everybody. First of all, I would like to thank Dr. Calvin and his team for giving opportunity for the second time for this excellent clinical CME. And my topic is today on acute myocardial infarction and cardiac shock, my approach. So what is shock? Shock is basically a cellular dysfunction caused by perfusion, less hypoperfusion, induced imbalance between the delivery and requirements of oxygen that at the end cause cellular dysfunction. So that is the shock. So how do I approach shock in an acute MI setting? My approach would be rapid, protocol driven and focused in restoration of the perfusion. That is very important. Not only perfusion, you have to get the perfusion very quickly. And most important thing is you have to have MAP, that is mean arterial pressure, which is the most important factor. I should have highlighted that, sorry for that. So that is very important, very, very important. Whatever you do, the mean arterial pressure should be more than 65. So when it comes to less than 65, you need to worry. Suppose what is our normal mean arterial pressure for a normal person with 120/80 would be somewhere around 90/93. In tachycardias, maybe the calculation may vary here and there, but MAP you must remember when you are dealing with acute MI or any shock. So I target to maintain MAP of more than 65 millimeter of mercury. That is the most important thing. And systemic blood pressure 90, MAP 60, the signs of hypoperfusion. This is a worrisome issue. So what is the clinical examination? As the patient comes to you with the shock, the first examination of the patient. Examine the lungs, wet or dry. Examine the periphery, warm or cold. Based on this, you can have different combinations. So look for autosensorium, oliguria, and most importantly, you have to have your lactate level, index lactate level, and as you treat the patient, you have to keep monitoring the lactate level. That is very, very important. So as I said, you must look for wet lung or dry lung, and you should look for peripheries. So first, touch the feet, whether it's cold or clammy or warm. Auscultate, it's dry or wet. So these two things are very, very important when you are moving forward to treating the patient. If it's a simple patient with a normal MAP, you can go ahead and do primary angioplasty in acute setting and keeping some medications. So this is what I was talking. Cold, wet, warm, dry, all this combination. And on your lower right, cold and wet, there is one classification, that's a pulmonary edema, which has got a mortality of 51%. That's a typical acute MI cardiogenic shock. On the other hand, you have cold and dry. What would you see here? Cold and dry. On the bottom here, which is probably another cardiogenic shock, which has also got a high mortality rate because of the RV dysfunction and RV failure. So what are the parameters that you have to look for? The cardiac index. The cardiac index, you have a monitor that will tell you what is the cardiac index. The cardiac index is less than 2.2 liter per minute and meter square, you got to be worried. And pulmonary capillary wedge pressure more than 50 millimeter. That is also called left ventricular end diastolic pressure. If it is more than 15, then the patient is in trouble. So patient presented with symptoms, signs and typical features of MI and a shock. What next? Next thing is airway maintenance and oxygen. And you have to have the IV access, 2 large bore lines and arterial line. It has to be there. After the clinical examination, once you have seen the clinical examination, as I said, the peripheries and the lungs, and you have to have echocardiogram done. Many times you go and do the primary angioplasty, and after you do the echo, you will see something aortic stenosis or ventricular septal rupture, or you will see RV dysfunction and so many acute MR. So all these things would be missed, especially when you have a wet lung, you are likely to miss the murmurs and other things. So you have to have bedside echo. So I will repeat again, first clinical examination, after the clinical examination, you have to do the echo, and don't forget mean arterial pressure. That is going to direct your strategy, your trajectory. So how do you stabilize pharmacologically? Vasopressor is the first line, norepinephrine is the key. So why norepinephrine? Because norepinephrine, you may question me, norepinephrine is going to constrict the vessel, it's going to increase the afterload. So once you increase the afterload, the already failing heart will find it difficult to pump, isn't it? So why should you give norepinephrine? Can anyone of you answer that question? Because, as I said, norepinephrine is given to increase the MAP. When you have a mean arterial pressure of less than 60, you have to improve it. Without that, you cannot do anything. You have to save the heart and you have to prevent a death. So for that, even though it increases the afterload, which is not good for shock, you have to give norepinephrine because your MAP is less than 65. So you have to increase the MAP. So vasoconstriction is to maintain the MAP, and it also increases to some extent the LV contractility. Earlier days, we have been giving dopamine. It increases the heart rate. Because of the heart rate, the heart is finding it even more difficult to pump. So of late, dopamine has been discarded in most setup, and norepinephrine is at superiority. So norepinephrine should be the first choice. And another important drug is dobutamine. It's an inodilator. Again, you may question, already the BP is low, you are going to lower the blood pressure. Why dobutamine? Because dobutamine also improves the contractility and improves the cardiac output. It has a vasodilatoric action, but when you combine with norepinephrine and dobutamine, if you are able to get good mean arterial pressure, that's fine. Suppose if you are not able to get the mean arterial pressure, you can discard the dobutamine. You can only go with norepinephrine with the dose that I have given. When the patient is wet and cold, combination therapy, combining norepinephrine and dobutamine will be helpful to maintain the MAP. And if the MAP could not be maintained above 65, you may have to consider intra-aortic balloon pump. That would be the next step. Combination therapy improves stroke volume and reduces LV filling pressures and the LV unloading. The IABP is a wonderful device. Thanks to Dr. Vijay Shankar, the senior cardiac surgeon, he taught me to insert IABP 30 years before in 1995 at Madras Apollo Hospital when I was there. He only encouraged me because at those time there was no angioplasty, was just the beginning, it's just budding, and for emergencies nobody used to take primary PCI. I'm talking about 1995. So the IABP was used only for the bridging before the bypass surgery. So that is why I learned IABP at that time. The machine itself was so big, but he said, come on, buddy, come, Maddy, come, please do it, come on, do it, sir. So even after 30 years, I still feel that a lot of patients have been survived because of intra-aortic balloon pump. 10 years before, there was a trial came, shock trial, before Impella, which said IABP does not have mortality benefit. But I personally believe the IABP has got a very good role. Even I have some of patients who are living even after 10 years, 15 years, after very severe cardiogenic shock. So IABP is a wonderful device that's very easy. Anybody can insert it. So IABP combination with norepinephrine is a good thing. Initial days I used to question why you are giving IABP to reduce the afterload and you are giving norepinephrine to increase the afterload. This is very funny. You are giving acceleration as well as brake. So I did not like the idea. But later, when I started utilizing this combination, I felt okay, norepinephrine, even though it increases afterload, IABP reduces the afterload because IABP, when you keep the MAP mean arterial pressure more than 65, 70, and when you give IABP, it really gives rest for the heart and the coronary perfusion becomes better. Once the coronary perfusion becomes better, you can do primary angioplasty or even with maybe one total block and other 60-70% blockages in other two arteries, perfusion increases, contractility increases. As the contractility increases, so your job is better. So I like this combination very much. And dopamine, nowadays, I don't know, I don't use much, very rarely I use. So before all these things, you are giving the standard treatment. In acute MI, you are giving aspirin, clopidogrel, statin, all those things. I'm not going to touch on that, but you have to look at the blood gases analysis, look for acidosis, correct it, hypoxia, you treat electrolytes, anemia, all these things should be properly monitored. Then next, revascularization. So reverse is the most important critical step, life-saving measure and definite treatment. So life-saving measure is what? You open up the artery. Suppose you have a patient not really very sick, okay, it's in shock, but not still acidotic, and just open up the artery, he may improve very well. So after that, suppose you need some other assistance, then you have to think of all those things. So with just a simple angioplasty with an norepinephrine, all these things, if you don't have, you have some mechanical support devices. As I explained about IABP, it's a wonderful device which I have personal experience of 30 years that you should use. And you know, it's a big balloon from the whole 30-40 centimeters before the subclavian, below the subclavian to the renal artery, just above the renal artery. It's a big balloon. It during the diastole, it augments the diastole. When it augments the diastole, as I all know that coronary perfusion occurs during the diastole. So what happens is it gives rest to the heart, it augments the diastole. So 120, suppose the value goes like this, 90, 60, 140. This 140 is augmented diastole. So at 140 augmented diastole, definitely the coronary perfusion is going to be better. Especially when the patient is presented very early, he is going to have good outcome with the entire balloon pump. This is the balloon pump. You would see a white balloon. The whitish thing you see shrinking and relaxing, contracting and relaxing. Are you able to make out? This patient also got temporary pacing with him. So this is about IABP. And you have other modalities like Impella. This is also another device which unloads the LV. It gives rest to the LV. So it sucks the blood from the LV to the aorta and it gives the rest to the heart. But this very, very costly thing. It costs around 15 lakhs to 20 lakhs. 15 lakhs? More. So in acute setting, cardiogenic shock, if you are going to use 15 lakh procedure and you are likely to lose the patient, and not everybody can afford this. So this is another very important tool. It can be used. Suppose someone is staying near the corporate hospital, very well-to-do patient who can reach the hospital within few minutes, and if they can do the procedure within an hour or so, or the money is not a criteria, this is a wonderful thing. But remember, this IABP and Impella are not definitely going to help right ventricular dysfunction. It is not going to address the right ventricular dysfunction. That's a very important thing. Then we have got ECMO. You all know ECMO. It's very popular in these days. Politically also it became very popular. We have got ECMO VV and VA, ventricular arterial. What we normally suggest is ECMO VA. So ECMO VA is supposed to be good for the this cardiac dysfunction. This is a diagrammatic representation of VA ECMO and VV ECMO. So in cardiology, we use VA ECMO. In pulmonary diseases, we can use VV ECMO. So, what to summarize, the cardiogenic shock complicating MI, 80% is LV dysfunction. So, I have narrated what all should be done. Norepinephrine, keep the MAP above 65, if necessary IABP, if necessary Impella, if possible. If the patient is going to collapse or near collapse or very bad shape, you can initiate ECMO and do the primary angioplasty. Or the patient is collapsed, and if you can do ECMO, well and good. But IABP will not work if the mean arterial pressure is less than 40, it will not work. There is no role for IABP if the mean arterial pressure is less than 40. So ECMO, in that situation, ECMO comes into play. So that can be used. For RV dysfunction, you have to be very careful. You have to be very careful about the drugs. You have to give fluids. Diuretics should be avoided. And I said you must do echo, because if you do echo, you can do identify VSR, papillary muscle dysfunction, free wall rupture, all those things. This is the patient with infraval MI and RVMI. And the treatment of RV infarction is treat the volume replacement to increase the preload. IABP will not be helpful. Revascularization. Drugs to be avoided is nitrates, morphine, and diuretics. This is another one, post-val MI. Total cutoff LAD. After that, the MR improved. This is about the acute MR, where we need cardiac surgeon's help. Thank you.
Thank you very much for a elaborate discussion on cardiogenic shock and also support devices. It is very informative for all of us. Any questions?
How will you calculate the presence of hypertension? Mean arterial pressure. Normal person will calculate diastolic plus 1/3 of the pulse pressure. Previous history of hypertension.
No, 1/3 of pulse pressure. You have to calculate systolic pressure plus 2 into diastolic pressure divided by 3.
The presence of hypertension.
No, that's the mean arterial pressure. Hypertension or hypotension, whatever it may be, that's a mean arterial pressure. The thing, it varies from, suppose the heart rate is 70, 80, it's okay. When it goes to 140 heart rate, the mean arterial pressure, if you calculate, it may not be correct.
In your experience, the urine output and the mean arterial pressure correlations, how often good? The
I forgot to add that oliguria, you must look for
urine
oliguria.
Output and the mean arterial blood pressure correlation.
If the blood pressure improves, automatically the urine output start pouring in. I remember one patient, that was the first IABP in Madurai, I remember. There was a patient operated by Dr. Girinath. This incident happened 2000, in the year 2000, when we started the unit in Apollo, the very first unit in Apollo. One Mr. Palanisamy, he is a brother of my ex-colleague, the surgeon. He had a bypass surgery long before, many years before, 87 or so. In 2000 he came, he had 25% EF and maybe only one graft patent. And it's just few days after we started our unit, I was very hesitant to use IABP because that was angiogram was new at that time. Angiogram, leave alone angioplasty. Angiogram was new, and we used to do some rescue angioplasties because we were not getting primary angioplasties those days. So, with hesitantly I put IABP, immediately picked up the BP, as you said, urine output improved. I personally shifted the patient to Chennai, handed over to Dr. Girinath. And I used to do at least monthly three times IABP for the last 30 years. In between 5 years, I was not doing that many cases. Of course, cardiothoracic people do very often, but personally I do a lot of, I've done around 3 per month, you can say.
Just for IABP per se is class 3. I mean, really, it is not shown to be beneficial in cardiogenic shock. So is ECMO. The only MCS which has shown any benefit is Impella. But again, it has again got problems with vascular problems. So I don't think MCS should be the first way. Revascularization as early as possible. MCS you must consider, but understand that cardiogenic shock has a high mortality, whatever you do.
No, you were not there when I was presenting this thing. Yes. You were not there when you were presenting. You went outside. I have mentioned, it's not, I did not skip the revascularization. I said keep the map.
Yeah, I understand, but
very so
IABP per se.
No, even IABP, when I told you were not there, the shock trail really shocked me. The shock trail really shocked me because even today IABP helps. And not those patients with a map of 40 or 50, it's useless. But when you have a reasonably good map, if you are going to open up the coronaries, it really helps. See, what happens in industry, normally, there is a one drug or one device. If another drug or another device comes, they will try to suppress the existing device or drugs. That usually happens. If you look at, so I feel when they were pushing for Impella, naturally they have to suppress
No, I'm not pushing for Impella. No one should push for Impella.
Because it is a 50 years old device and it has a consistent effect.
Now, recently, I mean, it just came this week's JAC. It is a STEMI DTU. That's a unload versus angioplasty. Patient who came with STEMI going for cardiogenic shock, they first did a unloading with either any of the MCS or angioplasty, and they found there's no difference in the infarct size. So MCS has limited value in cardiogenic shock, but yes, when you're pushed to the limit, you have IABP, which is the easiest and probably the only one that we can use. But you should not be. You should understand the limitations.
No. My idea is to ensure for the primary care physician, other things, what to look for, what is most important, what should be the first line of treatment, and when do you consider IABP. So that's what my intention. I'm not pushing IABP, but IABP does wonders, definitely. And totally suppressing one particular device, because you get Impella. How many people can afford Impella even today? But I am sure even in Kanyakumari, IABP can be done. My idea is that not to propagate or give propaganda for IABP. It's a very useful technology. And what you use, and I am questioning myself. My people put norepinephrine and IABP, and say both are increasing the offload, and how does it going to help? But I later realized it really helps. I'm sharing just my experience so that people will get something out of my talk. That's my intention. That's all.
Thank you, Dr. Madhavan. So that was a wonderful talk and also like made a lot of things clear to us. So, ladies and gentlemen, we'll have a brief refreshment break and we'll have the next two topics after the break. Will that be okay, Doctor?
Thank you for the thought-provoking and enlightening speech, sir. I request the moderators to felicitate Dr. Madhavan, sir. Thank you, sir. With this auspicious beginning, we shall continue with the second scientific session shortly after a tea break. Everyone is requested to kindly join us for refreshments at the designated area. We shall resume in a period of 10 minutes. This is an intimation to the postgraduates who are participating in the quiz session. Kindly give your names in team of 2. We have an organizing committee member, Vibin, here. Kindly give us your names.
Government Rajaji Hospital. So the gold standard test is a body fat assessment, is a DEXA scan, and waist circumference and waist hip ratio, and the cutoff point based on the morbidities and mortality. So the body fat is the best way, but unfortunately we don't have much equipments to assess this body fat percentage. And Indian cutoff for obesity is 25 because of this more and more visceral fat is there in the Indian. So the cutoff definition is lesser as comparing with the Western population. So the any obesity of grade 3 or more than 35, it is known as a grade 3 obesity. Why it has to be concerns, the obesity? And so it is basically a complex mechanisms. It is not a easy to treat obesity because it has more pathophysiological things, and single drugs definitely it is not going to work, or single measures it is not going to measures, because it is a continuous spectrum, and it start in utero itself, because we have to focus the GDM, gestation diabetes, for the appropriate age, appropriate weight of the baby. So it starts from in utero and in childhood and adolescent, adult and adulthood. So it is a continuous spectrums, and we have to intervene at every stages so that the obesity can be prevented and it can be addressed. So as a result of obesity, there are lot of fat cells, and more and more the white adipose tissue, and these fat cells produce lot of inflammatory milieu in the particular environment. This inflammation is one of the forerunner for underlying insulin resistance, and the inflammation is leading to the inflammatory cytokines and insulin resistant cytokines, that leading to the various cardiological pathophysiological mechanisms, and ultimately the fatty liver. Again, the excess adipose tissue that is stored in the liver, it is causing the fatty liver and type 2 diabetes. And recently obstructive sleep apnea we are increasingly diagnosing because of the availability of the modalities, and clinically also by snoring and other simple bedside test you can diagnose, and osteoarthritis, and rarely it may be causing the esophagus and endometrial carcinoma and other things in the female subgroup, or PCOS. So it is a continuous spectrum. And why we should reduce the weight? So there are the weight reductions have lot of advantages in the day-to-day clinical practice, and you can see these slides that there is a 5 to 15%. So any 5% of weight loss, it is going to be significant. So the around 10 to 15% of the weight loss, we may expect that reductions in the lipid, particularly the triglycerides, and improvement in the HDL. LDL, there may not be much changes, and hypertension, again 10% reductions we can expect, and diabetes remissions. So if a morbidly obese individual, around 100 kg individual, reducing the weight by 5 to 10% of pre-diabetic range, it is going to be remissions for a point of time. So the diabetic remissions, again weight loss, it is an important measures, and osteoarthritis, sleep apnea, and non-alcoholic steatohepatitis, or MASH LD. So PCOS. So there are the lot of beneficial effect of weight loss or weight reductions, and it is again continuous spectrums, and we have to emphasize on every day-to-day clinical practice. So the first and foremost is definitely the nutrition therapy, medical nutrition therapy, and subsequently the physical activity. The last may be a psychological interventions, that is a eating behavior modifications. Again, it may produce around 3 to 5% of the weight loss, and in extreme stages there may be a bariatric surgeries, and there is a gap between lifestyle and bariatric surgery. That is the medicines that brings or bridge the gaps, and what are the medicines. And I will be focusing regarding the semaglutide, that is the incretins. So basically there are two incretins. These are the physiological hormones being there in everybody, human individual's life. So there are two hormones, GAP and GLP. So the GAP is a glucose dependent insulin-trophic polypeptide, previously known as gastric inhibitory peptide, and GLP-1, that is a glucagon-like peptide. So both are released in the intestines. So one is released from the K cells. So K cells is basically in the duodenum, and L cells predominantly in the small intestines of the ileum. So these are the mechanisms how the bariatric surgeries also improves the weight loss, produces weight loss. So there are a lot of gut hormones that has important role. In addition to the gut, it also has role in the brain. So there is a gut brain all crosstalks, and the liver also is coming into the picture in the in between way. So basically the incretins, it increases the insulin. So by increasing the insulin, it produces the it improves the insulin level, and it suppresses the glucagon. So it causes improvement in the glucose parameters, and simultaneously it delays the gastric emptying. So and so in addition, it has brain actions. Those GLP-1 receptors are there in the hypothalamus, ventromedial nucleus of the hypothalamus, and it improves the appetite. And so these are the main mechanisms how this GLP-1 agonist improves the weight. So the GLP-1 stimulates the POMC, and that is a pre-opium melanocortin, and it suppresses the hunger. and so there will be a knockout of hunger and there won't be any happy to eat. So there is a mechanisms, and another one is it's improve the satiety by neuropeptide YY and agouti related peptide. So by stimulate some of the things and inhibit some of the neuropeptides, that is how it is going to be beneficial effect. And the semaglutide is not a only GLP-1 receptor molecule. You can see there was the first one is exenatide. It was being launched in at similar to the sitagliptin phases around 2003-4, but since it is a twice daily and there was not much cardiovascular safety, it has been not become very popular. And subsequently the liraglutide came into the picture at around 2010. Now also it is being available. Again, it is a daily injections, and CV safety is relatively better as comparing with the exenatide. And subsequently the lixisenatide and exenatide long acting came into the picture, and 2017 was a major breakthrough. So there was the subcutaneous semaglutide launch. Even though 2017 it was banned in Western countries and UAE, the India it was came into the picture in the last year only. And so the any 10 years of any patented molecules, the patency has been over. Now the biosimilar version is being available in India, that is for the subcutaneous semaglutide. And subsequently the oral sema was launched in 2019, and it is also available in India almost now 3-4 years. So the journey of this semaglutide is starting from 2005, and this is all from GLP-1. So the tirzepatide is a GLP plus GIP, so that is the different molecule. And the pleiotropic benefits. So in addition to the weight loss, how this molecule is having beneficial effect, as already told that in brain it has the central nervous system, it suppresses the appetite, and liver by causing the preventive stages. Again, it is recently the lot of trials has been published in NEJM also, randomized controlled trial, and found to have this semaglutide is one of the molecule is going to be now recently FDA approved also. It is being used for the non-alcoholic fatty liver disease, and it has some amount of extension of albuminuria, so it is friendly to the kidney, and as already told that reductions in the BP and atherosclerotic plaque and the myocardium, and it causes reductions or shift of the fuel metabolisms. And so by all these mechanisms it has cardioprotective effect, and it is been one of the safety molecule, and it is being endorsed and recommended by almost ADA as well as the EASD and all other cardiological guidelines also. So this is the in vitro pictures, and you can see that it has anti-inflammatory effect, basically vascular endothelial smooth muscle functions, and it prevents the proliferation of the vascular smooth muscle, and in addition to the other parameters. So this effect has to be when you continue the drugs. So previously these drugs was being developed for the anti-obesity drugs, that was the initial era, and by the safety profile it has been like DPP-4 inhibitors, these extensions into the cardiovascular system also, but it has to be continued in a longer run, so that only you can expect the cardiovascular benefits, not for the weight reduction benefit that may be in a transient phase. So this is the recent obesity standard of care ADA 2026 guidelines. You can see that any persons you want more than 10% of the weight loss, then the two best drugs are the tirzepatide and semaglutide, and you can see that the level of evidence is A, that means that RCTs are available and it is strongly recommended. And the moderate weight loss 5 to 10%, currently we don't have in India, the phentermine topiramate, and modest all will be the liraglutide and other drugs came into these pictures. So by reducing the 10% of the weight loss, the steatosis phase and NAS and fibrosis also has going to be improved in case of the fatty liver disease. So you identify the current phenotype or correct phenotype, then you use these agents, and you have to adequate counseling and knowledge so that the patients may continue in a longer run. So the success of the GLP-1 molecule is going to be a longer run usage rather than the short term usage. And again, cardiovascular benefit, it has beneficial effect both preserved ejection fractions and both with reduced ejection fractions, And the mechanisms, again, it improves the myocardial fat and it reduces the atrial enlargement and remodeling also, and it has anti-inflammatory mechanisms. So it has 11 percentage reductions in the heart failure hospitalizations. Again, it is from the RCT. But as comparing with the SGLT2 inhibitors, the heart failure beneficial effect is going to be more with SGLT2 inhibitors, maybe around 30 to 40 percentage, whereas this GLP-1 receptor is beneficial for the atherosclerotic is more, and even it has also heart failure reduction. So heart failure, the best one is SGLT2 inhibitors, but the this also is having found to be more beneficial effect and almost 11 percentage reductions. And again, this is from the ADA weight loss medicines, and you can see that where to position this weight loss molecule in various beneficial mechanisms. And you can see that the center one is a atherosclerotic cardiovascular disease. The more benefit is with the semaglutide, and the other benefits is liraglutide and tirzepatide. So the level of evidences is more with the sema, and subsequently the lesser with lira as well as the tirzepatide, and other drugs exenatide and lixisenatide and these are all doesn't dulaglutide, these doesn't have much impact on the cardiovascular benefits. And similarly, the pre-diabetes reductions, type 2 diabetes management, hypertension management, MASH and OSA and osteoarthritis. So any severe osteoarthritis of 5 kg weight loss, it is going to be dramatic improvement for the pain relief. So it has definitely the pleiotropic benefits, and these are the various trials. I am not going into the detail. So there are all almost compared with all the drugs, and so the maximum dose you can expect up to 18 percentage, but it is not going to be happen in every people, but even 5 to 10 percentage of the weight loss, it is going to be a significant beneficial effect. So how to initiate or how to usage? So it has to be going slow, and because the side effect profiles may be there in each individual, so it's vary, but you can start with 0.25 milligram per week, and so you have to continue for 1 month, then second month only you have to go for the next dose 0.5 milligram, and subsequently third month you can go for 1 milligram per week, and fourth month you can go for 1.7 or 2.4. That was the classical Novo, the designing of the molecule, and the Indian companies now has come with 2 milligram pen also. So by reaching the dosage 1.7, it may take 4 months. By the time patient has to be adherent, and it should not discontinue medicines for the beneficial effect. So the weight loss benefit may happen only if you going to around 1 milligram per week. So by 1 month you may not expect any weight loss, and 2 months also, because these are all the tolerability dose. So patients may have initial nausea, vomiting, but usually 1 to 2 weeks it will settle. It is not a refractory or very severe nausea, vomiting these individuals. So by the time it may improve the nausea and vomiting. So the long term adherence is the key success of this molecule, and by 1.7 the tolerability is the individual concern. So we have to case basis. Our aim should not be the going to the maximum dose. Our aim should be the best tolerable doses for the longer run period. And this is the sustained, that is a semaglutide once weekly for type 2 diabetes management. It is compared with all the agents, so it can use it, but only thing you avoid or you stop DPP-4 inhibitor. So if patients is on already GLP-1 receptor agonist, there is not going to be additional benefits by giving this DPP-4 inhibitor. So you can always stop the DPP-4 while using the GLP-1 receptor agonist. And this is the comparisons. Again, it is compared with almost all the agents, and it is found to be beneficial. So this is again one landmark trial for the CVOT outcome, that is a cardiovascular outcome trials. It was published in 2016 NEJM, and you can see that the benefit effect you can see at most around 2 months, maybe 6 to 8 weeks we may expect this beneficial effect of the SEMA, and you can see that it has to continue in a longer run. So this is the 5 years data, and 5 years data of the semaglutide versus placebo. You can see that 26% of risk reductions in the primary composite outcomes, that was CV death and non-fatal MI or non-fatal stroke, and so it has been used in type 2 diabetic of populations. And this 2026 guideline also has been endorsed that for the atherosclerotic benefits, this is the best drugs even at par or ahead of SGLT2 inhibitor. So it has to be used in all atherosclerotic cardiovascular disease, CKD, MASH or weight management and glucose lowering. So this is the beneficial pleiotropic benefits is more rather than the glycemic benefit. Glycemic benefit you may expect around 1 to 1.5 percentage, whereas the pleiotropic benefits is going to be what. So again it has to be continued in a long run for the optimal benefit. So now the oral molecule also is available, and I am not going into the detail. And there are 3 doses for oral molecule. Oral molecule is a technology is different. So basically it's a peptide and it is being given in a pill. So it is a challenging technology, peptide in a pill, and so it has to be taken in the empty stomach for the better working of these conditions. It has to be daily instead of weekly once of injection. This oral molecule should be a daily. And again CV renal PVD septa has been keep coming, and it is being found to be more useful, and oral molecule should be taken in the empty. And 14 milligram of oral is equivalent to 1 milligram of injection of semaglutide. So you can switch over it to any form. So the last slide is the concerns. So what are the concerns about semaglutide? So the pancreatitis. So if patient is already on gallstone disease, better to treat gallstone first, then use the GLP-1, because nobody knows which causes pancreatitis, as diabetics per se is more prone as comparing with the non-diabetic population. So you treat gallstone disease. Similarly, the patients have triglycerides of more than 500, better not to use. You give concerns for reducing the triglycerides. And diabetic retinopathy, again there are a lot of issues has been discussed, but prospective studies is not there, and FDA also is closely watching. Currently, if it is a severe retinopathy is there, then all drugs that can reduces rapid glucose loss, the glycemic variability drugs, it is not to be used. That is the concern. Otherwise, this drug doesn't per se going to cause retinopathy. Similarly, non-arthritic ischemic optic neuropathy. So the hypoglycemia again initially may not be there. 3rd, 4th month it may cause hypoglycemia. So you have to reduce the insulin or sulfonylureas. And the other concern is muscle loss and fat loss. So whoever is going to lose more than 10% of the weight, we have to emphasize resistant strengthening of exercise and adequate protein intake, and GA adverse effect like gastroparesis and gallbladder disease I have already highlighted, and weight regain. So there are a lot of paper now coming up that if one stopped, it is going to increase the weight. So it has to be continued in a longer run, or we have to reduce the frequency of the injection. So the India has higher type 2 burden as well as the obesity burden, and we have more and more macrovascular complications as comparing with the Western counterpart, and it's both oral and injections, but safety profile has been more with injection as comparing with oral, and it has significantly reduced the major adverse cardiovascular events, and HbA1c reductions is around 1.7%, but the weight loss is quite significant, and so it has been now at affordable cost around 3 to 4,000 per month as per the biosimilars this thing, but as comparing with the Western populations, previous the original molecule. So it has the pleiotropic benefit. So we have to continue, and we have to choose the right patients, so that, and we need more time to discuss with them, so that the long-term adherence is going to be a success one. So with that I am concluding. Thanks for the kind attention and opportunities.
Thank you, Dr. Sridhar. That was a wonderful talk. You just covered almost every aspect of semaglutide and its benefits as well as disadvantages. If there are any questions and discussion from actually or from the floor, so here Dr. Sridhar will be able to take a couple of questions from the floor.
Phenotypes of obesity.
So
it will work out, or we have to select the patients accordingly.
So the thin lean phenotypes or thin lean type 2 diabetes phenotypes, there is not much studies has been done, but definitely we should not use FCPD prone individual, fibrocalculus pancreatic diabetes or pancreatic diabetes, or lean phenotypes of diabetic individual. So so metabolically unhealthy obese individual, like normal BMI with other body fat percentage, we have to do more data. But these all data has to be generated from India or China. So these are the predominantly a normal weight obese individual. So Western data is not there, and I don't know any data are India are generating or started doing the work, but it is a normal way how our normal weight phenotype individuals are behaving for this genotype. But definitely FCPD or LADA or thin lean phenotypes, we should not use this semaglutide.
And what time we will achieve them? Because it takes time.
Yes, sir. Almost all the 1.7 or 2.4, that is the dosage. We may expect the HbA1c reductions of 1.4, 1.5 around. So it may take around 3 to 6 months. We may not expect very immediately, because the dose reaching that level itself will take 3 months. So we may not expect within 3 months. So it take long time. Even hypoglycemia also will start later part of this thing only. Within a week or within a month it may not take.
In your experience, what is the tolerance, the vomiting, the
So the upper GI side effect is more with sema, lower GI like diarrhea, they are more with tirzepatide. And I don't prefer to use in metformin intolerant patients semaglutide and severe gastroparesis. So if they are not tolerating metformin, I don't tried actually. And remaining all initial 3-4 days, some patients they may have that symptoms, but usually the dropout is predominantly till now was a cast actually. Otherwise now recently only I have prescribed couple of cases of biosimilar version, and but I accept the cast, there is not much. But only thing, when my patients want to go fastly, I will little bit scar about 1.7 or 2.4, because it has to be a longer injection rather than the short term. So 1.7 itself they are tolerating well, it is very good enough. But I have not gone to the 2.4. I have stopped with 1.7. Patients is comfortable with it, because even patients themselves they feel the difference. I am feel better with that the dose. So not to go maximum dose for every individuals. That is my personal experience.
Dr. Sridhar, you talked about actually the retinal issues as well as
Yes,
the muscle loss and other things. There seems to be an apprehension about actually like presently progressive, even after stopping the drug, progressive sarcopenia and inability to recover from that. One, even with actually like calorie-based balance, compensate as positive, and with all the exercises. Then about the progression of dementia, so which has been especially subcortical demyelination and other things. What is your observation on that?
Actually, the second question is dementia. It has a beneficial drug, sir. There is some trials and evidences also is there. Dementia, semaglutide is very good drug actually. Some specific trial for dementia is there. Only concern is that retinopathy. So what concern is any patient's fluctuations in the glucose, particularly in pancreatic diabetes or any diabetes, we expect ups and down is more, that is going to cause more retinopathy and more harm. So if any we are slowly reducing any glucose level, it is not going to be a dangerous one. So the glycemic variability is dangerous for diabetic retinopathy. But again, people with all end organ damage, retinopathy, neuropathy, nephropathy, it is not going to work as a major, not a wonderful drug. So you have to choose the patients in the right, not at the very late stage, and it is not going to work. And only concern this non-arteritic ischemic optic neuropathy, but we need more and more prospective data rather than some case reports is keep coming. So now ophthalmologists also more look into this picture. So I think another 3-4 years we may get a clear data. Sarcopenia, again we I don't want to go to maximum dose, but appropriate dose, and definitely it will be more than 10% weight loss, will have muscle loss also, fat loss also, and definitely we have to emphasize about protein. But protein, again the concern is we may not take 1 gram per day protein also. So we have to animal proteins or vegetable proteins we have to emphasize, and currently resistant training only. Another one drug is been in the pipeline. It is not been come into the Indian market, but again we have to see in our populations rather than we take it from the Western populations.
Thank you, Dr. Sridhar.
Sir, my question is that we have the wonderful drug metformin, which is time tested and connected with the obesity and PCOS. Why to go for a costly drug like semaglutide? Is there?
So it's a similar, one size doesn't fit all. So metformin still we are using only. That is the first line and foremost drug. I am not going to recommend all for the semaglutide for all the diabetic populations, even childhood obesity or PCOS. It is a gold standard drugs. Only we need percentage of weight loss is more we expect. Then only we are going to have. So metformin may be around 2 to 3 kg weight loss we may expect. So I am speaking regarding the other pleiotropic benefits are the major weight loss, the percentage of weight loss when we expect more. So this is the, but we may not use it for all diabetic population, these drugs. It is practically also not possible. Yes.
Thank you.
Thank you, Dr. Sridhar, for your elaborate and interesting talk. Thank you very much.
Thank you, sir. I now request the moderators to felicitate the speaker for his elaborate discussion. Thank you, sir, for that insightful and informative presentation. We shall now move on to the next topic. Post-myocardial infarction, antiplatelet optimization and beta blocker therapy by Dr. Madhu Sridharan, sir.
Coronary imaging and physiology. Is a coronary imaging and physiology. Is a fellow of Royal College of Physicians, American College of Cardiology, European Society of Cardiology, SCAI, and his interests are in interventional cardiology majorly. And is an active member and with so many presentations in the national and international conferences and arenas. Now I welcome on behalf of all of us, Dr. Madhu Sridharan to give his talk.
Thank you, sir. Thanks to the chairpersons and Dr. Calvin for inviting me again for this beautiful meeting. And here we're talking about post-MI antiplatelet optimization beta blocker therapy. I mean, the context of the topic is extremely important because all of us managing patients in the ICU would be dealing with them. All patients treated for ACS should be discharged on DAP, beta blockers, ACE, ARB, statins, MRA or SGLT if there's LV dysfunction. This is the classical teaching. But times have changed in the management of ACS from watchful expectancy in the 80s to primary angioplasty with a door-to-balloon time of less than 90, which is what is recommended now. So have the evidence in the use of these drugs. So there's a 2025 ACC/AHA guidelines for ACS. And the layout of the talk would be antiplatelets. We're talking about aspirin, P2Y12 inhibitors, which and why, IV antiplatelets, long-term, whether what happens to patients with high bleeding risk, de-escalation, and in those requiring anticoagulation. So this is the platelet receptor and site of action. First is aspirin, which we all use, a thromboxane A2 inhibitor, which is the cornerstone in the treatment of antiplatelet, and it acts in the conversion of arachidonic acid to thromboxane A2, that's aspirin. And this is the P2Y12 inhibitor, and you got a whole lot of antiplatelets now, the newer P2Y12 inhibitors, starting with clopidogrel, prasugrel, ticagrelor and cangrelor, and finally it's glycoprotein 2B3 inhibitors, which is the final pathway. So aspirin and ACS, there's no confusion, it's class 1 level of evidence A. Thromboxane A2 inhibitors, it reduces vascular death after MI, reduces MI and stroke. In secondary prevention, 160 to 325 milligram is the loading dose, and 75 to 100 milligram is the daily maintenance. Higher dose is associated with increased bleeding with no added risk. And the dose has to be less than 100 milligram per day, especially if the patient is on ticagrelor. So aspirin, there's no confusion. Now comes the P2Y12 inhibitor. It inhibits ADP-dependent activation of platelets, and addition of P2Y12 reduces MACE, but it increases bleeding. So this is what we'll be looking at constantly. It's the bleeding versus ischemic risk. You got clopidogrel, prasugrel, ticagrelor, and cangrelor. Clopidogrel and prasugrel are prodrugs, which is metabolized by cytochrome P450. Ticagrelor is a direct-acting reversible P2Y12 inhibitor. It is CTPT, that's cyclopendyl triazolopyrimidine, and Canclor is direct acting IV with restoration of platelet function within 1 hour of drug discontinuation. So this is effective in the acute phase when the patient is being taken for angioplasty, or if you want to bridge. Now, clopidogrel has been shown in the CURE trial. It reduces death, MI, stroke in medically managed patients, and also in the pre-treatment, it reduced MACE in PCI arm. Then came Clarity, TIMI-28, and COMET, which is post-lysis, and this is the only one which has shown evidence in patients post-fibrinolytic. It reduces TVR, death, MI, and TVR, and there's no excess of bleeding as compared to placebo. So post-fibrinolytic, clopidogrel is a drug to be used. Now, what happened to prasugrel? In the Triton TB38 is the classical, the main trial of prasugrel. It reduced MACE by 19% at 15 months, reduction in MI, TVR, and stent thrombosis. But there was a 32% increase in non-CABG bleeding, which offsets many of the benefits. So, what is the overview? It's more potent than clopidogrel, lesser stent thrombosis, but increased bleeding. Not for less than 60 or more than 75, or with a patient with history of TIA or stroke. These are the contraindications for prasugrel. There's no difference in mortality. It reduces stent thrombosis, but there's no difference in mortality in the Triton TIMI-38. Not of use in medically managed patients in ECOS trial, and no benefit in pre-treatment of ACS, because in all these trials, prasugrel was given after the angiogram was done, after the anatomy was known. So pre-treatment in ACS, there's no benefit in the ECOS trial. Then came ticagrelor to the Plato trial. There's a 16% reduction in MACE at 12 months as compared to clopidogrel, more than 18,000 patients. There's reduction in death in MI and reduced stent thrombosis among patients undergoing angioplasty. And major bleeding was similar. Now, the meta-analysis, it's the only P2Y12 inhibitor associated with a reduction in all-cause death. But there's a 20 to 30% increase of major bleeding as compared to clopidogrel. Now, this is important because prasugrel, ticagrelor is the only one that reduces all-cause death. In the other one, you had reduction in stent thrombosis, but no reduction in mortality, while you have with ticagrelor. Now, what happens when you compare prasugrel versus ticagrelor? This is an ICER REACT 5, 4,000 patients. Prasugrel at the time of angioplasty versus pre-treatment with ticagrelor. There's a 26% reduction of MACE at 1 year without any increase in bleeding. Prasugrel had a more potent platelet inhibition and probably better compliance due to less discontinuation of the drug. So in ICER REACT 5, prasugrel was shown to be better than ticagrelor. Then had a network meta-analysis which showed there's no difference between prasugrel and ticagrelor. Of importance, only prasugrel reduced MI compared to clopidogrel, and only ticagrelor reduced mortality and CV death. Now, we have data from the Tuxedo 2, which is an Indian trial, which many of us are part of, that is comparing ticagrelor versus prasugrel in patients with diabetes and multivessel coronary artery disease. This is an important trial. It's more than 1,800 patients and 85% at triple vessel disease, 3-vessel disease. The primary endpoint was death, MI, or stroke, or major bleeding, and this happened in 16% on ticagrelor versus 14% on prasugrel. And there's a numerically higher, non-statistically significant composite of death, MI, or stroke, and major bleeding with ticagrelor. So in this trial, Tuxedo 2, patients with diabetes and multivessel disease undergoing angioplasty, ticagrelor was not non-inferior to prasugrel, which means prasugrel was better. So in the ICER REACT 5 and in the Tuxedo 2, you find that prasugrel had a probably minor edge over ticagrelor in the acute phase. But again, ticagrelor is the only one that reduced cardiovascular death and total mortality. Now comes to Canclor, which is a direct-acting P2Y12 inhibitor, a rapid and potent inhibition. You got 3 major trials of Canclor. The first 2, the Champion Platform and Champion PCI, were neutral, while in the Champion Phoenix, Canclor reduced death, MI, and TVR, and stent thrombosis versus clopidogrel in patients undergoing angioplasty. So the recommendation is class 2B for patients with ACS undergoing angioplasty, who have not received a P2Y12 inhibitor. Canclor can be given to reduce peri-procedural ischemic events. So it's class 2B, and it's only one trial which has shown the difference. Just a word about glycoprotein 2B3 inhibitors. It was with much fanfare that it was started, but we all know that it's increased bleeding and many of us have stopped using 2B3 inhibitors. You got a class 2A recommendation in patients who have a high thrombus burden, no flow or slow flow, and adjunctive use of 2B3 inhibitors can be given to improve procedural success. So it's just 2A, and a routine use of 2B3 inhibitors is class 3. It's harm. You should not be using it. So in ACS, if the patient is taken for angioplasty, whether it's STEMI or non-STEMI, it's aspirin with ticagrelor or prasugrel. If it's a CABT, it's aspirin again with ticagrelor or clopidogrel, the P2 vital inhibitor to be started once the patient is stable. If there's no planned invasive evaluation, which means medically managed patient with ACS, it is aspirin with ticagrelor. I think probably in Indian setting, it has to be aspirin with clopidogrel alone. Ticagrelor is much more expensive. You're not planning for intervention, it's because predominantly of finances, and in which case it's aspirin with clopidogrel. And if the patient has got fibrinolytic therapy and is not being planned for angioplasty, it's again going to be aspirin with clopidogrel. So this is what you would do in ICU in the patient in ACS setting. But we must understand the time course of bleeding versus ischemic risk. So these are the two basic things. Now, in a patient with ACS, the bleeding is the ischemic risks are very high in the first 3 months, after which it plateaus out, while the bleeding risk is high again in the first 3 months, but it remains high. So this is a thing that you have to remember. It is ischemic versus bleeding. The ischemic risk comes down after 3 months, while the bleeding remains as such. So if you're giving dual antiplatelet, we know that there's increased bleeding. So you got great antiplatelets, prasugrel, ticagrelor. So why not continue with DAPT? The problem is increased bleeding, and that can lead on to mortality. So it's always a balance between ischemic and bleeding risk. So how would it affect the DAPT strategy? You need potent antiplatelets in the initial phase, and this can vary from 1 to 3 months. Beyond this, the ischemic risk is low, while the bleeding risk remains the same. So if you can reduce the potency of antiplatelet after the initial phase, we can maximize the benefit of DAPT and reduce the risk. So this would be personalized care, and this is what we should be aiming to do, rather than just continue prasugrel, ticagrelor long term. So DAPT reduces thrombotic events, but excessive bleeding is there, and this may necessitate DAPT interruption, which can lead on to ischemic events. So the alternative strategies would be aspirin discontinuation with ticagrelor monotherapy, or de-escalation from prasugrel to clopidogrel, or just aspirin monotherapy, particularly in high bleeding risk patients. So this is what we have. This is a high bleeding risk. You can see it. Almost all the patients we're doing angioplasty would fall into one of those criteria. And these are the trials for reduction of DAPT. We had start from Stop DAPT to Smart Choice, Twilight, Global Leaders, Master DAPT, and TICO. Twilight and TICO are the more important trials where you had 3 months of DAPT followed by ticagrelor. Is aspirin to be discontinued after 1 to 4 weeks, and it's only oral anticoagulation after 1 year. So summing up, DAPT in post-PCI, prasugrel, or ticagrelor along with aspirin in hospital, especially for angioplasty, continue for 12 months if it's high ischemic and low bleeding risk. Remember, it's only for the patient with low bleeding risk. Strategies to reduce bleeding would be de-escalate to clopidogrel after 1 month, ticagrelor monotherapy after 3 months of DAPT, or single antiplatelets after 1 month in high bleeding risk, and stop aspirin after 1 to 4 weeks if the patient is on anticoagulation. So this much about DAPT. Now beta blockers. This is a game changer, because previously we thought that beta blockers should be on all patients with post-MI. It is the standard of care. Reduces MI, arrhythmia, and heart failure, and should be given early and continued long term. But these are recommendations based on older trials, from BART trial in 82 to Norwegian Timolol, ISS 1. But what was there in these older trials? The early trials were in the pre-reperfusion era, larger infarcts with LV dysfunction, higher sympathetic activation, and beta blockers reduce ventricular arrhythmia, sudden death, and reduce infarct size. What is the difference now? The current treatment is early reperfusion, dual antiplatelets, high statins, AC inhibitors with smaller infarct, preserved LV function, and low arrhythmic deaths. So what is the efficacy of beta blocker in this group of patients? Now, subset for beta blockers are definitely beneficial of patients with LV dysfunction. Anyone with LV dysfunction should be on beta blockers long term, period. There's no question about it. And that's based on Merit, HF, CBS2, Copernicus, US Cardiology, and Capricorn. And the only 3 beta blockers recommended are bisoprolol, metoprolol, succinate, and carvedilol. These are the only 3 beta blockers recommended for for LV dysfunction, and they should be continued long term. But what about MI with preserved LV function? That's a different thing altogether. Now, you got a number of trials coming up. The first one is the Reduce AMI, which came in 2024. Among patients with acute MI who underwent early angiography and had a preserved ejection fraction more than 50%, there was no benefit with beta blocker. Came a Reboot NIC, which came in August 2025. Again, patients are invasive care after MI with ejection fraction above 40. There was no benefit with beta blocker. In the same issue of NEJM came the other one with beta-amide DAN block, which showed that among patients with MI and an ejection fraction of at least 40%, beta blocker therapy led to a lower risk of MACE than no beta blocker therapy. So you got 2 trials showing no benefit with beta blocker and 1 showing there's a benefit. Why the difference? Now, Reduce AMI and Reboot showed no benefit, while beta-amide DAN block showed benefit. There's a recurrent MI was reduced in the beta-amide DAN block, and beta-amide enrolled patients with Minoca, that revascularization rate was lower in them, and beta blocker may confer some incremental benefit in patients with unrevascularized or non-obstructive CAD, where the effects on heart rate and blood pressure may target the underlying pathophysiology. This probably is the reason why there's a difference in the 2 trials. And again, this is shown in the guidelines. The ACCHA 2025 guidelines is class 1A, beta blockers to be continued long term, while the ESC 2023 guidelines, beta blockers are recommended in patients with ejection fraction less than 40, class 1A, but for all patients, if the ejection fraction is good, then it's 2A. So it's not 1 for all patients. Ejection fraction less, yes, you should be on beta blocker. Preserved ejection fraction, it has to be individualized. Now you've got a meta-analysis of all the recent beta blocker trials, including the individual patient data, and that's more than 17,000 patients. A Reboot, Reduce MI, beta-amide DAN block, and a capital RCT from Japan. 50% were on beta blocker versus no beta blocker, and the conclusion is that beta blocker did not reduce the incidence of death from any cause, MI or heart failure, with preserved ejection fraction when you have no other indication for beta blocker, that's either uncontrolled hypertension, AF, or heart failure. Among 1885 patients with the same trials with mildly reduced ejection fraction between 40 to 49, beta blocker was associated with reduction in the composite of death MI. So when the ejection fraction is less, beta blocker can be given, but ejection fraction more than 50%, there's no benefit for beta blocker. And this is the new paradigm for beta blocker post-MI. LV ejection fraction less than 40, it should be on either metoprolol, bisoprolol, or carvedilol. 40 to 49, you have some benefit, especially if you have associated hypertension, atrial fibrillation, or heart failure. More than 50, if you have none of these, beta blockers have no benefit. So in conclusion, routine use of beta blockers after MI should not be a uniform approach for all. Guided by ejection fraction and coexisting diseases, it's not a one-size-fits-all. Clinical judgment and personal care is a way forward. Thank you.
Thank you, Dr. Madhusreesan. That was a very impressive, nice, encouraging talk. About beta blockers also being pushed in. So interesting. Actually, there's one question which I have. It could be probably like falling into all the 3 papers which you put out from an EGM. So what if the patient has been actually on beta blocker and they develop one of this sudden onset cardiac failure with preserved ejection fraction? And also, like, it takes a while for them to recover from the crisis. What do we do in such situation? Do we withdraw the beta blocker fully or continue with that, or is there any other way out?
Now, if you're looking at heart failure with preserved ejection fraction, that's a different entity altogether, because you don't have any drugs which reduces mortality in heart failure with preserved ejection fraction. The only ones that you have is MRA, that's spironolactone, aldactone, or Finron now, or SGLT2 inhibitors. Now, if the beta blockers are given before, for whatever reason, if it is for hypertension, atrial fibrillation, whatever, it should be continued. But there should be some reason why the beta blocker was given before. If it depends on
during acute phase or a refractory situation where it's taking a while but still ejection fraction is well preserved.
Ejection fraction is well preserved. If it's heart failure with preserved ejection fraction, beta blockers have no role. In fact, it's probably contraindicated because in heart failure with preserved ejection fraction, heart rate is important. You have a higher heart rate, it helps the heart. So if it's predominantly heart failure with preserved ejection fraction, beta blockers are not to be given. But if the beta blockers are there for whatever reasons before, I think probably can continue.
Got it, doctor. Dr. Jason.
Wonderful talk on the beta blockers and antiplatelet drugs. I have one question regarding regarding ticagrelor. Is there any, what is the time interval between prasugrel, ticagrelor taking and surgery?
Surgery is prasugrel at 7 days, ticagrelor 3 to 5 days, clopidogrel 5 days. Ticagrelor is the shortest one because it's reversible, while the other two are irreversible. So for any surgery, I mean for CABG for example, if you want to stop the P2Y12 inhibitor, prasugrel 7 days, clopidogrel 5 days, ticagrelor 3 to 5 days.
3 to 5 days. 3 to 5 days.
The least of the lot.
Patient, because of the prevention of pregnancy-induced bleeding, already the patient is on aspirin, 75 milligram. For emergency obstetric indication, they have to do a cesarean section. There is a profuse bleeding, and the obstetrician has taken all steps to contract the uterus and other maneuvers, and that the bleeding continues. How often the aspirin is blamed, or there are other factors in bleeding in this situation?
It's most likely other factors. Aspirin 75 milligram does not cause that kind of bleeding because the patient can be taken for or even bypass surgery on dual antiplatelets along with aspirin and clopidogrel if it's an emergency.
150 milligram and 75 milligram.
There's no difference. It's only the difference of the GI bleeding. There's no difference in the antiplatelet inhibition because 75 milligram is enough.
You wish to say the bleeding is due to some other cause?
Some other cause. 75 will not cause that kind of bleeding.
What to do? What is any therapeutic guidelines in this situation?
So it's essentially a gynec problem. So 75 milligram is not cardiac protection because that age group does not have a cardiac issue. So it just you can do whatever, stop aspirin, give whatever drug you want.
So look for the other cause.
Yes.
And other methods to control the bleeding.
Yes.
Sir, I have one question, sir. Sir, following a PTCA, how long these dual antiplatelets, statins, and beta blockers has to be taken? That's the usual question patients are asking in our GP. For how long? Is 1 year, or we wish to say lifelong?
Dual antiplatelet is only for 1 year. After 1 year, it should be only single antiplatelets. Whether aspirin or clopidogrel, you got more evidence for clopidogrel. So after 1 year, the patient should be only on one antiplatelet, preferably clopidogrel. And statin is lifelong. Beta blocker, if the LV function, depends on the LV function. If the LV function is good, beta blockers need not be given. And even if you are giving beta blocker for whatever reason, if the ejection fraction is low, you have to continue. If the ejection fraction is good, after 2 years, there's no benefit of beta blockers either way.
Okay, sir. Thank you.
Thank you, Dr. Badusriharan. Wonderful talk. We'll conclude the session.
Thank you, sir, for an excellent presentation that added meaningful perspective to our approach toward cardiovascular care. I request our moderators and Dr. Calvin, sir, to felicitate the speaker. Dr. Madhu Shidran, sir. Thank you, sir. I request Dr. Calvin, sir, to felicitate our esteemed moderators, Dr. Jay Seelan, sir. Thank you, sir. Dr. Joseph Ranjit Jayashekaran, sir. With that, we shall proceed to the session 3. As Martin Fisher once said, observation, reason, human understanding, courage, these make the physician. We hope the upcoming scientific session stimulates curiosity, encourages discussion, inspires new perspectives, and reinforces existing knowledge and enrich our cultural decision making. To chair this session, we invite Dr. Anandi Bhaskaran ma'am, Senior Consultant, Jayaharan Memorial Hospital and Faculty of Medicine at Rajas Dental College. Looking forward to your meaningful perspectives and practical clinical insights with us today, ma'am. Welcome again, ma'am. The first speaker, Dr. Arunachalam sir, regarding the topic optimal medical therapy for heart failure with reduced ejection fraction. Over to the moderator, ma'am.
So thank you, Dr. Calvin and Dr. Binula and the team. So I invite Dr. Arunachalam Isakiepan and Senior Consultant and Interventional Cardiologist, Aruna Cardiac Care, Tirunelveli, and former Consultant Cardiologist at Apollo Hospitals, Secunderabad. And his DM thesis is risk factor analysis and angiographic profile in young myocardial infarction. So we invite you, sir, for the topic understanding the cardiac failure with reduced ejection fraction from mechanisms to modern treatments. So the stage is yours, sir.
Good morning, everybody. First of all, I thank Dr. Calvin and his team for inviting me for this conference, and I also thank the chairperson for introduction. So I'll be going through these slides. Heart failure with heart failure with reduced ejection fraction. So, see, if you look at this, the definition, heart failure, there is nothing that there is a diagnosis of heart failure. It's a syndrome. You should have a signs, symptoms, and you should have any NT-proBNP increased, or there should be evidence of congestion, systemic or pulmonary. And you can have stages, which I will discuss in future slides, and classification by ejection fraction. This everybody knows that. So look at this. This is a big for the whole, not only for the cardiologists, for the general practitioner physicians, it takes economy like anything. So you see the global prevalence is almost more than 55 million, and you look at a country like developing country like India, we have almost 22.7 million. So the heart failure, many of them, even not only the patient, even many treating physicians also think that once the patient gets stabilized, totally is asymptomatic, we can stop the drug. It's not like that. If you carefully see here, there is decompensation and again compensatory phase. If the patient is multiple times going for decompensation, it produces lot of morphological changes in the left ventricle, and the patient will ultimately end up with end-stage heart failure. So this is by the ejection fraction. If you have less than 40%, then it's called as systolic dysfunction. Between 41 to 49, it is called as mildly reduced ejection fraction, and more than 50% is called as normal preserved ejection fraction. So today we are going to see more about less than or equal to 40%. So if you look at that, this everybody knows that New York Heart Association. See, 1 is no limitation, and 2 is slight limitation, and 3 is a moderate limitation, and 4 is at rest or severe limitations. And this one I want to just stress that you just look at that stage A, because if you pick anybody who is a diabetic, who is hypertensive, or who has obesity,
See, he is in stage A heart failure. So you think this all who are obese or has hypertension, you're all in stage A heart failure. Why I mean is, the early you pick up and treat, better you can prevent the biggest catastrophe. And those who have family history, either genetic or dilated cardiomyopathy, hypertrophic cardiomyopathy. So this is called at risk, where there is no problem in the structural or function of the heart and no symptoms for the patient. But when you go to stage B, which is called pre-heart failure, you have all these things. Along with that, there is a structural change. Say there is a left ventricular hypertrophy or a diastolic dysfunction, raised filling pressure, or you do this NT-proBNP, that will be elevated. So this still patient is asymptomatic, but the patient has a structural change. When you go to see, this is the stage everybody diagnoses, even the patient diagnoses himself, and most of us diagnoses. By that the patient is totally dyspneic, tachypneic, pedal edema, all the loss of appetite, full symptoms. And stage D is what the very, very worst stage, which the patient goes for recurrent hospitalizations. So stage A is at risk, no symptoms, no structural change, no biomarkers. Stage B is the patient has some problems, structural functions, ventricular hypertrophy, left atrial enlargement, wall motion, valvular heart disease, or there is filling pressures. Say there will be a grade 1 diastolic dysfunction, or the patients will have NT-proBNP elevation and all. Stage C is very clear, symptomatic, and stage D is the advanced one. And what is the correlation? I said stage A, no symptoms. Stage B, class 1, but also asymptomatic. Most of the stage C patients will be on class 2 or 3 symptoms, sometimes 4, but stage D patients predominantly on stage 4, that is dyspneic at rest, pedal edema, could not move. If he goes for a toilet and come back, he will be very much dyspneic. All these things happens. And you know that ischemic cause, yes, ischemic means the coronary artery disease got some issues, whether it is a chronic coronary, acute coronary, hibernating myocardium, whatever things, prior infarction. And there is a list for non-ischemic. Most of the time it is idiopathic. That's what my professor used to tell, that, Professor VG. Idiopathic means the treating doctor is idiot and the patient is pathetic. That means idiot means he doesn't know the cause, that's it. So the most of the time it's idiopathic. And you have the other things, that is all these myocarditis, drugs, tachycardia, valvular hypertension, all these things comes in non-ischemic cardiopathy. The pathophysiology is, as I said, that first there will be damage to the myocytes, extracellular matrix. There will be alteration in size and shape. The next only there will be a neurohormonal activation, that is sympathetic system, and ROS, renin-angiotensin activation, which will lead to vasoconstriction, fibrosis, hypertrophy, all these things, which ultimately results in a hemodynamic alterations, producing dyspnea, pedal edema, and all these things. And you know that the heart is not, it's almost like a cylindrical organ, so it can pump, and when it contracts, takes the blood into aorta. But what happens with maladaptive remodeling and worsening is the heart becomes globular, turning from cylindrical to globular. So when it contracts, when a globe is contracting, it will be swirling the blood inside. It will not be pumped into the aorta, and that's called the reduced ejection fraction, what you say that. So this is sympathetic nervous system. Everybody knows that epinephrine is, that's why the role of beta blockers, you have vasoconstriction, all these things, and you do a renin-angiotensin aldosterone that produces again angiotensin 2 vasoconstriction and releases aldosterone, which produces fibrosis and all the structural changes. And this is the third, which is now picking up for the few years, that is natriuretic peptide system. This is after the role of sacubitril valsartan. This is more talked among the physicians, because this does exactly opposite to renin-angiotensin system. See, when renin produces vasoconstriction, natriuretic peptide produces vasodilatation. That increases PP, this decreases PP. That reduces, increases aldosterone, this reduces. So it's just opposite. So imagine that is to prevent the deterioration, renin-angiotensin, say valsartan, this is to enhance the cardiac activity. That is the sacubitril. That's a wonderful drug. And you see this is a very, again same, the renin, aldosterone coming back. AC inhibitors initially used, then ARBs which block selectively the angiotensin 2 receptors. And you have this spironolactone, eplerenone, as said by Dr. Madhusridhan, which blocks directly the aldosterone blockade. Spironolactone is non-specific, and you see there the beta blockers which blocks the sympathetic system. And this is just, you see, renin-angiotensin, you have AC, ARB, ARNI. For sympathetic, you have beta blockers. For natriuretic peptides, you have sacubitril, and for SGLT inhibitors. And for vasodilation, if the patient in CKD, somebody will ask that, the patient has urea 58, creatine 2.4, I am not able to start MRAs, aldolactone, spironolactone, I am not able to start sacubitril, ARB, what I should do? You should remember, here is the role of ISDN with isosorbide dinitrate with hydralazine. And elevated heart rate, you have beta blockers, if not control ivabradine, if severe COPD, you can go. This is other important area, guanyl cyclase, soluble guanyl cyclase. This is called vericiguat. The latest drug has come, probably trying to take the fifth pillar. This produces lot of beneficial effects. And you know that when the patient goes for advanced stages with LV dysfunction with QRS widening, there is a role for device therapy, CRT, cardiac resynchronization, ICD, and all these things. You know the symptoms, classical, dyspnea, orthopnea, paroxysmal nocturnal, right heart failure, liver congestion, pedal edema, and you have third S3 odd sound, and you have these basal crepes, fine crepes. And this is what you just, how to find out ischemic, non-ischemic. You do all the clinical evaluation, basic lab, ECG, echo, then you are again confused. Then the best is to do coronary angiogram. If there is no flow limiting, it goes to non-ischemic. If there is flow limiting more than 70%, it's called ischemic cardiomyopathy. Apart from this, I want to stress, look at the cardiac MRI. I will discuss in the next slide. The cardiac MRI can say that if your patient is CKD, not willing for coronary artery angiogram or CT angiogram, you can suggest a patient to cardiac MRI, and you can differentiate whether the patient is ischemic or non-ischemic. And then you go for other things in advanced state. So this is what you do, the first clinical clue, whether ischemic, non-ischemic by ECG, echo, and all these things. These are all gross. Q waves, ischemic, LBB, not always. Regional wall motion, ischemic, global, non-ischemic, not always, most of the time. Then do coronary angiography, if the thing permits, then it is easy, more than 70% obstructive, and less than 40-50% it goes to the non-obstructive. Look at this step 4, I want to stress that. If suppose your patient is renal failure, you cannot do CA, coronary angiography. Look at this. If there is subendocardial or transmural late gadolinium enhancement, it's ischemic. If it is a mid-wall patchy or epicardial late gadolinium enhancement, it is non-ischemic. So if there is no LGE, think about a reversible cause. It's neither ischemic nor non-ischemic. And you do all these things when you don't find beyond that this copper toxin, TSH, thyrotoxicosis, and all these things. See, this is with NT, this is for the European guys. This is not for us, but still I want to stress that. See, what they are telling is, if there is failure is suspected, do NT-proBNP. If NT-proBNP more than 2000, refer for urgent echo in 2 weeks. If it's between 400 to 2000, do in 8 weeks. You can get morning, afternoon, evening, same patient echo with cardiologists in India. So this doesn't serve much purpose. It's for them. So just think that the care what we give in India is far, far better than Western countries. Maybe little has to be channelized. This is a wonderful slide, I love that. How a high sensitive troponin I can guide a heart failure. This is fantastic, very simple. You do at the baseline, you do 6 hours, you do 24 hours, 3 troponin I. And for the high risk patients, which is hospitals, if you feel that cost factor, you do at least admission and 24 hours. What is type 1 troponin elevation is, you have the troponin elevated. So it will be increased, then the peak will be reduced. The patient has high risk, that means increased mortality. And for the type 2, it will be persistently elevated, it is more dangerous. Type 3, it will be same. For example, say troponin is 8 and then it is 10, like that. So the patient is chronic heart failure, need not worry. And if that is falling, you say that is increased and then falling, the patient is recovering. And type 5 is the troponin is normal. So this is the trends, and this is what depending on the management. So very simple, you do at 0 hour, 6 hour and do at 24 hours. The dynamic change matters more than absolute. If you are confused that troponin is elevated due to heart failure and not due to acute MI or ACS, then this trend will help to differentiate that also. So this is the other, you must know that other cause for troponin elevation. It can occur in acute heart failure, arrhythmias. Many times we have seen patient present with AF, all comorbids, trop elevated. You do angiogram, nothing will be there. So the atrial fibrillation can produce, and you know, Takotsubo cardiomyopathy, and for physicians it's CKD, pulmonary embolism and sepsis, all these things produces. So this is, if there is acute rise, markedly elevated on admission, high risk, persistent elevation, very high risk, falling trend, the prognosis is good, it is constant, you need not worry, this is a chronic heart failure. So these are all the few things, you just catch hold of these things, this course which you can do online, and you can put your senior staff or the medical officers taking care of ICU to put that, and you can do a risk assessment. This is get with the guidelines heart failure score. This will be like this, you can put all the data, you can assess, and this is a magic risk score which can predict a 1 year, 3 year mortality. See, at least we can, if we want to talk the patient is bad and all, it should be some evidence base, and this is a cetal heart failure model, and this will be like this, and this all you can do that. And for those who are telling that no experience based, it's evidence based era, this is the heart failure trial which says that. For AC, these are all the trials, consensus, solve, and for merit heart failure, Copernicus beta blockers, and RALS for spironolactone, emphasis for eplerenone. And for ORNI, this is what I want to tell, that this latest drug, wonderful drug, not latest drug, it's there for quite few years. Paradigm heart failure and shift for ivabradine and SGLT. This is very, very important, because even DAPA for DAPA heart failure and an emperor reduced for heart failure with reduced ejection fraction. So you see that when one drug, two drugs, the benefit, if the ratio, more drugs are involved, you see the last 4 drugs involved, the mortality is very much reduced. And I will just discuss the 4 pillars. First is ACC, ARB. You know that ACC acts on the enzyme, prevents conversion 1 to 2. ARB acts on AT1 receptors, right? And this ORNI is a drug which I said that it will block the valsartan, the receptor ARB, and the neprilysin is the enzyme which degrades peptides. So this sacubitril inhibits the neprilysin, so the peptides are not disintegrated. So the BNP peptide produces all these beneficial effects, which is just opposite to the angiotensin 2. So this is an enhancer that prevents deterioration. So what the trial for AC inhibitor is consensus for enalapril, and solve for enalapril, and paradigm for sacubitril valsartan. So previously they used to say start with enalapril or ramipril. If patient coughs, switch over to valsartan, telmisartan, candesartan. Then if the patient deteriorates, switch over to sacubitril valsartan. It's not like that. Now you can straightforward start sacubitril valsartan. The patient affordability is not an issue, because that's the latest preference. Beta blockers, as well discussed by sir previously, this is what? It reduces the heart rate, thereby myocardial oxygen supply, and brings down the contractility, and demand is reduced and increases ischemia. So it's a pillar. So it's the second pillar, supported by the only three drugs should be preferred: carvedilol, metoprolol succinate, not tartrate, metoprolol succinate, and you can use bisoprolol. These are the 3 proven drugs. and supported by Copernicus for carvedilol, US based, Merit heart failure, metoprolol, and CBIS is mainly done with bisoprolol. So they reduces sympathetic overactivity, improves remodeling and enhances survival. So this is the third pillar. This is spironolactone with eplerenone. So in short, it prevents RAS, that is the reactive oxygen species, and brings down the inflammation, thereby fibrosis, structural alterations in the heart. So this is one of the very important drugs. Previously, it is started late when the patient develops symptoms or congestion. Now it's not like that. It should be started earlier to prevent remodeling. And another, it's a direct aldosterone blocker, so it is quite useful. So because you know that aldosterone levels are increased in heart failure. So RAL study supports spironolactone and emphasis supports eplerenone. So only thing, look at potassium and urea creatine, be careful. Patient do gets hospitalized when the creatine goes more than 5.5, especially elderly more than 75 years. And last, this is one of the drug which should be used left and right, like statins. This is drug for heart failure. You have to put any patient on heart failure, SGLT inhibitors, it does all the wonders what you see in the slides, and a lot of robust data supporting from DAPA heart failure trial and also for Emperor reduced trial. And only again you have to look at this is the patient should, whether even non-diabetic patients you can start, and that is what the study supports. So other agents, diuretics, yes, you can use furosemide, torsemide, but no mortality benefit. If the patient is congested, use. If the patient decongested, stop. You can talk to the patient, ask him to buy a weighing machine, have a dry weight. If your weight is going to increase by 4 kg, you consult yourself, because that's a time when the patient is going for a heart failure. Once 4 kg is gone, you can look at the pedal edema. So before that, if you want, all the patients should be on should have one weighing machine which costs less than 1,000. So this diuretics, you can make the patient to titrate diuretics SOS. Then go for hydrolysin isosorbide dinitrate. If the patient has renal failure, you're worried about starting RNA, even with consultant with a nephrologist. If they disagree, you can go that. And ivabradine, digoxins still has the role. Device therapy, yes, it has all the supported by that. I will just close with that. And latest with heart transplant and bridge therapy. This is the LVAD assist device. And this is the final slide. I want to see that, and I will just go to whatever I discussed all this. See, this is one I want to tell the vericiguat. This is now picking up soluble guanyl cyclase inhibitors. This one guideline you just read 2025 latest Indian guidelines. See, it is very useful. If the patient has hypotension, don't start RNA. If he has high heart rate, you start nothing. If the patient has symptomatic hypotension, you RNA, you stop it, then you start. Be careful, beta blocker. This is a wonderful thing. You go through this one. This is our nice one. And the device therapy, very simple. If QRS duration is narrow, EF 35 below, put ICD. The QRS duration is more than 130 and the patient has EF less than 35, you go for CRTD. More than 150, definitely class 1 recommendations. I close with this final slide. So there is no sequential titration of 4 pillars. You must start simultaneously all the 4 drugs. Beta blockers, RNA, MRA and gliflozins. You can start with low doses, all the 4 drugs. So you inhibit all the axis, sympathetic axis, RAS axis and neprilysin, and get the benefits. Try to titrate within 2 to 6 weeks the maximum dose. This one is very, very important. Never go with first one AC, then beta blocker, and also simultaneous is very, very important. This is the latest trials supports that. So this what you start, initiate everything. If you this 2 you can start, but this you can titrate RNA and beta blocker. See, gliflozin you can immediately initiate. So that's it. So the final message is you prioritize the 4 pillars, start simultaneously, rapid and simultaneous sequencing, monitor the trends for NT-proBNP, TROP-I, not the single values. EF changes. If the patient EF is deteriorating, worst prognosis, the language matters. Never say that heart failure in remission. you say instead of patient recovered, and you say that it's persistent heart failure rather than stable heart failure. Tailor the treatment. You have these three important: blood pressure, heart rate, kidney function, urea creatinine is very important. And in spite of 3 months of 4 pillars adequate treatment, patient symptomatic EF less than 35, you can suggest device therapy. Thank you.
Thank you, sir. Thank you very much for your wonderful elaborate talk. If there are any questions from the audience.
In your practice, now where you level the IV iron therapy market, number one. In real world scenario, where do you use versicolin? Because good number of patients are having hypotension, number one. Good number of patients is having associated CKD. Good number of patients, because of the alcoholism, the liver is there. So, in what place you will put versicolin in your practice? And how do you titrate the dose of versicolin? And intravenous iron therapy, what is in your place?
Sir, I use lot of intravenous iron therapy, sir, because it is proven, because the time was short, I didn't show that all the trials supports that if the patient is anemic less than 10 and 9 grams, definitely IV iron has the role. And regarding vericiguat, if the patient is hypotensive, I was not able to start ACE, ARNI or things, and other things are not able to do it. I start vericiguat. I start with 2.5 milligrams, and every 2 to 3 weeks you can up titrate up to 7.5 milligrams. And it's little costlier. If it comes down, it can be used. But only situation is after all the 4 pillars, you should go for that. Or if the ARNI AC pillar cannot be used because of renal dysfunction and hypotension, you can go for vericiguat.
So if there are no questions, we can move on to the next session.
Thank you for the wonderful topic, sir. I'd like to invite Dr. Anandi ma'am to felicitate the speaker. We'll move on to the second topic of the third session, contemporary approach for managing dyslipidemia in high-risk patients beyond statins. I request Dr. Praveen, sir.
So I invite Dr. Praveen, Senior Consultant and Interventional Cardiologist at KIMS Global Hospital, Trivandrum. And thank you for this.
After that exhaustive talk by the previous speaker, I don't stand create a block between you and the lunch. I'll just go for a quick revision. So, beyond statins in high-risk patients with dyslipidemia, fine, right. So, you know, the dyslipidemia is a huge topic. So, it's very difficult to cover. I'll just go with the practical points alone. So, this is yesterday's patient which came to the emergency late in the evening, and so this clearly shows an anterior wall MI. And when you see the angiogram, there is triple vessel disease. You have so there is a tight lesion in the RCA. There's a lesion in the circumflex. There is an LED lesion. So that's an LED lesion also. And today morning when I go for the rounds, he's a 55-year-old male. This is the investigation. So you see the lipid profile, the total cholesterol is 292 and the LDL is 229. So this is a classical scenario of a high-risk patient I see in my clinical practice. And this patient has a strong family history of CAD. His father, his brother, all have a history of dyslipidemia, and the bystander just casually says his sister has dyslipidemia which is not getting controlled by statins. So this could probably be a heterozygous familial hypercholesterolemia. So the patient subset I see in my routine practice is almost always going to be a high risk dyslipidemia or a very high risk dyslipidemia. What would I suggest this patient? He's already on 80 milligrams of atorvastatin. Now, based on this study, the EVOPAC study, I have suggested this patient to start on evolocumab to bring down the lipids fast so that his lipids come down fast over the next 4 to 8 weeks. Of course, they are contemplating on that. But then this is where our exact role of any drug beyond statins comes into clinical practice. Again, a similar situation, a patient had a CABG 2023, and you see he has a new lesion in the LAD beyond the graft, presenting with an acute coronary syndrome. He was already on atorvastatin, all the drugs. I did a PCA, just a balloon dilatation alone. And this brings us to another concept, like a high risk, to what is called a residual risk. The first patient is a high risk. The second patient is already a high risk patient. He's on all the medications. Still, he has sustained an acute coronary syndrome. And that is what we call a residual risk. So, I would request all of you to go through this 2026 guidelines on dyslipidemia running to more than 100 pages, which gives an exhaustive discussion on lipid guidelines, and you can go through that. I'll just brush through that in my talk. See, when these newer drugs for cholesterol lowering came in, Braunwald had written a nice article where he said that how you can live to 100 years before clinical coronary artery disease develops. And there he has suggested that when you talk about LDL, the burden of LDL is actually dependent on number of years your blood circulation is exposed to high lipids. So that if you give a molecule like inclisiran, which reduces the lipids dramatically as a vaccine once in 6 months, you are able to prolong the time you don't develop a clinical CAD, so that you can even well live without atherosclerosis up to 100 years. So that is where we stand now. We have heard so much about apo molecules, lipoproteins. Our chylomicron absorbed from the stomach has ApoB48. That is not very permeable. So our concern is ApoB100, which is an important lipoprotein component in all the atherogenic lipoproteins, be it LDL, be it VLDL, all the remnants, or even lipoprotein little a, all these have ApoB100. So one of the new things we should understand is the introduction of ApoB in risk stratification of high-risk patients. So the new guidelines say that in adults on lipid-lowering therapy, especially with diabetes or elevated triglycerides, or your lipids are not coming down with statins, then you can measure ApoB, because that is a more important and more specific marker of the total atherogenic burden rather than LDL. Now, so it is basically measuring each atherogenic particle per se by ApoB, and that correlates with all together, whereas LDL cholesterol measures only the LDL component. And this happens in situations you have given statins, the LDLs are low, but still the patient's residual risk, maybe the ApoB has not come down. So this concept is elegantly demonstrated in this slide. Two patients both have the same LDL 100, but then when you measure the ApoB, this patient ApoB has come down to 80, whereas this patient still has 120. Thereby, this patient has a high atherogenic risk even with a low LDL. So the importance of ApoB measurement in high-risk patients is now stressed in the newer guidelines. Again, lipoprotein little a, we used to read lot when our MD days, then it went into vein. Now again, it has made a comeback. Now, in all patients, now an assessment of lipoprotein little a is advocated as per the newer guidelines, especially because of the phenomenon of high risk and residual risk. So you should measure lipoprotein little a, and yeah, of course, lipoprotein little a, and you should understand that it's a one-time measurement in life, non-fasting, majorly genetically modified. Newer drugs are in the pipeline to reduce lipoprotein little a. Now, coming to high-risk population, in high-risk population, the guidelines say that the LDL has to be less than 70. If it's a very high-risk population, the LDL has to be less than 55, especially with heterozygous familial hypercholesterolemia, atherosclerotic disease, or severe hypercholesterolemia. Again, the importance of subclinical atherosclerosis as measured by a coronary artery calcium scoring to stratify the patients from a low risk or intermediate risk to high risk is stressed in the newer guidelines. The importance of hypertriglyceridemia as a high risk modulator in patients where LDLs have come down is again stressed in the newer guidelines. And in all these patients, ApoB has also come the ApoB levels roughly correlate is almost the same, less than 55. Now, this slide gives the importance of lipoprotein concentrations. If the lipoprotein little goes up, you see the chance of atherosclerotic risk goes all the way up to 4-fold from a normal value of 30 to 49, and that is the importance of lipoprotein little measurement in cases of atherosclerosis. Now, the newer guidelines has come up with an equation called the prevent ACVD equation. You can download that from the previous pooled cohort equations to stratify patients from a low risk to intermediate risk or high risk. So, you give this score, you find the atherosclerotic chance over the next 10 years is 10% or above, that patient is going to be a high risk patient. Now, and again, they have also given a 30-year risk assessment also. Again, now, these guidelines have explicitly recognized that the most important serious adverse effect of concern for statins is induction of new diabetes mellitus in patients who have already a pre-existing impaired glucose metabolism. And there they have found that to have the benefit of statins in these sort of patients, you should find out what is the number needed to treat and what's the risk. And if the atherosclerotic risk is more than 10%, then the benefit of statins outweigh the induction of diabetes in these sort of patients. Now, this is also one thing these guidelines have recognized. There is something called a risk enhancer. You have somebody with a low risk coronary artery disease. You want to find out what is high risk. Premature atherosclerotic disease in a first degree relative is a risk enhancer. Again, South Asians, we are prone for coronary artery disease. We should understand that. Chronic inflammatory conditions, lipoprotein little, high sensitive CRP measured on more than one occasion, triglycerides high, the cardiovascular kidney metabolic syndrome or the CKM syndrome, LDL persistently elevated even on statin therapy, and again, the guidelines say that reproductive risk markers are also risk enhancers. Somebody has gestational diabetes, premature menopause, PIH, all these patients have a high risk of future cardiovascular events. Again, the guidelines say, somebody you find that LDL is say 140, 160, you say, hey, low risk, no need for statin. You should again risk stratify these patients based on subclinical atherosclerosis. You can easily do a coronary artery calcium scoring. If the calcium scoring is moderate, severe or extensive, these patients should be directed to statin therapy. Again, somebody with a low risk with a calcium score, say 300 on a plain CT, is naturally going higher up in the category of risk, and you should intensify the statin therapy. You know, we call severe hypercholesterolemia LDL levels 190 or above with a ApoB correlating with 140. And again, heterozygous familial hypercholesterolemia is also a high risk condition where you have a risk of CAD more than twice. Again, when you have a heterozygous with high lipids, 6-fold increase in atherosclerotic events are documented. So they obviously are a high risk population. So severe hypercholesterolemia, you have to rule out other secondary conditions. You have to screen the family members, and based on whether the patient has atherosclerotic disease or not, the treatment varies. And you can add ezetimibe, PCSK9 inhibitors, bempedoic acid with a goal of LDL of 55 or less. Again, the point you should understand is the conventional teaching is anybody with diabetes, dyslipidemia is high risk. Not always. Diabetes, generally a new onset diabetes, young diabetes, they generally is a moderate risk, whereas a diabetes with a high, long duration of diabetes, a renal involvement, retinopathy, neuropathy or a peripheral occlusive disease, they fall in the high risk category. So in adults with clinical atherosclerotic disease who are on high risk, you should intensify statin therapy to high risk, and there comes the role of newer molecules. So again, for us clinicians, major atherosclerotic events, especially episodes of acute coronary syndrome, history of MI, ischemic stroke or symptomatic peripheral occlusive arterial disease, more than 2 events or 1 major event plus either of these high risk conditions like a 65-year-old above, CABG, PCA, smoker, diabetes, hypertension, all these, they form a high risk population or even rather a very high risk population. CKD patients, we know they are also high risk population, but then again you should understand that CKD means not end stage kidney disease where the benefit of statins or high intensity statins is debatable or not even proven. And hypertriglyceridemia, we all know we have to maximize the statin therapy because the target of therapy is still LDL. If it is not coming down with that, then you have to add icosapent which has trial data compared with gemfibrozil or fenofibrate for lowering the cardiovascular events. Of course, elevated lipoprotein little now the PCSK9 inhibitors reduce the lipoprotein little a. Newer agents are on the market, expected shortly. But as of now, if somebody has a high cardiovascular risk with elevated lipoprotein little a, the newer guidelines say that these patients should be initiated on inclisiran or evolocumab. Of course, the emergent lipoprotein therapies we know, antisense oligonucleotides, small interfering RNA, even the oral agent movalaplin, they are all undergoing clinical trials, and maybe in a decade, within a decade, we expect these drugs in the market. Now, why should we think beyond statins in our routine clinical practice? We know even with high doses, some patients lipids are not going to come down. Then we have what is called a residual risk or a high risk, intolerance to statins, adverse effects. Again, adverse effects are more often patients thinking that they are going to have adverse effects, which is often called a placebo effect, which is actual reality, not an adverse effect. And then of course, we know some conditions like a homozygous hypercholesterolemia is not going to respond to a statin. A heterozygous might have an inadequate response to a statin. So, you have all the newer drugs in the market, ezetimibe, bempedoic acid, the combination, high intensity statin with any of these combinations or with the PCSK9 inhibitors, where right from a 30 to 50% lowering of LDL with statins to almost a 86 to 90% lowering of LDL happens with the PCSK9 inhibitors. The most useful drug is ezetimibe. We know it's an oral cholesterol absorption inhibitor. It blocks the intestinal biliary receptors for absorption. Orally 10 milligram once. Generally around 15 to 20% reduction in LDL happens either in isolation statin intolerant patients or add on to statins. Again, these drugs can also raise the LFT. So, you have to monitor the LFT. Then PCSK9 inhibitors, we know there are two. One is a monoclonal antibody, evolocumab and I think alinocumab. It binds to PCSK9 and reduces the LDL receptor degradation. It's subcutaneously given once in twice, 2 to 4 weeks. Secondary prevention, we have data with statins, and there is almost a 50 to 60% reduction with evolocumab in trials. Then we know about bempedoic acid, that is an ATP citrate-lyase inhibitor. If you take the cholesterol pathway, that is higher up the HMG-CoA system. So it is 180 milligram orally daily, and it is a prodrug which is converted to an active molecule. It's useful in primary prevention as well as secondary prevention. One caution is that this might increase the uric acid levels and might precipitate hyperuricemia and gout in prone patients. Again, you have to monitor the renal function in these sort of patients because worsening renal function is documented, which is usually reversible. Then muscle symptoms and tendon ruptures are also documented bempedoic acid, so you should monitor these patients. Again, they also reduce lipids to around 18 to 20%. Now, inclisiran is a PCSK9 inhibitor, which is not a monoclonal antibody, but it is a small interfering RNA. It is given subcutaneous once in 3 to 6 months with more than 50% reduction in LDL. And we have a slight dearth of secondary outcome data compared to the evolocumab, so more data is actually expected. So if we take the lipid lowering therapy, we find that when you have all the drugs together, you are virtually able to knock out the LDL. And we have seen patients on inclisiran having a single digit values of LDL like 5, 7 and all that. I think others will also have the same experience. Of course, these drugs are newer in the pipeline. This is actually useful for further reduction of LDL and triglyceride. This might be in the market shortly. I'm sorry. Yeah, I think that's the last slide. Thank you.
Thank you, sir. Thank you very much for the eye opener and topic in DLP and the newer drugs in the dyslipidemia management. If there are any questions from the audience, please.
What is your place for colchicine? How often you start in your practice?
Actually, the newer guidelines recommend monitoring of CRP in patients who have a respiratory risk as a risk enhancer. You have somebody with coronary disease of atherosclerotic events. You control the lipids with statins. Still, the patient has events. You are supposed to monitor CRP at least 2 values, which is CRP. If that is elevated, that suggests there is a respiratory risk, and there is small outcome data with colchicine also. Even the newer guidelines say colchicine, but not conclusively proven.
So if there are no questions, we will wind up the session and we'll move on to the next topic.
Thank you, sir, for the elaborate discussion for the day-to-day Peli. I request our moderator, ma'am, and Dr. Calvin Singh, sir, to felicitate the speaker. Thank you, sir. Moving on to the last topic of the third session, advances and current status of valvular interventions by Dr. Selvamani, sir. Over to moderator, ma'am.
So I invite Dr. Selvamani, sir, for talk on advances and the current status of valvular intervention. And he is a senior consultant and interventional cardiologist in Meenakshi Mission Hospital and Research Center, Madurai. And he has performed 20,000 plus PCIs. And he is a very good academician also. So he is a pioneer of all newer therapies in South Tamil Nadu, presented more than 5,000 sessions in regional, domestic and international forums. And
valvular heart disease like aortic stenosis is definitely a big problem. And recent advances like transcatheter therapies, that what we are doing, that is non-surgical therapy, definitely has improved the management of valvular heart disease. So common valve disease, what do we have is aortic valve, mitral valve, tricuspid valve and pulmonary valves. So these are the common valves we have, and even in all the valves we will either have stenosis or we will have regurgitation. So my point is, like, we have a lot of advances. I will tell you a few things that how we treat. Before that, you should know that when this patient should be treated, that is, what are the indications, because you are the people whom you are going to see the patient first. And once you see the patient, you should know that when this patient should be referred or when he should be treated. So basic principle, if somebody is having any valvular disease, if it is a severe disease, either stenosis or regurgitation, and if the patient is symptomatic, definitely he requires intervention, no doubt. I am just simplifying for the physicians. It is if symptomatic, either severe or severe stenotic or regurgitation, he needs to be treated. Now the problem comes is, he has a valvular lesion, but if it is not severe, what is the thing? So then you require a specialist to consider whether he needs treatment, whether he needs to be treated or not. That is one. And next step is when somebody is asymptomatic, when there is no symptom, but on routine evaluation you find that he is having a problem. So then of course there is a question. We have certain criteria when even if the patient is asymptomatic, must be treated for valvular heart disease before he comes with a stage where he becomes inoperable. So the secret of success for the management in our society lies in most of you physicians and the general practitioners, because you are the people, you see this where patients first, and you should recognize he requires treatment, and then it should be referred in a right time, not in a stage where patient is class 4 in pulmonary edema, where not much cannot be done. So to say that classical symptoms, like if he has, you know the symptoms of aortic stenosis, dyspnea, chest pain and syncope. And if they have severe aortic stenosis, these values are echocardiographic values where we diagnose it as severe aortic stenosis. And if this patient has severe aortic stenosis and symptoms, he must be treated with aortic valve replacement, either surgical or percutaneous, which I will tell you how we decide. And when somebody is asymptomatic aortic stenosis is also very common. You clinically pick up a murmur. If it is severe aortic stenosis where the gradient is very high, and if we see that the progression of stenosis is higher, that is 0.3 millimeters per square per year, that is, he is progressing very fast, probably even if there are no symptoms, he should be operated. And if aortic stenosis is associated with reduced ejection fraction, so that is a classical indication that this patient requires aortic valve replacement. Now comes how we are going to treat this aortic valve replacement. All these years, it was only surgical aortic valve replacement, but probably for a decade or so now, we are doing non-surgical aortic valve replacement, what we call it as TAVI. So generally, to whom we are doing TAVI is, now the advances in this valve technology has become so comfortable. For patients who are above 65 years in Indian population, most of the patients you can do percutaneous aortic valve replacement. For younger patients less than 65, even today we recommend surgical aortic valve replacement. So I think I'm very clear in this. And of course, in patients in whom surgery is not possible, very old, very fragile, above 80 years, because so much of comorbidities in which you cannot operate, in such cases, we generally do percutaneous aortic valve replacement. In general, any patient above 65, we can do a TAVR procedure. Now, coming to regurgitation lesion in the aortic valve. Here, it is very, very simple. If it is severe aortic regurgitation and if the patient is symptomatic, as I already told you, he should be operated, he should be treated with aortic valve replacement. Then, but many times regurgitation lesions, they may not develop symptoms very early. So even if he is asymptomatic, we have certain echo criteria. If the LV is getting dilated, so that is the point that this patient requires valve replacement. So for that you will have to do an echo, you need a specialist to say that. But whenever you suspect aortic regurgitation and it is a severe aortic regurgitation, forget about mild AR, moderate AR, trivial AR, all those things can be managed medically. I'm talking about all severe valvular lesions only require therapy as a general rule, unless otherwise. So this is because it's a very basic thing. Most of my referral physicians, they keep asking, this patient has mild MR, moderate MR or something, he is having atypical pain, should I operate now? So to generalize, any severe lesion, definitely it is indicated. And then today, as I already told you, it is a class 1 indication in patients in whom the valve is suitable for percutaneous aortic valve replacement for aortic stenosis. When it comes to aortic regurgitation, we still have some technical issues in doing percutaneous, although we do percutaneous aortic valve replacement for aortic regurgitation. There are certain technical challenges which probably we will consider. If it's not suitable, still we send them for surgery. And I'll just show you how we do a percutaneous aortic valve replacement. So it is a very simple procedure and patient is usually discharged within 1 or 2 days. And most of my cases, we do it under local anesthesia. And probably in our region, we do the highest number of aortic valve replacements or probably any valve intervention in this southern Tamil Nadu region. And it is, as I told, in Indian population, anybody above 65, aortic valve replacement is an excellent treatment. And what we do in aortic valve replacement is, so we generally introduce a puncture in the femoral artery. From the femoral artery, a catheter is passed into the aorta to the heart, and we go to the aortic valve ear and we cross the valve ear with a wire. And then you take a balloon there, and then this is the balloon which is getting inflated there. So this is, we call it as pre-dilatation. Once you dilate it, the valve which is stenosed actually becomes widened well. And then after that, we have different types of valve, balloon dilatable, self-dilatable valves. And you place this valve. This valve is loaded on the same balloon which I showed you, and it is deployed in the valve, and the valve immediately starts functioning once it is deployed. We will see a live case here. How we do is, before any valvular percutaneous intervention, for us today, CT, cardiac CT is a very important tool. In the advancement of cardiac imaging, what precision it gives is, we will know exactly what is the size of the valve, what are the complications to expect, where to keep the valve, and cardiac CT is an excellent tool for that. And see here, actually this is the left ventricle and this is the aorta, this is the aortic valve. We are going to put a valve here. When you are putting the valve there, most important structure what we have there is coronary arteries. So if you block this coronary artery, patient is going to have an MI on table. So we'll have to be so precise that you are not going to block the coronary artery, and at the same time you should not overdilate and create problem and rupture the aortic valve. So to decide all these things, we need cardiac CT, and 90% of the job is done with cardiac CT. It is all done outside the cath lab. We plan it properly, then the procedure is very, very simple. And we look at for the amount of calcium on the CT, and then we'll have to look at the peripheral arteries also, because you are going to take the valve from here to here. We need adequate sized peripheral arteries. If it is also severely diseased, it is very difficult to take it. But anyhow, we measure all these things on CT and take a decision, and we decide what size of valve that we are going to put here. So here, this is what we are seeing. This is the pigtail where there is the aortic valve, and this is how it looks. We always put a temporary pacemaker, so that while deploying the valve, we pace the heart at very fast so that the valve doesn't jump out. I will show you how we do it. And this is the wire crossing. From the aorta, we are putting a wire into the LV so that we cross the aortic valve. Once the aortic valve is crossed, we have specialized wires which we keep into the left ventricle like this, and then we pre-dilate with a balloon. So as I already showed you, we take the balloon here and just dilate across the aortic valve so that the severe aortic stenosis comes down. And now you take the valve from the femoral artery into the aorta here, and then you just cross the valve. You might feel, how do you cross the valve into the aortic? It usually crosses very freely, and it is a very simple procedure. It crosses like that, and we are positioning the valve here. And once I position the valve exactly where I am satisfied, you see here the coronaries are here on both sides. I am not going to block this coronary now. And then now we are deploying the valve here. So this is how it is deployed. While deploying, what we do is we'll increase the heart rate through the temporary pacemaker to 180 so that the BP comes down. When very fast, when the heart is beating, we deploy the valve, and this is how the valve gets deployed there. And this is immediately after the deployment, and the valve functions immediately after you deploy there, and whatever severe aortic stenosis were there gets treated. And this is it. And sometimes if you need it, you can post dilate the valve also. Most of the time that may not be required. And this is the final angiogram. We look for aortic regurgitation and look at for the gradient across the valve there. So this is how a percutaneous aortic valve done. So it is all very simple, and it is done in the local anesthesia, and generally patient gets discharged on the day 2, and they have a very good follow-up, and we have an extensive experience with this with us. And right-sided aortic valve is tricuspid stenosis and tricuspid regurgitation, which we have already dealt in the earlier session, but for just to completion, I will just tell you, we have percutaneous tricuspid valve replacement also, which can be done, which we call it a strict valve. It is done for severe tricuspid regurgitation. What we do is, instead of treating the tricuspid valve directly, we put 2 valves, one valve in the inferior, one valve in the superior vena cava, so that it acts as if you are treating the tricuspid valve. This is one of the easiest technique which is there for last few years for tricuspid valve. And now coming to mitral valve. So mitral valve is, again, as I told you, if the mitral stenosis is severe and the patient is symptomatic, there is no doubt you should operate him. So how are you going to operate? Either open or percutaneous, depends on the valve morphology. But today the most common procedure is percutaneous mitral balloon valvotomy, or BMV, what we call it as. It is again a very simple, we have extensive experience for the last so many decades, and with high volume experience, This is a very simple procedure, and I think it is a boon for patients who are really, most of the time, mitral stenosis patients come from very low background, and probably it's a very boon for them, this therapy, and it's very cheap also. And next, coming to mitral regurgitation, again here, if it is a severe MR, if it is symptomatic, it should be treated. And if it is severe mitral regurgitation, and even if it is asymptomatic, as I already told you for regurgitation lesion, we have certain measurements on echocardiogram. That is LV, if it is getting dilated, if the LV volumes are increased, probably you should operate that patient surgically or percutaneously. So important thing is mitral regurgitation, common cause is rheumatic heart disease. Apart from rheumatic heart disease, we have other reasons now. For example, when patients have an MI or they have dilated cardiomyopathy, they tend to have mitral regurgitation, which is very significant. And due to this MR, they will be having significant history of hospitalization, dyspnea. So in such cases, also they might require a surgical or percutaneous intervention. And the most common percutaneous intervention that for secondary mitral regurgitation, but today we are practicing is mitra clip. Mitra clip is percutaneously you can repair the mitral valve. So previously surgeons, what used to do, they used to open the heart and they used to do a surgery called Alfieri stitch to repair the mitral valve so that mitral regurgitation gets reduced. That can be done percutaneously now. I will just show you how we do this. This is a patient who had severe LV dysfunction and severe mitral regurgitation. And this is a severe MR, and you look at the LV is severely dysfunctional. And this patient was put on all anti-failure medication, what Arnachalam sir and most of us we have been telling. In spite of that, the patient is getting admitted to the hospital having dyspnea, and he is unable to walk even a little bit. So in such cases, what we do, so here this is the mitral regurgitation. We has the severe MR in such type of patients. If you treat this mitral regurgitation, definitely it will improve. So what we did is we decided for mitra clip here, and generally we do it under transesophageal guidance, and this is how the transesophageal echo looks here. And once you see this, it's a severe MR, and then we have certain examples here. And how we do is, actually we take only venous puncture for this. We enter the femoral vein, go into the right atrium, and this is the interatrial septum. From the right atrium, we will go into the left atrium by puncturing the interatrial septum. You do the puncture there, and you enter into the left atrium, and once you will enter the left atrium, you will have access to the mitral valve. And this is the mitra clip device that we have. This catheter is introduced into the left atrium. You can flex it antegrade, retrograde in any direction. So we will look into the transesophageal echo and fluoroscopy. We direct it towards the mitral valve. And once it is going there, we look into the alignment of the clips, both to TE as well as fluoro. And this is how it looks when we are aligning into the LV. And once it is there, we put the clip there based on the fluoro as well as TE there. And once you place it, so this is how we are catching the mitral valve leaflets there. You just catch there, and then it is a position we make sure after catching the MR is reducing, and then it is just released. There is a switch. If you just put it, it gets released here. So now what has happened is, see here, the clip is holding the mitral valve here, so it is reducing the mitral regurgitation, and this is how it looks. And once you release it, you do an echo, you see that severe MR what was present becomes very less. And we always look for forward gradient. By putting this, you should not produce mitral stenosis also. So we look at the gradient and then decide. And this is the post 2 days pre-discharge echo. It is a very mild MR. And then patient, this procedure is almost 1.5 years now. After this procedure, he never got admitted for failure. And his class symptom is almost class 2 to better now. A patient who had severe MR and LV dysfunction. So this is a very important procedure, and surgical procedure in such a high risk patient carries a lot of risk, and this can be done percutaneously and safely today. And next, basically, as I told you, most of the time it helps in reducing admissions and exercise capacity improves, and it's a percutaneous simple procedure. And you are all familiar with balloon mitral valvotomy for aortic mitral stenosis. And you just, again here, we puncture the interatrial septum. You go into the left atrium and dilate the septum. And this is the balloon mitral valvotomy balloon that we have. You cross across the mitral valve and then deploy it and dilate it. And this is how you treat mitral stenosis. And we can replace mitral valve also percutaneously, that we are doing routinely today. That is TMVR, percutaneous mitral valve replacement. And usually it is done for patients who already undergone surgical bioprosthetic mitral valve replacement with valve dysfunction. Here again, percutaneously you can cross into the left atrium, cross the valve, and then we dilate it with a balloon, and then this is how the valve is deployed in the mitral valve also. And native mitral valve replacement is a research tool now, although there are few cases where even in normal persons, even without surgical valves, we can do mitral valve replacement today, but in full-fledged real-time practice it is still not established. And if there is severe annular calcification, you can still do percutaneous mitral valve replacement. And pulmonary stenosis is usually treated with balloon pulmonary dilatation. So to conclude, today the advancement is so much, especially the imaging, especially CT, TEE, cardiac, cath labs, all the facilities have improved so much, and most of the surgical procedures can be done percutaneously without opening the heart. Especially valvular aortic valve is a very, very important today. So in our practice, the maximum number of procedures is still balloon mitral valvotomy. Then it is TAVR, that is percutaneous aortic valve replacement. Then mitral clip or mitral valve repair percutaneously. And then percutaneous mitral valve replacement. And lastly, the TRIC or the tricuspid valve procedures. So these are the current position that we are using. And this is a brief introduction for you people regarding valve interventions. And I think with this I will stop. And if there are any doubts, we can always discuss. Thank you so much.
Thank you, sir. Thank you for your clear explanation and procedural videos. We really enjoyed. So if there are any questions from the audience. Sir, is there any age limit for aortic valve replacement?
See, there is no limit at all. Actually, in the Western countries, even at 1995, we are seen. When I went to Germany some 10 years back, where I got this training for TAVR. So most of the patients above 85, 90. For them, it's all covered under insurance. For them, age is not a limit. And they do it for any patient who is actually fit for the procedure or probably wants to be done. It's all covered under insurance. For them, it's all free. But in India, definitely there is an issue. See, we are doing it for patients who are above 65. But in India, we are 75, 80, 85. The tendency for the patients to come to the hospital itself comes down. And even if they come, most of them, they may not be willing for a procedure like this. They want to take some medicines and go away. But in spite of that, awareness is improving, because if you treat these patients, they do extremely well. Aortic stenosis, when it becomes symptomatic, mortality is very high. Generally, patient dies of within 6 months or 1 year. So it's such a bad disease, he'll be sitting, suddenly dies. To prevent that, this is an excellent therapy can done to anybody. In my center, the eldest patient is 89 years old. I have done a TAVR procedure. And only thing is, the offspring should be educated, willing to do that, and then affordable, of course.
Thank you, sir.
Thank you, sir. And I request our moderator and Dr. Calvin David Singh, sir, to felicitate the speaker. We sincerely thank Dr. Selvamani, sir, for sharing his valuable knowledge and practical clinical insights with us today. Thank you, sir. I request Dr. Calvin David Singh, sir, to felicitate the moderator. Thank you for it. After completion of 3 successful scientific sessions, we now break for lunch. Participants are requested to kindly proceed to the designated dining area for lunch. The scientific sessions will resume after half an hour, and we request everyone to kindly reassemble on time so that we may continue the program as scheduled. There's instructions for the postgraduate quiz session. I request all the participants to kindly stay back only for brief instructions. We have 8 teams registered so far. Kindly stay back for instructions. Once again, sir. We have 4 topics for the current session. Let's welcome our first speaker, Dr. Selva Rani ma'am. Myocardial infarction with non-obstructive coronary arteries, MINOCA, an update. Welcome, ma'am.
So the topic is myocardial infarction with non-obstructive coronary arteries, an update by Dr. Selvarani. She is from Madurai Medical College, and she's a Best Doctor Award from IMA Madurai chapter, and she was editor of 10 CSA Cardiology Society, and having many papers to her credit. And we were happy to hear from you, madam.
Very good afternoon, respected Chairperson, sir, and Dr. Calvin, learned audience. After a great struggle, technically, we will move on to the very important topic, very clinically applicable, is a MINOCA. What is MINOCA? M for myocardial infarction, MI for myocardial infarction. NOCA means a non-obstructive coronary artery disease. That is, you will have ECG changes similar to infarction, but patient will not be having significant coronary artery disease when you do the angiogram. That is the main topic we are going to deal with. This is the definition. As I have explained, it is with a non-obstructive coronary artery disease. It's a evolving concept in cardiology. It represents heterogeneous group of ischemic myocardial injuries without obstructing the coronaries. And you can have even highly sensitive troponin elevation. So to understand the concept, we have to understand what is the epicardial artery, what is arteriole, and what are all the small arterioles between 40 to 100 microns, and what are all the capillaries. And this is the place where the circulation to the myocardium plays a very important role. For good blood supply to the myocardium, we need to have all these to be normal: epicardium, pre-arteries, arterioles, and the capillaries, as well the endothelium, which has to be normal. If it is affected by atheromatous process like this or any spasm like this, there will be a reduction in the blood flow, leading to compromise of the capillary circulation, leading to myocardial damage. And this is in toto, ischemic heart disease can be classified into stable coronary syndrome and acute coronary syndrome, among which you have in the acute coronary syndrome, unstable angina, NSTEMI, STEMI, and separately the MINOCA has come as a separate classification. So I have already told you the mechanism. You must have seen in the clinical books there are 5 causes for infarction, is it not? One is plaque rupture, another one is spasm, another one is clot obstructing, another one is any stress, that is demand supply mismatch, and another one is the slow flow leading to thrombus formation. All those things can play a role, but mainly in MINOCA only 3 mechanisms will overplay and overlap, and the plaque rupture is the first one, and next will be the coronary spasm, which are very important pathological. We will see in the next slides also the same thing. And the coronary arteries will have a structural problem one side and functional problem in the form of spasm on the other side, and structurally certain things may be altered, like LV hypertrophy, diastolic dysfunction, and increased LV EDP, valvular heart diseases like aortic stenosis, severe systemic hypertension, coarctation, and dilated cardiomyopathy and infiltrative cardiomyopathy. All will lead on to reduction in the microcirculation, which can be again divided as 2 mechanisms. One is functional obstruction, another one is the structural obstruction. And this is the epicardial arterial spasm. leading to reduction in the coronary blood flow, but the coronaries are non-obstructive, and here in the downstream you have the microvascular dysfunction. The coronaries are obstructive due to atherosclerosis. Both will lead on to myocardial damage. So there are 3 diagnostic criteria to diagnose myocardial, that is MINOCA. The universal criteria for acute myocardial infarction holds good, and angiogram is negative. Negative means not fully normal. There may be 50% lesion. Anything not more than 50%. And then no clinically overt cause for the acute presentation. As far as other coronary artery diseases are concerned, we know these are all the risk factors. There the plaque has ruptured, there the erosion has produced, all those mechanisms we know. But here the mechanism is a question mark at the time of presentation. And this is how the definition of MI, you all know. The universal definition for MI, the AMI criteria is the number 1, number 2 is non-obstructive coronary artery disease. Normal means not more than 30, and partial means not more than 50%. And no clinically or about specific cause for the acute. Already I have told you the 3 criteria. And there may be some overlaps between the diseases whenever there is a troponin has raised. For example, MINOCA one side, other side myocardial diseases like myocarditis, Takotsubo cardiomyopathy and other cardiomyopathies where there is a microscopic damage to the myocardium. And non-cardiac disorders like pulmonary embolism, renal impairment where the troponin may get elevated, even CPK, MB. Acute aortic dissection can also present with the STT changes, chest pain, and they mimic like infarction. And again, what are all the coronaries which can be visible in the fluoroscopy? They are all the epicardial visible vessels which are of a diameter more than 1 millimeter only we can see, but the smaller arteries starting from 400 microns to 10 micron, that is that tree you can't see in the fluoroscopy as you see in the second diagram. And epidemiologically 5 to 10% suffer this type of problem, and most of them are younger and most of them are females. And outcomes, as you think it is not a benign condition, sometimes they may go malignant. So that is why they need some systematic type of evaluation. So this is the concept of MINOCA. It is a working diagnosis, not a final diagnosis. You have to go further. We are halfway through, that is the meaning. So overview we have seen epicardial and microvascular circulation. There is a disruption due to so many risk factors like diabetes, hypertension, high cholesterol and obesity. All will lead to oxidative stress, which will lead to a balance between the dilators and constrictors. And there is a reduction in the nitric oxide availability leading on to endothelial dependent vasodilatation failure. And again, the adhesion molecules will increase leading on to further constriction of the endothelium leading to stenosis, and there is a reduction in the circulation. So many inflammatory problems are also there. Cytokine response and tumor necrosis factor alpha, everything will come to play. So that is why we call the coronary artery disease as a disease of inflammation. So this is what I was telling, no? The nitric oxide, ROS system, endothelin 1, and all these things get totally deranged in a non-obstructive coronary artery disease. And these are all the common etiological problems. Plaque getting disturbed, and otherwise called plaque disruption or plaque erosion or rupture, and vasospasm can be another mechanism. Dissection, the SCAD, spontaneous coronary artery dissection, and thromboembolism, microvascular dysfunction, and demand supply mismatch, as I have already told you. These are all the etiology. One by one we see. Plaque rupture means there is a stable plaque, suddenly one day the shoulder part of the plaque get ruptured, and this is the vasospasm. You have a small 50% plaque is there, and proximally or distally you can have a spasm that can be induced by hyperventilation, or in the cath lab acetylcholine also can be given. And for such conditions, you have to put the patient on calcium channel blocker to avoid further spasm. You can see here there is a plaque, a small plaque is there. You can see. So this plaque is there. Proximally or distally, you can have total spasm leading on to total obstruction of the distal vessel. And microvascular dysfunction, you are very well aware of this condition due to diabetes, hypertension, endothelial dysfunction is there, and microvascular problem oversees the epicardial disease. And the diagnosis requires further minute estimations like coronary flow reserve and index of microvascular resistance. So these are all the newer technologies where you can find out the coronary microvascular dysfunction, otherwise called CMD, and it is increasingly recognized in the Minoka patients. Now, are you able to see the coronary artery? This is a LED. You are seeing the slow flow, is it not? So the Timmy count, otherwise called Timmy count. So normally we have to start from here to here to reach how many counts it needed. So whenever there is a slow flow, it indicates a microvascular dysfunction even though the coronary arteries appear normal. So there is a gross slow flow, and where it starts from the area where there is a dilatation of the coronary artery, otherwise called a ectatic segment. That is also coronary artery disease. Not all the constrictions are diseases. Dilatation of the coronary is also a coronary artery disease. And coming to the SCAD, spontaneous coronary artery dissection, is a very important cause for Minoka. It predominantly affects younger women without traditional risk factors. Some weakening of the valve can occur leading to disruption of the endothelial dysfunction can occur, and one layer will be peeled off and leading to obstruction of the artery partially or totally. Angiographically, sometimes subtle changes may be there, and you have to do some further intravascular imaging like OCT or intravascular ultrasound to see what is really happening there, what is the true lumen, what is the false lumen, etc. So sometimes if the flow is achieved, we need not bother, because putting a wire is a problem. It will definitely go false lumen and produce a totally no flow phenomenon can occur. That is why if you have a Timmy flow, very good flow, 2 to 3, better leave the patient as such. So here you can see the SCAD. So inside the artery you are able to see some spiral and non-opacified areas are there. That is the dissection of the mid LED, but there is no disruption of flow to the diagonals or septals. So in such patients you need not go and meddle with, you can continue the patient with the medical management. These are all the classifications of the SCAD and etc. Type 1, type 2, type 3 are there. We are not worried about that now. And coronary embolism, some microembolization. Whenever we are doing angioplasty, so balloon and every hardware, when it is passed through the coronary arteries, it will try to embolize the clot which is sitting over there to the distal part. So where will it go? It will definitely enter into the microcirculation and it will produce microvascular clogging of the vessels leading on to stunning of the myocardium, further worsening, resulting in the on-table VT, VF, bradycardia, sudden death, etc. So this management, you have to prepare the patient with a good antiplatelet, anticoagulation, and inside the coronary also you can give antiplatelet agents intravenous and anticoagulant agents intravenous to prevent further occlusion and clogging of the small coronary arteries. And what is the role of CMR? The MRI, cardiac MRI is having definite role in the microvascular disease. So it is the gold standard for the tissue characterization of the myocardium. It differentiates between the infarction, myocarditis and the Takotsubo stress cardiomyopathy. Late gadolinium enhancement, the so-called LGE, can occur. The pattern itself will give you a clue whether it is a mid-myocardial, subendocardial or epicardial, etc. So it is recommended for the Minoka patients as a next part of investigation. You can see the transmural LGE indicating ischemic cardiomyopathy. Subendocardial means again ischemic cardiomyopathy and various other causes. Idiopathic DCM also can have. Amyloidosis will be having uniform subendocardial LGE. Epicardial LGE can occur in myocarditis and also non-dilated cardiomyopathy, which is a new entity you can see in the ESC guidelines. Myocardial mid-wall LGE can occur in the idiopathic DCM as well as in the myocarditis as well as in the hypertrophic cardiomyopathy. So like this, no LGE can occur in the some of the places where the perfusion defect is not there, so it may be normal. So this is some of the pictures showing the LGE, the mapping showing myocardial disruption and the rings in the subendocardial indicating ischemia as a cause. So here this coronary artery portraying the small subtle lesion in the middle eddy. You can see the plaque here, small plaque is there, but in the cardiac MRI, you can see beyond this lesion, ischemic problem is there in the MRI, you can demonstrate. So even though the lesion is small, the fractional flow reserve is not satisfactory, leading to ischemia of the distal myocardium where it supplies. So MRI is a gold standard for assessing the tissue characterization of the myocardium. So it is a very important study showing heterogeneous group of patients undergoing CMR. You can see this sort of acute myocardial infarction in 24%, myocarditis in 33% of patients, and this is Takotsubo cardiomyopathy, HCM, DCM, and other cardiomyopathies, and this is a diagnosis not available in these cases. So it's a very busy slide showing any patient with abnormal circulations, we can subject them for cardiac MRI, and this is a split up. So in this one study showing the most common is the myocarditis, next come the undiagnosed, and next come the acute myocardial infarction and related disorders. What is the role of OCT? So optical coherence tomography provides high resolution imaging of the coronary artery. Put a wire over the wire, the machine goes inside, and this tip will have the camera, and like this you can see. So you can see the representation here. So there is a plug, it is a plug. It has ruptured and given way, and this representation diagram showing platelet-rich thrombus nearby. These are all the thrombi. Okay, so this is a wire artifact. So this is the three layers: endocardium, myocardium, and the epicardium. And the backscatter indicates the lipid present in the around the plaque. So the entire circumference is having lipid, and in the shoulder region, this is the plaque region, and this is a normal area where it has given way. That is the theory. Shoulder region will give way for the plaque rupture. And here what has happened, there is a small erosion which is overlaid by the platelet-rich thrombi, and you can see this arrow showing the small erosion which is healed now. So, and that is healed, and platelet-rich thrombi you can see. Thus very clearly you can see 2 millimeter resolution inside the coronary artery. You can visualize what is happening inside the coronary. So Minoka, even though the subtle changes are there in the fluoroscopy, the image guiders show all these changes through the optical coherence tomography. I am not going into the detail. This is the normal one. 3 layers you are able to see. This is a fibrous plaque, thrombus, backscatter means red thrombus, no backscatter means white thrombus. Lipid plaque will have a shadowing artifact, and a calcified plaque will have very severe shadowing artifact. So like this we can characterize what is there in the coronary artery. These are all the some of the examples of the coronary lesions by OCT. Again, like the same manner, by using intravascular ultrasound, it produces somewhat characterization to the deeper wall, that is the mid layer and the adventitial layer. You can see better, and it detects plaque burden, remodeling, and it complements with the OCT in the selected cases. It is useful when the OCT is not feasible, and also in the large lumen like left main will have a large lumen. So intravascular ultrasound is the imaging of size in the left main, aorta, arterial lesions, etc. So this is a one patient showing normal coronary artery. It is not at all showing any problem, but in the IVS you can see a small erosion which is healed. You can see in this picture, and this diagrammatic representation also you can see. So don't think that Minoka patients are having normal coronaries unless otherwise proved by IVS and OCT. And these are all the diagnostic algorithm for the Minoka. Once the patient is suspected to have a heart attack followed by angiogram which is normal, you have to subject the patient for thorough echocardiography, D-dimer blood test to rule out pulmonary embolism, and also endomyocardial biopsy for certain cases to diagnose myocarditis, IVS OCT for the lesion characterization. So this is a diagnostic algorithm. Step 1, 2, 3. Cath lab, what is the step? After angiogram, you have to go for the IVS or OCT or vasodilatory test like acetylcholine, etc. So this is the bedside algorithm. Clinical history, physical examination, ECG, blood test, and CTPA, the CT pulmonary artery angiogram, and CT brain for ruling out any associated problems, encephalopathy, etc. And the post-discharge care also, one has to advise the patient to go for cardiac MRI, because at the time of admission, patient may not be able to go for MRI. So these are all the some of the working diagnostic algorithm. Coming to the coronary flow reserve, I will skip these slides. I have told you these are all the measurements to find out what is happening in the inside the coronaries. So you can see this splaying of the curves due to adenosine once given, the distal lesion will have the reduction in the blood supply. So there is a splaying of the curve leading to FFR of 0.7. That means aorta, if it is 100, after the lesion it has to be 90. 0.9 will be the normal. If it is less than 0.8, it has to be addressed. Here it is 0.7, so you have to put a stent into this lesion because the fractional flow reserve is low. And these are all the some of the studies on Minoka, Swedish study, Minoka bat study, telling what are all the mechanisms underlying, what are all the management we have to give. So having diagnosed Minoka, we have to go for the antiplatelet, anticoagulation and symptom stabilization by nitroglycerin, etc. ACE inhibitor, ARBs, all the preventive measures, secondary preventive measures you have to give. And control of hypertension, you have to know the numbers, 130, 80 and HbA1c of 7, and dyslipidemia means 55-85. LDL should be less than 55 and non-HDL should be less than 85. These numbers you should not forget, and you have to give the lifestyle modification, cessation of smoking, etc. And all the guidelines are insisting the multimodality imaging and the proper treatment. So to conclude, Minoka is a complex and heterogeneous syndrome. It requires a systematic multimodality diagnostic approach and the mechanism specific therapy. If it is a SCAD with the flow, you leave it. Total occlusion, you try to do something either by intervention or by surgery. Like that, if it is a spasm, give the anti-spasm medications, mainly the calcium channel blockers. And future researchers will refine management strategies. There is still a role for antidepressant medications like amitriptyline, deriphylline, and your trimetazidine, etc. There are small studies supporting the positive outcomes among the Minoca patients. After having Minoca, the patient has to be followed up till their end with all the goal settings. Thank you for patient listening. Thank you for the opportunity. I thank Dr. Calvin for having called me to give this lecture. Thank you, sir.
Thank you, madam. You make us understand that Minoca is a working diagnosis which needs systemic evaluation.
Yes.
And you stressed the importance of the latest investigations, cardiac MRI, intravascular ultrasound, OCT, etc.
Yes,
Thank
sir.
you, madam. Any
Thank you,
questions
sir.
from the floor? Then
Thank
we will
you.
wind up the session. Next.
Thank you, ma'am, for the enlightening talk. I request our moderator. Thank you, ma'am. Thank you, sir. Before we move on to the next lecture, there's a notification for the postgraduates competing for the PG quiz session. Kindly assemble in the dining area for the preliminary sessions. We have 8 teams. Kindly assemble in the dining area for the preliminary session. We have the second speaker, the topic being updates on coronary CT angiography and calcium score in assessing disease severity. For that, we welcome Dr. John Roberts, sir. Over to the moderator.
So, Dr. John Robert is a consultant interventional radiologist from Madurai, and he performed the highest number of mechanical thrombectomies in Madurai last 8 years. Pioneer of microwave ablation of HCC in Madurai, high volume operator in trace procedures. He initiated prostate artery embolization program, and he published many papers in the Indian Journal of Urology, and he is a contributor of practical neurology, and his areas of interest are thrombectomy, embolization, and oncology. Over to you, sir.
Thank you, sir. Thank you for the introduction, sir. So by the time we are getting our PPT up, for those of you who are wondering why I'm wearing an apron in the afternoon session post lunch, this was pressed by my wife, so it has to be worn till I finish my presentation. So we'll talk about recent advances in coronary CT. Like how many, before the PPT gets a show of hands, how many of you routinely prescribe coronary CTs? Very good. So only 1% in the audience is regularly prescribing coronary CT. And what about the rest? Is there any reasons why you are not towards coronary CTs? I know all of us are, many of you will be cardiologists, so you prefer invasive angiography. Agreed. I'm an interventional radiologist. I don't go through peripheral angios for my below knee angioplasty. Before starting it, let me give my disclaimer. I've been doing peripheral plasties for the last 15 years from 2011. So any artery which is less than 3 mm, my diagnostic rule is I can't measure the artery properly. So I don't trust my peripheral angiogram images even if it is I who has reported that particular image. So I can totally understand if you're not into coronary CT, but the entire aspect of it, yeah, our PPT is up actually. So the entire aspect of coronary CT is any vessel which is going to be less than 2 mm or 3 mm, it's going to be difficult for a scanner to pick up what exactly is happening in the artery. That holds true for our anterior tibial arteries, posterior tibial arteries. It also holds true for our coronary arteries. So the recent advances are towards identifying how these coronary arteries can be identified. It's a 20-minute talk, so I thought like let's talk about like 10 important recent advances. Again, these are not recent advances in the sense of this is being going to come into vogue in the next 5 years, 10 years. No, it's not like that. This is something which is being practiced day in and day out in any particular center which has a cardiac CT, except for maybe the photon counting CT. Photon counting CT, that is the only one center in India which is doing it, Reliance Center. It is in Mumbai. The cost of the machine is going to be 25 crores. Because of that, that is the only particular recent advances which will not be available for many of you guys. Remaining 9 things which has been listed in this particular slide is something that you can ask for to your radiologist, and that is something which is available at your footsteps. So before going into all this mind-boggling terms of what is photon counting CT, fractional flow reserve CT in CT, Madam was talking about how we calculate FFR in angiograms. I'm going to talk about how FFR CT is going to be done in a CT machine. What is cataract score? What is high-risk plaque imaging? And cardiovascular biomarkers. The age-old decades above, we have been always calculating calcium score. You calculate the calcium score, you will be able to tell whether the patient is going to need a statin therapy or aspirin therapy. Now we have better cardiovascular biomarkers such as perivascular fat inflammation, epicardial adipose tissue, few obesity markers also in imaging which we will be seeing. Apart from that, we have extracellular volume imaging and AN plaque detection and risk detection. Let's go through each and everything. First thing is photon counting CT. So the conventional CT, if you see, yeah, it's going very well. So do I have a marker? Yeah. Can we have the lights off? Actually, I don't think the marker's projecting. Yeah, if you see in the conventional CT, why the resolution was very poor is, here we are able to see that X-ray is going to get converted into light, and after that it is going for interpretation of images. Whereas in photon counting CT, what happens is, the X-ray is directly converted to an electric signal. So that particular step is outdated right now. Because of that, the resolution is better. How good is the better? Let's see. This is in canine models in which they have shown. Let's go to the human models itself. This is how a normal coronary CT is there. This is why many of us do not trust our CT images, because we get such a blurred image in which this is the calcium and this is the normal lumen of the coronary artery. Now to calculate the stenosis in this particular segment is going to be very difficult for us. But when we have a photon counting CT, here we are able to see that the calcium plaque is very clear. And the lumen is also very clear. So here we are able to see nearly 50% of the lesion is having, there is a 50% stenosis. So because of this, the coronary CT is becoming more interpretable and easy for us. To summarize about photon counting CT, what we need to take home is, the resolution has come down to 0.2 mm. When I started, I told anything more than 1 or 2 mm, the CT is not just coronary CTs, any other part of the artery is not going to be very clearly defined. This is one thing in which they promised that it's going to be 0.2 mm, and we saw the proof of the same. Heavily calcified arteries, the thumb rule, if the calcium score is more than 400, don't go for a coronary CT. That is the thumb rule. In my department, I say, calculate the calcium score, that gets done within a minute. And if it is 0, well and good, stop the study until you are suspecting a soft tissue plaque. And if it is more than 400, again abandon the study, because in heavily calcified arteries, it becomes very difficult for us to make a sensible decision. Post-tent evaluation and complex CAD. So these are the things in which we will be able to see in a case of a photon counting CT. The only center which is having right now in India is going to be Mumbai. The second thing is going to be fractional flow reserve CT. So the question is, do we really need an FFR? In low risk patients, low risk anatomical stenosis, you don't need, because it's going to be less than 30%. High risk stenosis, completely occluded, that is really not a point of FFRC. The only groups in which we need is intermediate risk anatomy, which is between the low risk and high risk. So in this, we have an algorithm in which CT, madam told different numbers, but we have a thumb rule of 0.8 and 0.75. If it is more than 0.8, then we assume that the intermediate stenosis is not going to cause any functional narrowing in that particular artery. That is, the blood flow is going to be good distally. Let's see it with a couple of examples. For example, there is a stenosis here. Now the million-dollar question is, do I stent it, or is it a significant stenosis? So when we do a CT, already we have these kinds of images which is circulating around. Now when we upload this particular images into a software, we will be able to tell distal to this particular stenosis, what is the amount of blood which is going. So if it is more than 0.85, it doesn't matter. But if it is less than 0.75, it means that it is not just a stenosis, it is causing a reduction in blood flow distal to the stenosis. So it is not just about stenosis mapping, it is also about the blood flow which is going through it. So there are 3 stenosis which we are able to see, 3 calcified plaques. The question again, what is actually happening to the blood flow which is distal, which can be calculated even in a CT, which is a non-invasive way in which we do the fractional flow reserve which is going to the distal part of the thing. So this is a summary of it. Remember these values, 0.8 and 0.75. And yeah, the thumb rule, the only thing that I need you to understand is it's not just an array, it also tells us about the exact blood flow through that particular artery. How is it done? For most of you who are refusing to believe that the FFRCT can be done, there are 4 important parameters we take. One thing is the angle of incination, the angle in which the blood flow is going through that particular stenosis, which is called the alpha angle, the luminal diameter, the distance of the entire hill area. All these things are put in a computational flow diametrics model to tell us whether that particular blood flow is going to be correct or not. So what is the accuracy when compared to an invasive FFR? It is going to be more than 80%. There are various articles. You can go through this particular article for further references. And the measurement is supposed to be 2 centimeter distal to the stenosis to identify the exact amount of FFRCT which is occurring at that LAD. So it's a non-invasive way. Coming to the third recent advances, cataracts in coronary CT. So again, another thing is whenever you're getting a CT report, when I talk to my cardiologists, they always keep saying, John, you 50% கொடுத்திருக்கீங்க, உங்களுக்கு 70% வருது. நீங்க 80% கொடுத்தா உங்களுக்கு 100% வருது. Always try to understand when we are reporting, we report in 2 particular ways. Most of us tend to report in this particular thing, that is diameter. If the diameter is 50%, the cross-sectional area is going to be even further lower down. It's going to be 75%. So most of the radiologists, including me, we try to report the stenosis in case of diameters rather than cross-sectional area. If you specifically ask for cross-sectional area, yes, it can be done. Here we are able to see the same thing can be shown in a cross-sectional area. But try to understand why we do not do it in a cross-sectional areas, because here the entire length is seen. So because of that, most of your coronary CT reports will be having a diameter area reduction rather than a cross-sectional area reduction. So when you interpret it in a higher degree, so that both of us are looking at the same numbers. So a single page summary of what we spoke about cataracts is, yeah, 0, 1. Now we have started giving numbers, like in everything in your imaging is going to be objective. You talk about malignancy, you talk about breast, you talk about prostate, you talk about anything, you are going to give in numbers. So anything which is less than cataracts 2 is going to be benign for the patient, 5 is going to be total occlusion, 4 is going to be intermediate. Coming to the fourth important recent advances, which is high risk plaque imaging. The question is not about whether there is a plaque. The question is about whether the plaque is going to rupture, whether this can be computed in CT. For example, normally when you see a CT report, this is what we report. We report fatty plaque, soft tissue plaque, whether there is calcium. Heavily calcified, we call it a plaque. If there is no calcium, we call it a non-calcified plaque. And if areas of calcium, we call it as a mixed plaque. So we have started moving from just a plaque imaging to high risk plaque imaging. Before seeing what is high risk plaque imaging, let me show you this particular slide. There are 4 important features in CT, which is posterior remodeling, a lipid core, a napkin rim sign, and spotty calcification. For example, in the conventional imaging, if you see 2 specks of calcium in a coronary artery, we will report it as less than 10%. But according to high risk plaque imaging, if we see these 2 calcium specks, it means that this patient is having a dystrophic calcification, which is leading to an inflammation which is occurring in the artery. So according to high-risk plaque imaging, even 2 specks of calcium which is seen in the calcified plaque can rupture later. So how does these images look? Just for you to see. So this is how your posterior remodeling will look. It will be just a slight bulge outside the artery. Low attenuation plaque, if you see, it is more blackish. Lipid is going to be more black. So you see a more black plaque, it is going to be a lipid-rich plaque. You see such small, tiny specks, it's a spotty calcium. You see a napkin rim sign where you see a cross-sectional area which is more than 50% involved. Then if you see any of these 4 kinds of plaque in your CT report, then it is going to be a high-risk plaque. Even if the stenosis is going to be less than 50%, these are the plaques which are going to rupture. This is a better image to show the posterior remodeling. You can see this particular wall is straightforward. On the contrary, the other wall is going to show an elevation, which is because of the posterior remodeling. The cutoff is going to be 1.5. So let's move to the 5th one. Yeah, calcium score is something that all of us are clear about. So just to summarize about calcium score before going to the other recent biomarkers. Calcium score more than 400 is going to be severe, 0 is going to be no calcium, and between 1 to 99 is mild, and 100 to 400 is going to be moderate. The limitations of calcium score are more important. For example, if the plaque is going to have calcium, you are going to pick it up. If it is going to be a soft tissue plaque, you are not going to pick it up. You are going to assume this patient is having a calcium score of 0, is not going to have any ischemic risk disease, but this patient might have a soft tissue plaque. Second thing is it cannot assess severity, and some of these patients, last month I opened up 3 MCAs, all of them were between the age of 30 to 35. None of them had calcified plaques, at least in the brain. So the same thing holds true for even coronaries. So recently we are seeing more and more of lipid-rich plaques, ICADs in our population. So calcium score of 0 doesn't give us a reassurance that the patient is going to be quite safe. How is it calculated? So this is minimal, moderate and severe. It is extensively calcified. We have an objective criteria. Once it is calcified, we put the HU. If it is more than 130 HU, we take that particular thing and we multiply it by the square meter. I'll just give you an example of how it's done. For example, here the calcium plaques area is 15 millimeter square. We can calculate it in CT. The attenuation, which is going to be 450. We are going to multiply both of it, and the value which we give 60, which is a product of the attenuation HU, and the area is going to be the final calcium score. I'm not going to how calcium score is going to help in statin and aspirin therapy. You're well versed with it. But what is the recent advances in calcium scoring? So from calcium scoring, again we have started moving to recent biovascular markers. So what are the recent cardiovascular markers we have? One is perivascular fat attenuation index, epicardial adipose tissue, high-risk plaque imaging, which was already talked about, and myocardial CT markers. Let's see what these things are. What is perivascular fat inflammation? So basically there is a coronary artery. Right now we are more worried about what is happening into the coronary artery, what is happening in the lumen, what is happening in the wall. Perivascular fat inflammation is going to talk about what is going to happen in the fat which is surrounding the coronary artery. If there is an inflammation, that means that the artery is under stress. So how are we able to see it in CT? The attenuation value is going to move towards -30. So we have two cutoffs. If the attenuation value of the fat is more -30, it means the fat which is around the coronary artery is an inflamed fat. So even if the coronary artery looks normal, it is a artery which is having inflammation going on within it. So what is the reason for it? I don't want to bore you with it. Lots of leptins and all those theories comes into play. Let's see how we calculate in CT. So for example, this is the RCA, this is the LAD. So this entire green area is the area, and we are going to stretch it out, and we are going to give the score from -190 to -30. More towards -30, it is going to be an inflamed fat. So this is a CT image. Here you are able to see the more yellow thing means it's a benign thing. The more brownish, it is going to be an inflamed fat. So this particular thing can be done in CT right now. Again, another image in which all the three arteries, RCA, LAD, LCX, wherever it is red, it means that the fat around the coronary is inflamed. That is fat attenuation index. This is a summary, just one take home point. This is a summary slide of it. -30 means an inflamed fat, -190 is a normal fat. Coming to the seventh reason advances, it is epicardial adipose tissue. So let me clarify few terminologies. What is pericardial fat, paracardial fat, epicardial fat, perivascular adipose tissue, non-perivascular adipose tissue? These are basically adipose tissues which are around the heart. So this was basically for radiologists. So bear with me when I am trying to differentiate between the pericardial fat and paracardial fat. In CT, what we are able to see is a pericardium. This white line you are able to see, right? This is the pericardium. Any fat which is going to be within it is going to be called the epicardial fat. The fat which is going to be outside it is going to be called the paracardial fat. What we are seeing in purple here is the paracardial fat. What we are going to see within the pericardium, green, is the epicardial fat. Now what is pericardial fat? Again, the same thing is shown in MRI. Here we are able to see the pericardium very beautifully. This black line which we are able to see, right? That is the pericardium. In MRI, we will be able to see it even much more clearly. So the fat which is within it is the epicardial fat. Fat outside is going to be pericardial fat. The sum of these two fats are going to be called the pericardial fat in imaging. So what is the importance of it? We are least bothered about pericardial fat. However, fat deposition is there in the pericardial area, it doesn't matter to the person at all. But if the epicardial fat is increased, it directly is going to reflect on the obesity and biomarkers and metabolism of that particular person. Let's see how it is. So I think the same epicardial adipose tissue can be calculated in echo also. This is how we do it in CT. Again, the pericardium and this particular area which is dotted in yellow, and this is in MRI. So this is important. So epicardial fat tissue and paracardial fat tissue, the important differentiating feature is this is a storage fat, whereas this is directly going to contribute to the metabolism and inflammation. Coming to other obesity markers, we already saw two obesity markers. One is the epicardial fat attenuation, other one was perivascular fat and epicardial adipose tissue and perivascular fat inflammation. What are the other fats? And we know that visceral fat is more important to contributing to sudden cardiac death rather than subcutaneous fat. So at the level of L3 vertebra, what we do is we calculate the amount of fat which is seen in the subcutaneous plane and the fat which is seen within the viscera. Whatever yellow is shown here is the visceral fat. Whatever red which is shown here is the visceral fat and yellow is shown here is the subcutaneous fat. However obese that patient is, if it is only the subcutaneous fat, it is not going to directly correlate with your cardiovascular events. But even if the patient is thin and the visceral fat is higher, it means that the patient is going to have a acute coronary disease and metabolic disturbances. So there are three types of adipose tissue. So what we already saw was subcutaneous fat and this is visceral fat. These are easy things. In any imager, you put it at L3 vertebral level. L3 is the point at which the patient is too stout. Take one section that's more than sufficient. The radiation dose is going to be less than an X-ray. You can calculate the entire visceral fat within a matter of minutes. Now recently intermuscular adipose tissue fat. Like I was talking to sir also, like there is an entity called sarcopenia or muscle wasting which is occurring in the bodies. So when that occurs, what happens is, this is the muscles. So between the muscle plane, water fat is going to get enlarged because of this atrophy is going to be reflected and picked up by the intermuscular adipose tissue. That can also be calculated. Again, the objective criteria for this is going to be more than 150 centimeter square and this is going to be more than 20 centimeter square. So from qualitative to quantitative data is also there as far as adipose tissue. Coming to fat quantification, we do MHCs, right, for grade 1 fatty liver, grade 2, grade 3 fatty livers. Gone are the days. Right now what we do is MRI quantification of liver, because here we are able to tell the exact percentage. There is a software which is needed for it, Dixon software, and there is no radiation involved. So here, this is a patient whom I did a couple of days back. This patient came from Trichy. This was a liver transplant donor. We wanted to know what was the exact fat deposition in his liver. For example, if had we not had this Dixon software or MR quantification, what we would have done, we would have just done a liver biopsy. We would have sent to the pathologist to ask for how much exactly is the fat. Now, since we have this MRI quantification, what we do is, we just take the particular sequence, put a range of interest, it calculates very clearly that it is 7.5%. So the exact value till the percentage of fat can be delineated with just a simple sequence. This gets done within 2 minutes and there is no radiation which is involved in it. Coming to the ninth recent advance, which is extracellular volume. So extracellular volume, like I saw a couple of speakers talking about late gadolinium enhancement and cardiac MRI, and so ECV is one thing which is going to actually contribute to your interstitial fibrosis, scar tissue and all those things put together. So if your late gadolinium enhancement is going to pick up a scar, very simple, when they ask me a cardiac MRI, there's only one indication they tell me. John, tell me whether we can revascularize this patient or not. Already the scar tissue is there. If I open it, will it be of use to a patient? Simple sequence, one sequence, put a T1, late gadolinium enhanced delayed imaging, water is white is already gone, dead. There is no point in revascularizing that tissue. Whatever is remaining is the thing which can be picked up. So that is one of the components of ECV. Other things are going to be any diffuse infiltrated disorders. Let's see what exactly it is and how we calculate it. It can be done with an CTA and it can be done with an MRI. It is the same formula, 1 minus hematocrit multiplied by the difference in myocardium and blood. Hematocrit should be taken on the day in which you are doing that CT or MRI. How do you do it? Take a non-contrast CT, then after 15 minutes take a contrast CT, add the differences between, put a marker in the myocardium and put it in the lumen between the first image and the 15-minute image. You have the formula and voila, ECV is calculated. Same in MRI. MRI, we actually go for a cardiac viability. As part of cardiac viability, we'll be doing an ECV thing where the scar tissue is more important. So remember these important things. Hematocrit should be calculated on the same day and CT and MRI should be done at an interval of 10 minutes and 15 minutes. This is a single page summary of it. What I like you to remember is the important indications, cardiomyopathies and dilated HOCMs, infiltrated disorders, amyloidosis and myocarditis. So that brings us to the end of cardiovascular risk inflammation. My last slide is going to be A and plaque and risk reduction. So A is going to just calculate all the remaining 9 recent advances, put it in a particular score. It is going to take all those things, fat attenuation index, high risk plaque imaging, your calcium score, and integrates the above marker into a single particular thing. How it does, it delineates all the coronaries which is given to it. It tries to identify which is a normal coronary, which is the one which has stent, which has myocardial bridging, which is a movement artifact, and based on it, it is going to give you an answer. So this is how it takes the EAT, PCAT, all the 4 high-risk plaque imaging which we saw, and the stenosis, whether it's going to be significant or not, without using invasive angiography. Thank you. My sincere thanks to Calvin Hospitals and Dr. Calvin sir for giving me this opportunity. This particular talk will be available in YouTube as well as in Insta. So if any of you have any doubts, you can just go through it and you can ask me any questions right now.
Thank you, sir. We learned many points regarding the recent advances in the coronary CT. Thank you. Any questions from the audience?
So FRCT is already in vogue, sir. FFRCT.
No, you have to say it's a software basis.
Yeah,
right?
it is a software basis.
How long would it take after your CT?
So there are 2 ways in which we do it. Actually, the CT can be done in any department which is doing. The only part is the computational cloud. There are 2 ways in which it is done. One is a cloud software, another is a non-cloud software. The cloud software is going to take a couple of weeks, sir. Because it's a US based software, we send it, and the cost is also proportionately higher. It is going to be around 60,000 to 70,000. The other one, which is non-cloud software, is case per case C. That is around 10,000. That takes at least 3 to 4 days, sir, actually.
And what exactly is napkin ring? What do you see in that?
Napkin ring is, can you go through the previous slides again?
Okay, just explain that.
So basically, it is the lumen volume and the napkin ring. We have a central lumen and there's a peripheral thing. The peripheral thing is the calcium and the central part is the necrotic component in it, sir. So if you have a plaque which is looking like that, that means that is a high risk plaque. That's all. So, yes, sir, please. Sir, I didn't understand the question. What is the problem in? Yes, sir. Exactly. I understand that, sir. True. So only one thing, sir, it is a negative predictive value. When someone asks for a coronary CT, we do a primary level of screening of all the forms which comes to us. For example, if the patient is having a clear-cut MI, there are many patients who are coming, they feel very scared of going to a cath lab. One of my professors came to me, he was having clear-cut signs of MI. There's really no point doing a coronary CT. When you know the answer is going to be positive, there is no point spending your time in your coronary CT getting it. So what exactly is the role? It has a negative predictive value. What does it mean? For example, I'm pretty sure this patient is going to have nothing in invasive angiogram. I take him off coronary angio. So non-obstructive, as ma'am's pointed out, actually, non-obstructive lesions can be picked up, sir, actually. But again, such entities, it's very difficult. For example, we just learned about an entity called that there is a non-obstructive coronary things. So those things will again turn out to be normal. If a patient is having dyspepsia-related chest pain, and you want to be safe before sending the patient out of your OPD, then you can ask for a coronary CT. So that is one thing. Second thing is you want a baseline biomarker. For example, you want to know what is this calcium score. There you can do it. My thumb rule is if the calcium score is more than 400, I don't report. My colleagues do. Even if it's more than 400, they do the reporting. I say when it is more than 400, I won't be able to give any sensible report. So I'll stop it at calcium score. I'm not going to do a coronary CT done actually. It has a high negative predictive value. If it is normal, most likely your coronaries are going to be normal. No need to get a invasive coronary angiogram done. If it is positive, you are going to send it to a cardiologist. Yes, sir.
The most important indication for a coronary CT is when a post-CABG patient.
Yes, sir.
And the calcium score is immaterial in a post-CABG patient when that is one of the first indication. And any patient who has undergone a CABG as per guidelines post 5 years has to have a CT coronary angiogram.
Correct.
That has to be highlighted.
The reason why it is actually, because again, anything which is in our field, we never refer to other ones. Why this post-CABG patient alone comes for coronary CTs? That is because many of these patients will have an occluded graft. Now, when I'm cannulating artery, for example, I keep on poking a renal artery, I'm keeping on poking an ATA, I'm not very sure whether it is there and I'm not able to cannulate it or it's totally occluded. So in a patient who's having a graft status, there is a high chance that these grafts will be occluded. So in such patients, when you're directly taking the patient for an invasive coronary angiogram, there is a high likely chance that you might perforate it. So in all post-CABG status, if you're not able to hook the coronary arteries, and before you label that it is occluded, it is wise to get a coronary CT done, where we can see the lima, we can see the venous graft status also, sir. Correct. I agree to it, sir. Thank you.
Thank you, sir. Thank you for the enlightening session. I now request Dr. Prince Paya, sir, to felicitate the speaker. Thank you, sir. Moving on to the next topic, Novel Insights in Cardiorenal Syndrome by Dr. Shivakumar, sir. Over to the moderator.
So, sorry, this is the medical director of Madurai Kidney Center, and is he is senior consultant nephrologist, SS Kidney Care Center, and he is a consultant nephrology in Madurai Apollo Hospital. His area of interest are preventive nephrology and renal transplant. He got gold medal award in INSNSC in 2012, and he is author of a chapter in a book of diabetes, and he organized many CMEs and speaker in many CMEs. And over to you, sir. It's a CKM syndrome.
So good evening, everyone. At the outset, I thank the organizing team of this wonderful cardio update 2026. Thanks to Dr. Calvin. A few years back, I have been in the APA as well as IMA of Norwell chapter. So this topic, that is cardiorenal syndrome, it's one of the old entity, but it is getting momentum in our day-to-day clinical practice. As a physician, as a cardiologist, as a nephrologist, so as an intensivist, then and there we are coming across these clinical settings. It's a King's clinical scenario. So the morbidity as well as the mortality of this CRS, cardiorenal syndrome, is more and more. Recently, a lot of innovations, innovative ideas and new recommendations, a few interesting drugs come and knock this area and has changed the outcome of this entity. The CRS is different from CKM. CRS is cardiorenal syndrome. CKM is cardio-kidney metabolic syndrome. So cardiorenal is it's in between the two organs. If anything, one is suffering, automatically the next organ will fall. It's a fight between like Israel and Iraq. One is a heart, another one is a kidney. Suppose in cardiac CRS1, kidney is the primary culprit. That is first 1 and 2 is the kidney, the heart is the primary culprit. CRS3 and 4, kidney is the primary culprit. The CRS5, both. It's just like a war between the Israel and Iran. The air defense system fails in tackling this issue. So automatically the affected people of the whole world are getting affected. Like that, the morbidity and mortality comes into this area. How to tackle this? So what's the relation between the heart and kidney? This man is the father of nephrology, named by Richard Bright. In 1837, he came almost for 19 cases of edematous patients. He has done autopsy. And then they have found out that 3 things they have found out. One is the urine is frothy, number 1. Number 2, in autopsy, kidneys are small. Number 3, the heart is big. In 1837. So this is the first time he has correlated the relation between the heart and kidney. CRS history, that is a cardiorenal syndrome history, in 2000, the term, this has been coined. Later on, in 2008, the first consensus definition of acute cardiac injury, how it produces AKI. And 2012, the European Society formalized a CRS classification in 2012. Now we are in a position to tackle this problem. What is the pathogenesis and other things? So we have in a better position to tackle this situation. So it's not you, it's me. So that organ is telling it's not you, it's me. So it's whether it's a kidney and heart. The CRS type 1 and 2, the primary problem is with the heart. When it is an acute heart failure due to any reasons, it affects the kidney, then it's a type 1. Type 2, it is a chronic heart failure or heart pathology that affects the kidney, then it's a type 2. So reverse, 3 and 4, it's primarily it is either acute kidney injury or chronic kidney disease. Secondarily, it affects the heart, then it is the type 3 and 4. And type 5 is primarily both organ is having a problem, pathogenesis, and that results in the both organ failure. So why this classification is important? Because the pathogenesis, the mechanisms is different in each. So the pathways are different, mediators are different, molecules are different. So drugs which acts at those pathways, right now we are having at our hand. That's the way it is. So what's the prevalence, what's the incidence of this entity? CKD we know, almost 1 in 10 adults they are having CKD. Heart failure we know that the number 1 cause of death in the world is congestive cardiac failure. So the two entities are a non-infectious entities, metabolic disease producing these entities. Now the world is the non-metabolic diseases like diabetes and hypertension is almost a pandemic. India is the capital of the diabetic capital of the world, hypertensive capital of the world, slowly CKD capital of the world, CCF capital of the world. So it's like that. So almost I can say that it's a 30% disease. Almost 30% of the CKD at one point of time they are having the heart failure. Reverse, as a cardiologist, probably Calvin and other cardiologists, they would have seen their cases, the primary cardiac problem they may have creatinine around 1.4, 1.7, 2, 2.5. Many a times, 30% of their cases. So this is where this entity comes in. You know, normal creatinine value is 1.2, am I right? But creatinine is a late marker of renal dysfunction. Anyone is having a rise in serum creatinine more than 1.2, that means 50% of the nephrons already lost its function, either temporarily or permanently. Anybody's creatinine is 1.4, that means 50% of the nephrons has lost its function, either temporarily or permanently. Suppose the serum creatinine is 2, that means what? Anybody's creatinine is more than 2. So how many percentage of nephrons lost its function? 75% of the nephrons lost its function. So creatinine, whatever we are doing in a clinical practice, is a late marker of renal failure, renal dysfunction. So this is the problem of this entity. It's a very much vulnerable subset of population. This is both for morbidity as well as mortality, number 1. Number 2, this CRS population is having a very limited clinical studies. Throughout the world, you take either from any corner, intensivist corner or cardiologist or from a nephrologist, we have a very limited clinical evidences of the drug, whether it acts or not, very limited evidences. So how to approach this problem? So if any patient with a heart failure patient may get hospitalized or rehospitalized, okay? So then the acute decompensated heart failure, then subsequently kidneys are getting involved, and the patient may have this issue, mortality, or patient succeeded, decongestion properly done, then again patient went home, again it's cycle. It's just every once in 6 months, once in a year, or once in 2 years. So quite often it's happening. This is the cycle of cardiorenal syndrome. So what is the pathogenesis of this particular entity? Any organ is getting affected. The first one is hemodynamic impairment. There is a decreased CO, as well as increased CVP, increased extra volume, intravascular volume overload, as well as the RAS activation and sympathetic nervous system activation, and everywhere this is a unified thesis, okay, starting from atherosclerosis and through the diabetes, the many pathogenesis of many clinical entities. That is the final one. This one, that is the unifying hypothesis, that is the inflammation. Quite a number of molecules, as well as the VEGF, angiotensin system impairment, everything comes into play. So it's a common one. This diagram will show you that this time that heart failure it occurs. So primarily we thought that when we have studied our MBBS as well as in the MD post graduations in 2005 till 2005, the reason for kidney injury in acute heart failure is decreased cardiac output. Am I right? But the current understanding totally changed. The primary driver is, it's not a low cardiac output, it is a decreased renal filtration is due to the congestion. It is a venous pressure. That is the key driver in this situation. So why we have to understand that? So how this increased venous pressure produces renal failure? So it's a backlog, just like your car is moving in the road, there is a traffic, so quite a number of vehicles were standing one after another, and it's a backlog. Like that, there is a venous congestion, and there is increased CVP, central venous pressure. Automatically it is getting into the capillaries of the nephron, the functional unit of the kidneys, and then slowly the tubular pressure, glomerular pressure increases. That's slowly it is getting into and it's knocked the glomerulus, both tubules as well as the glomerulus. That reduces the single nephron GFR. So this is the basic pathology. So understanding this one, why it is important. So the increased central venous pressure directly impairs the glomerular filtration rate by reducing the transglomerular pressure gradient, acting as an independent predictor of mortality. This has been proven now. This is the latest understanding, recent insight as far as the cardiorenal syndrome is concerned. So clinically, how do we know? That is central venous pressure. We know if it is more than 8. If it is around 10, then it is significant in this clinical setting. Like that, IAP, that is if it is more than 12 millimeter, it's recognized as a primary villain, primary driver of this clinical entity. So the management, so what? There are two pillars. One is, that is the decongestion, as far as the CRS1 is concerned. Okay, number 2 is, next one, that is the GDMT, guideline mediated medical therapy. What is GDMT? It is ABCD. A for either AC inhibitor or ARB, number 1. B for beta blocker. C for, put it as C for S, SGLT2 inhibitors. D for aldosterone antagonist. Okay, these are the 4 pillars of the this guideline directed medical therapy, GDMT. That's the one. These are the 2 pillars. One is decongestive therapy, another one is the GDMT. Coming to the decongestion, first, before starting the decongestion, first ensure the hemodynamic optimization, ensure the adequate blood pressure and cardiac output, use vasodilators, and if necessary, you can go for inotropes. And diuretic therapy, you know what we are doing that is furosemide or torsemide we are using, intravenous dose, whether it has to be used as intravenous or oral. In acute clinical settings, automatically intravenous. And then the next question is whether it's a bolus or infusion. Next one, whether it is a torsemide or furosemide. So these are the questions I will explain one after another. So avoid nephrotoxins and monitor the urine output, serum creatinine, electrolytes, hemoglobin, and other things. Just skipping. So the goal is to relieve the congestion, at the same time minimizing the renal issues. How to relieve the congestion? The first one is the loop diuretics. That's the golden one. We every day, every people we are doing here. And SGLT2 inhibitors, to some certain extent it helps. And then nitroprusside. So congestion with the volume overload, loop diuretic, if it is there, starting dose is around 20 to 40, or intravenously you can use. Already patient is on 20 to 40 milligram of furosemide as a OP outpatient, then you have to double the dose in the intravenous. So you have to repeat it once an hour. You have to evaluate the response. You are giving the furosemide, then what the recommendation says, after 2 hours, you do a urine sodium analysis. Sodium analysis, okay? If it is significant, then then your drugs is working, there is no need to increase the dose. Or you have to go for a urine output. Clinically, if it is after 6 hours, then you have to assess the urine output. If it is around 0.5 ml, for example, 60 milligram, 60 kg individual adult, then you have to expect around 30 to 40 ml per hour. That is 0.5 ml per kg per hour. So patient after 6 hours, it should be around 40 ml per hour into 6 hours, it should be around 200 to 250 ml. So that means the patient is responding to your diuretic, Lasix or furosemide. So this is what if it's not no response, you have to double the IV loop diuretics and assess within the 6 hours. The urine sodium, what it means, if it is less than 50 to 70 milliequivalents per liter, then that's not responding. Your diuretic is not working. Like that, if the less than 100 ml per hourly diuresis is not occurring, then the drug is not working. So strategies, at the time of strategies, you really congestion without worsening the renal function, IV loop diuretics, monitor the output, adjust the dose, and if it is not there, next you have to go for the second, the diuretic, thiazide or ultrafiltration. Then daily you have to monitor for daily weight, JVP, edema, breath sounds, renal function, electrolytes, hemodynamics. So this is what it has to be done. So which one is better, furosemide or torsemide? Any takers? Any clinical experience? Furosemide, as far as intravenous is concerned, mostly we are using furosemide only. Torsemide is not much available, but the clinical evidence says that there is no difference between the torsemide and furosemide. Even though torsemide, the half-life is more, and then its availability, oral bioavailability is better, but as far as acute setting is concerned, it's intravenous furosemide. As an outpatient, you are discharging the patient on the 7th day or 10th day, then automatically the torsemide is better than furosemide. So there is no difference. See the primary outcome, all-cause mortality, there is no difference between the torsemide or furosemide. The dose equivalent, it may be 1:2 or 1:4. So depends upon the situation you decide. There are some reasons where you have to increase the dosage of either of this molecule, depends upon the situations. Patients with the liver disease, patient along with the renal failure, then in such situations you have to increase the dosage of this one. So this is a thing that is above is a conversion already told, that is a 1:4 or 1:2. Just I am skipping few things, few slides. So bolus or infusion. So many a time in my clinical experience, my own experience, most of the time I am going for a infusion. That is either by pump or by the hourly impulses I am giving. For example, 40 milligram I am taking, or 60 or 80 milligram. For example, 4 cc of Lasix plus 6 cc of normal saline, make it as a 10 ml, every hour 1 ml or 2 ml. See, my clinical practice in small setup, I am using such things. So I am attached to my small station, and also in Madurai Kidney Center big station, and also in Apollo. So there is, in Apollo there is no problem, pump, it is pump, we are using pump, just 6 milligram, we are using it. In my small station, old station, I am taking a 4 cc or 6 cc of Lasix, make it as a 10 ml, just with a 10 ml syringe, and ask the sisters to give either 1 ml or 2 ml, and put a Foley's catheter, and every hour you measure the output and then go for it. These are the small things, trick of the trade, we can able to do it. So next one, there is no response, diuretic resistance. Then here there is one clinical insight. Look for the chloride, that is sodium, potassium, chloride bicarb, usually electrolyte panel will have. This chloride, normal value is 105, we know. If it is a hyperchloremia, then it's a critical marker for a diuretic resistance. This is under your insight. So another one, clinical bedside information. So there is a resistance. Next you go for a sequential nephron blockade. So what is it? The strategies to counter this diuretic response, there are many strategies. The most proven is this one, that is a sequential nephron block. So we know that there are some molecules are acted at this level, some are at the tail, that is thick ascending limb, some are at the descending limb. So when you are combining 1 plus 2 plus 3, this is called sequential nephronal blockade. So one such drug is thiazide. This is a thiazide-like diuretic. Okay, this acts at the level of DCT. What is the mechanism? So when you are using a furosemide or torsemide, what happens? There is this, it acts at the level of TAL, that is thick ascending limb. It blocks the receptor, so there is an increased secretion of the non-absorption of the sodium, and then the distal delivery of the sodium is more and more. Okay, so when the distal tubules are getting more amount of this sodium, so it acts more. At one point of time, it is called breaking phenomena. So where it absorbs more amount of the DCT acts automatically. So it is intrinsic way, it is acting and it reabsorbs more and more sodium and other things. If you are blocking that particular part, DCT, with the help of thiazide-like diuretics, it's called sequential blockade. So it's very useful tool. Just adding 2.5 to 5 milligram, that's it. Then automatically you will give more amount of diuresis. So another one is MRA. MRA means it's a mineralocorticoid receptor antagonist. Still more distal. It's a potassium sparing diuretic. So you can use amyloidoid, or it can be a spironolactone, then you can use it. So either it can be a double or triple therapy. So breaking phenomena, you are discharging a patient with a furosemide 40 milligram or torsemide 20 milligram. After 3 months or 6 months, patient is not responding to your diuretic dose. This is called breaking phenomena. The reason is what I have told recently, just now. So the way to counter it is, that is just use a molecule which acts at the DCT or at the collecting tubule as a thiazide-like diuretic or thiazide or MRA. So other markers, NGAL and other things. Here cystatin C is another one important molecule. It's a yearly marker than serum creatinine. Why it is not picking up in our clinical settings, I don't know. The reason, probably the cost of the cystatin C is around 700,000 in some areas, and also the calibration of this cystatin C is also, it's a little more cumbersome. That's the reason why it's not picking up. I have done a cystatin C study in immediate post-renal transplant settings. It's a yearly marker than a serum creatinine. So in a cardiac setting, in a cardiac ICU setting, cystatin C doing, if possible, so definitely it pick up yearly than a serum creatinine. So nothing works. So the aim is decongestion. So far I'm discussing about the decongestion. So still we couldn't able to open up. So what the next one is? Ultrafiltration. Many a times in our settings, both in Apollo ICU as well as in my own Madurai Kidney Center, we have done even for a creatinine 2 with a ejection fraction 30 and other things. So ultrafiltration, many a times it helps to tide over the crisis. After 1 or 2 hemodialysis, we can pull out the patient from that incident and then we can give a life to them. So the ultrafiltration can be done by a machine, that is isolated ultrafiltration, we can set it, or I can take a kidney, artificial kidney outside, and without giving a effluent, that is the dialysis fluid, just with the help of the machine, I can remove the excess fluid alone. So visually we can see how much fluid we can take it from the dialysis, artificial dialysis. So we can remove the fluid alone. But remember, the accuretics are not useful. Tolvaptan is not much useful as far as CRS is concerned. Why? So now so far we are discussing about furosemide, torsemide and then other things. But accuretics like Vaptans, is it useful in CRS? It's not much useful because it concerns only with the water. But here the problem is sodium avidity. CRS is a state of sodium avidity. The body is having more amount of sodium. So just removing fluid is not enough. It's not a water disturbance. It's more than water, it is sodium. So that's the most important thing you have to understand. We can add, it can be add-on therapy, but it's not like it's a pillar therapy, okay? So just I'm skipping few things. That is, if you are getting admitted hospital admission, avoid congestion, reduce congestion by various means, and you start the GDMT therapy at the 3rd day or 4th day. So coming into the second pillar, GDMT, and then you have to up titrate and send the patient. So here another one clinical thing I want to say. Already told, that is angiotensin receptor, that is beta blockers, and then sodium gluconate, and then ABCD I have told you. So when to start? Your admission day is start with the RAS and RNA. Next is beta blocker, next is MRA, the last one is SGLT2 inhibitor, and then you slowly titrate and then do it. It's a simultaneously, it's a rapid introduction of the one drug after another drug. So don't hesitate, don't delay the start of these 4 drugs. That's another one insight, recent insight. So when you are using all this drug, so estimated to reduce the mortality by 73% and prolong the life of a 70-year-old individual by 5 years. This is a GDMT therapy. This is the insight. So as a physician, so take home message, probably you use all these ABCD drugs in acute CR. That is. So just I'm skipping the few things. So the benefits, we are using only AC inhibitors. This is the hazard ratio. When you are using ARB plus B and then RNA plus B, this is like that. ACE, beta blocker, 3 drugs, it will be like that. When you are using all the 4 drugs, then only the hazard ratio is more. So it completely revolutionized the therapeutic approach of the patient. Coming to the SGLT2 inhibitors, you know all the studies. There are 3 drugs are there, CDE, that is a canagliflozin, dapagliflozin, empagliflozin. Okay. See the canagliflozin, Credence trial, DAPA-CKD, as a nephrologist I am telling, E for EMPA kidney trial. So many trials are there, but the interesting thing about this, all these trials are, okay, all the trials have prematurely terminated. For example, study period is 2 years. All these studies are terminated in 1.5 years. 1 year. Why? Because the arm with the glyphosines are having an overwhelming clinical evidence for saving their lives. So the study group, the non-study group, they want to pass the benefit of the glyphosine to the placebo group. So this is the one area where the most of the studies concerned with the SGLT2 inhibitors are prematurely terminated. So just I am skipping. Coming to the last one slide, that is a non-steroidal mRNA, MRA, that is a mineralocortical receptor. The latest drug included after, that is spironolactone, later on eplerenone. Now we are having a finrenone. The cost of the drug is almost 100 rupees per day. Okay, finrenone is a non-steroidal. What is the advantage? Because this molecule will not getting into the nucleus. It's a non-steroidal. So it activates the receptors and produces effect without producing hyperkalemia, gynecomastia. Permissive hypercreatinemia in heart failure is accepted one. So even slight rise in the creatinine in a CRS is acceptable one. You much give more importance to the decongestion and then you continue that thing. So with this, the therapy has 2 pillars. One is decongestion, another is the GDMT therapy. So congestion, decongestion is the most important thing. You go for it. Even the permissible hypercreatinemia is acceptable one. With this, I conclude my talk. Thanks for patient listening.
Yes, sir, your nice talk on this CRS syndromes. Now we know that these 2 are interconnected and they are not isolated entities, and the treating one will protect the other. Thank you, sir. Any question from the floor?
So maintaining hemodynamic stability by any means, the basic of managing CRS patients. My slide putting using dopamine or dobutamine or with the help of this vasopressin, maintaining the hemodynamic stability is the paramount importance.
Post-glomerular capillary vasoconstriction, it may increase vasopressin, may improve the output.
Yes, sir.
Post-glomerular vasoconstriction.
Even the assisted devices are available by the help of Madhavan Mani has taken some, that is the intra-aortic balloon pumping and other things. So these are all again, these are all the recent innovations by the cardiologists They are changing the outcome of this CRS type 1 in the coronary units. So that thing I have not touched because it's a purview of the cardiologist.
Thank you, sir. Thank you for the elaborate lecture. I now request the moderator and Dr. Calvin David Singh, sir, to felicitate the speaker. Thank you, sir. Moving on to the last lecture for the session 4, Heart Failure with Preserved Ejection Fraction, Current Management by Dr. Venkatesh, sir. Over to the moderator.
Dr. Venkatesh needs no introduction to this audience. He is our son of the soil. He is a senior consultant and interventional cardiologist, and currently he is working in Catherine Booth Hospital and Vasantham Healthcare Center, Nagarkoil. He did more than 4,500 cardiac catheterization procedures, and he performed 1,300 PTCA as primary operator, and he has completed over 600 balloon mitral valvuloplasties, and he has done over 1,200 cardiac catheterization for congenital heart diseases. Over to you, sir.
From Professor Ravi Edwin, sir, because of a last minute thing is not able to come. So, and the replacement speaker for Professor Ravi Edwin, sir. So, with this, I'll start my thanks, Dr. Calvin Hospital Management for giving me this opportunity. So, heart failure with preserved ejection fraction. So, earlier terminologies like diastolic heart failure has now become obsolete. Now it's been called as either preserved ejection fraction or a mid-range ejection fraction. So, the current management strategies. So we need some definition for heart failure. Once when we have defined what is heart failure, we want to classify it. We have to stage the heart failure and diagnose once when we have a heart failure as reduced ejection fraction or preserved ejection fraction. And once when you have ruled out reduced ejection fraction, we want to know the management. So I'm not going into the pathophysiology or hemodynamics, but being given the topic as management, so I will substantiate my talk with some few trials and guidelines. So any patient with heart failure should have some symptoms or signs of heart failure, either structural or functional. Along with that, there should be some evidences like elevated natriuretic peptide or objective evidences of a pulmonary or systemic congestion. So this slide gives us a clear view about what is heart failure, what is definition. So I told initially about the definition. There are some few stages, whether the patient is at risk for heart failure, it's a pre-heart failure, or it's an advanced heart failure. Most important thing is the classifications. Once when you have made a diagnosis of heart failure, ruled out non-cardiac causes, then we want to know whether the ejection. So echocardiogram has now become a part and parcel tool of any clinical medicine. It's no more being considered as an additional tool. So to diagnose heart failure with preserved ejection fraction, we want to have a basic echocardiographic tool. So once we have classified whether it is a reduced ejection fraction, mid-range ejection fraction, preserved ejection fraction. So these two both go hand to hand because we want to know that whether the ejection fraction improves from 40% to 50%, then we call it as improved ejection fraction. So with this, I'll go in more detail about how to evaluate, manage heart failure. So whenever we say heart failure, it means that the LV end diastolic pressures have increased. It means that the systolic function is normal, the diastolic pressures have been elevated. So how are we going to non-invasively measure a left ventricular end diastolic pressure? It is by an additional tool apart from the early diastolic filling velocity of the mitral valve as well as from the tissue Doppler. So when I have an echocardiographic report with a tissue Doppler stating that more than 15, we know that now the patient is in diastolic heart failure, and now it is being called as preserved ejection fraction heart failure. So in addition to it, we want to know about the left atrial size, left atrial volume, as well as the LV mass. So any complete echocardiogram with the normal ejection fraction to rule out a reduced preserved ejection fraction or a mid-range ejection fraction should have a left atrial size, a left atrial volume, a left atrial volume index to the body surface area, as well as a LA strain. LA strain has been recently included in the new echocardiographic guidelines for management of preserved ejection fraction. So once when you have put in a diagnosis of heart failure with preserved ejection fraction, there are a lot of scores. Like, atrial fibrillation, we talk about charts to VAS score. We also have a couple of scores. One is from the American Heart Association, other is from the European Society of Cardiology. So we have a H2 FPUF score as well as HFA PUF score. So these tools guides us, in what stage of heart failure are we dealing with some sort of a heart failure which is going to improve. So we just go into few details about what this mnemonic stands for. So we have a body mass index of more than 30, the score point goes to 2. On 2 antihypertensives, again the point goes up. Atrial fibrillation points is 3. Pulmonary artery hypertension, echocardiographic TR velocity is more than 2.8 meters per second, then have 1 point. Elderly patients more than 60 years in men, 65 in women, again 1 point. Filling pressures more than 9, it's actually more than 8 to 15 is borderline. Anything more than 9 is considered with 1 point as per this European Society of Cardiology's FPUP score. So more than 6, we know that, the score more than 6, we know that it is going to be a preserved ejection fraction. So the other score is from the American Heart Association. So this mnemonic stands as pre-test assessment, echo and natriuretic peptide score, functional testing in case of uncertainty, and final etiology. So here, just look at the right hand side here. We are talking about a lot of numbers here. What is more important here? EA velocity more than 15. Anything somewhere between 9 to 14 is being considered with 1 point. And now we have the left atrial volume index to the body surface area, left ventricular myocardial mass, then we have the relative wall thickness. I'll be going to explain the next few slides about these 3 parameters. And that is why it is more important because we have included echocardiogram apart from the blood markers like natriuretic peptide score also here. So once this is done, then we have, like how we do an exercise stress test, we also have something called as a echocardiographic stress test, where we have a diastolic stress test in specific, where a proportionate increase in the E velocity along with the EA velocity. If one goes up and one goes down, then we know that the ratio goes down. We know that the diastolic heart failure is present. Then finally we have the imaging here, which it's not a part of the usual assessment, but when we have something like cardiomyopathies, we are talking about some sort of infiltrative cardiomyopathies, then we do it. So what are the risk factors with heart failure, preserved ejection fraction, advanced age group, overweight, obesity, metabolic syndromes with along with diabetes, physical inactivity, deconditioning, arterial hypertension, atrial fibrillation, and other atrial arrhythmia, other atrial or ventricular arrhythmias. So this slide keeps repeating at least 3 times in the subsequent slide. The reason behind this, we have the major criteria as well as the minor criteria. Any major criteria with more than 2 points, and then it falls into the category of heart failure with preserved ejection fraction. So I just want to go through 1 or 2 things here. That is, the tricuspid regurgitation velocity of more than 2.8 meters per second. Here, anything left atrial absolute number more than 40. Sometimes if we, in an echocardiographer, might not put the body weight and all those. Anything more than 40 ml is considered a large LA volume. NT-proBNP with atrial fibrillation, without atrial fibrillation. Anything more than 400. We keep it something like that, is considered an elevated NT-proBNP. For sinus rhythm, probably a little less. For atrial fibrillation is more than 660. So with this major criteria, we have some few minor criteria. When it falls into the borderline between 9 to 14, somewhere between 30 to 40, somewhere between 120 to 125 to 200. So these are the few things or the minor points. Adding on to it, anything more than 5 points, then it goes into the criteria of heart failure, preserved ejection fraction. And if it is between 2 to 4, then we have to do a diastolic stress test. Like, dopamine stress test, we measure the E velocity, EA velocity, and then get this 2 to 4 points to 5 points to ensure that we are not missing out a diastolic heart failure or a heart failure with preserved ejection fraction. So now, with the ACCHA guidelines which has come with heart failure with preserved ejection fraction. So anything more than 50%, we know that it is a heart failure with normal ejection fraction. In addition to it, we have ruled out infiltrative cardiomyopathies, hypertrophic cardiomyopathies, valvular heart diseases, pericardial diseases, and high output heart failures like anemia. So there are some mimickers when there is an associated kidney or liver diseases, then we are not including it as heart failure with preserved ejection fraction. So this slide I just put in to understand that any sort of evaluation of a heart failure with preserved ejection fraction, we should know these values. E velocity anything less than 80 centimeters per second. EA velocity, EA ratio anything more than 1.5 is considered abnormal. E bar E dash velocity anything less than 8 is normal, more than 15 is abnormal. Deceleration time more than 240 milliseconds is considered abnormal. So when we know about these 4 things in this diastolic numbers, we'll be able to identify or come to a conclusion that we are going to manage a patient with heart failure with preserved or a mid-range ejection fraction. So these are the different stages in the diastology of heart failure. Where so what is important here is, again, I'm going to stress on the point that anything more than 15, that is stage 4, we want to know whether it is reversible or it is irreversible. Once this is identified, and when we have a PA pressures of more than 35 millimeters of mercury, we know that we are going to deal with something like a heart failure with preserved ejection fraction. So to stress on what guidelines says that the sensitivity pattern increases to more than 83% if the E bar E dash is more than 15. The European guidelines again says that anything between 8 to 15 is also considered as a minor criteria. So if the biomarkers are lower, and additional information is more necessary here, that is where this LA left atrial volume index comes in. I'll be talking about this in the next few slides. So again, this is the point to indicate that about the usefulness of the major and minor criteria. So these are the 3, apart from the standard echocardiographic criteria, we have some comprehensive criteria to comprehensive echo parameters to know to identify it, as well as to come to a conclusion that we are dealing with a heart failure with a preserved ejection fraction. So 3 criteria: LV mass index, relative wall thickness, and LA volume index. LA strain pattern has also been included in the recent guidelines, which I'm going to highlight in the next slide. So how do we want to, it's not important how we are going to quantify LV mass. We have to take a couple of parameters like the posterior wall thickness as well as the LV dimension in diastole. The recent softwares completely evaluate the LV mass. Anything more than 240 is considered significant and being taken as a criteria for left ventricular hypertrophy. We are talking about relative wall thickness. So why is it important? Because sometimes we have something called as eccentric hypertrophy. We talked about concentric hypertrophy. We want to know whether is there any real hypertrophy. So a ratio of more than 0.4 is considered relative wall thickness. So any echo report with a patient with suspicious of a heart failure with preserved ejection fraction should have a relative wall thickness also. So once this is done, then we go into the LV mass. I spoken about LV mass. So put together both relative wall thickness as well as LV mass, we come to a conclusion whether are we dealing with a left ventricular hypertrophy, or it is a athlete's heart, or it is an eccentric hypertrophy, or it is a previously detected heart failure with reduced ejection fraction. Now it has improved, and it is now in a improved heart failure. And that is the reason why LV mass index as well as relative wall thickness are important. So once this is done, then now we have LA volume index. It's very easy. Anything more than 40 ml without even an index body surface area is considered a dilated left atrium. Why is it very important? At any point of time, it might be having an intermittent atrial fibrillation, or it might be going into a chronic atrial fibrillation. So once we have the LA, we have the LV systolic thickness, relative wall thickness, we have identified there is some left ventricular hypertrophy. The other additional point is now about the global longitudinal strain. So how are we going to have this global? There are some softwares which has been we have it in the latest echo machines where we want to put some few. I'll show some pictures also, which we put it in the LV muscle mass. Then a global longitudinal strain, if it is less than 16, then there is some amount of diastolic heart failure. So anything more than 18, we are very sure that even though this global longitudinal strain has not been inside the guidelines for heart failure, but it's an additional tool. Still, we want to know whether there is any subtle form of heart failure with preserved ejection fraction. So these are the functional morphological biomarkers when sinus and atrial fibrillation, again highlighting the point importance of having a echocardiographic criteria for identifying a patient with heart failure with preserved EF. So once this we have identified that it is within more than 5 points, if it is less than 1 point, we are going to say that it is a normal heart, and if it is somewhere in between 2 to 4, a functional testing is necessary. So it can be a diastolic stress test or an invasive hemodynamic test. Usually we don't do the invasive hemodynamic test. So a diastolic stress test. What is a diastolic stress test? So like our treadmill test, like our dobutamine stress test, we do a dobutamine stress echo. We are not going to identify any wall motion abnormality. We are just going to put some Doppler pattern, a E velocity, a velocity, a tissue Doppler velocity. If both the E velocity and A velocity goes hand to hand, then we know that the compliance is good. So there is no evidences of a heart failure. But if the graph widens, if the E velocity goes up, the E dash velocity goes down, we know that we are going to deal with some sort of a heart failure with a reduced ejection fraction. So now LA strain has been part and parcel of our guidelines now. Ashwin Venkatesan is a senior echo technician who worked with us at Satya Sai Puttaparthi, and he was the major reason for including into the ESC guidelines way ago in 2016. And now predominant teaching institutions also include left atrial strain pattern in a part and parcel of any echocardiogram when they are dealing with heart failure with preserved ejection fraction. So when we talk about left atrium, this is basically a conduit. So there is a reservoir to hold the blood. It is a conduit, and there is some amount of booster strain. So when there is a reservoir strain, we want to know about the filling pattern of the left atrium. When there is a conduit, we want to know how much it is going to empty into the left ventricle in early diastole. A booster strain is the ability of the LA to assess the contractile function of the LA. So these are the three parameters which by this one single slide will tell us about the LA function in a particular patient. So there's some red, yellow and green markers which has been put, the software detected. So we know that this is a automatic or a semi-automatic way of including this, and we get a value of like how we say ejection fraction in left ventricle is 60%. Here we call it as the LA function is one thing more than 40% and is considered normal. And here also we can use a global strain. Again, the numbers remains the same, like more than 18, which is normal. So this is the utility of LA reservoir strain. So when in a patient with normal ejection fraction, more than 50%, we want to identify that, whether there is any evidence of diastolic heart failure. So we know that I already told we are talking about 3 standard echocardiographic parameters like E bar E dash velocity more than 14, more than 15, 2.8 meters per second, and left atrial volume index of 34. When there is some discrepancy, then we go for the criteria. So the filling pressures, if it is normal, then we are rolling out. If the filling pressures are intermediate, then we go for diastolic stress test. If the filling pressures are elevated, then we know that it goes into a patient with heart failure with preserved ejection fraction. So what is the natural history of this patients with normal ejection fraction? 5 years mortality as high as 50%, because now we have very good tool for reduced ejection fraction. Slowly we have medications or improve the quality of life to improve this probably might have reduced to less than 50%, but still, when identified later, this also have a mortality of 50%. So very high alarming data. So what are the demographic features which helps to identify that these are all the patients who might have associated something like, the race, ethnicity, geographic region. African Americans have more to develop heart failure, episode ejection fraction. Asians, in contrary, with the lean Maribas and diabetes, have an increased with the heart failure, episode ejection fraction. Female sex is another potential risk for having a heart failure, hypertension, obesity, diabetes, atrial fibrillation, and either close to 50% of the patients will have some sort of an intermittent AF unless a Holter or a continuous ECG monitoring proves to it. High prevalence of renal disease, sleep apnea, and associated CAD is as low as 20% to 40%. So how are we going to manage these type of patients? Risk stratification, like any other treatment strategies in lifestyle modifications like hypertension, diabetes, obesity, controlling rate. Either we are being worried only about the rate control now, people talk about rhythm control as well. Management of CAD, CKD, obstructive sleep apnea, role of exercise and weight loss. A huge management change in heart failure with maintained EF. So now we have two drugs. One is the SGLT2 inhibitors. So this class 1 indication. So I'm going to talk in the subsequent slides. Historically, medical therapy has miserably failed in managing heart failure with preserved ejection fraction because of no demonstrable benefit with all the drugs like perindopril, statins, beta blockers, nitrates, digoxin. But this all I'm talking about only with normal ejection fraction, but still it's being used in most of our patients with heart failure with preserved ejection fraction also. So now we have two drugs which have been into the guidelines for the management for this heart failure. One is based on the Emperor Preserve trial, empagliflozin. Other one is the delivertire from dapagliflozin, close to 20% reduction in 40% reduction in mortality and 20% reduction in these are all absolute numbers in heart failure hospitalization. So now it's been recommendation for heart failure with preserved ejection fraction. The first drug to be used has to be SGLT2 inhibitor of choice. So we have to apart from this, a sprint trial which has been proven to be beneficial in intense blood pressure control, especially in a high cardiovascular risk patient. So still we uses all this first line management, ACE, ARB, mineral receptor antagonists, RNA, and all those things. Beta blockers to control hypertension as well as heart rate, especially these. So with Deliver and Emperor Preserve trial, we all know that now, dapagliflozin or empagliflozin has to be initiated in any patients with a reduced ejection fraction. But even with preserved ejection fraction, we have some sort of an indication to use it. So in conclusion, heart failure with preserved ejection fraction, 21% relative risk reduction in cardiovascular death or hospitalization, 30% reduction in heart failure. So this is again the guidelines. So how to treat the atrial fibrillation? Atrial fibrillation, we all know that it worsens the heart failure. So earlier we were all thinking that we had to control the rate alone. Now with increasing incidences of atrial fibrillation going into reduced ejection fraction, we have apart from the drugs, we also are subjecting these patients for a rate control either in the form of a EP study and RF ablation. So rate AF trial in particular with bisoprolol and digoxin. Digoxin fares very well. They favors more with rate control and thereby reduction in the quality of life. So the benefit of digoxin, if beta blockers are not tolerated, has to be initiated. Unlike earlier thing that digoxin might not be much useful or it is equivocal. Ablations are being tried or has to be the first line of management when the patient goes from preserved EF to a mid-range EF. That's a major indication for EP study and RF ablation. So the main line of treatment will be with aggressive diuretic therapy to reduce the intracardiac filling pressures, both at rest as well as during exertion. So what sort of a diuretic? So it is a loop diuretic. It all depends on the severity of the volume overload, whether we're using a diuretic at the sequential nephron blockage or at the diacet level. So using to reduce the myocardial fibrosis, TOPAC trial, which has been proven to be only 11%. It's not been one of the very good drugs for managing heart failure with preserved ejection fraction, but still to reduce the myocardial fibrosis, a mineralocorticoid receptor antagonist is being used. So taking into caution about the creatinine and potassium rise. So heart failure reduced ejection fraction, again RAS, ARBs. In Paragon heart failure trial, this is a trial which proved that even a heart failure with preserved ejection fraction, anything more than 40-45%, again valsartan sacubitril is being beneficial in reducing hospitalization for heart failure. So in conclusion, sacubitril valsartan did not result in a significant low rate of total hospitalization, heart failure and death among patients, and an ejection fraction of higher, but still being used for most of our patients. DITCH trial did not alter the primary endpoint of heart failure. It also did not reduce the overall mortality, but reduce the rate of hospitalization, both and by preventing heart failure. So we have other phosphodiesterase like sildenafil. These are very insufficient clinical data having any data that it will improve heart failure. Nitrate therapy is only to reduce heart failure congestion, pulmonary congestion, and otherwise not much of role, especially if only associated with associated coronary artery disease. So with treatment guidelines for the management of heart failure with preserved ejection, once the heart failure diagnosis is confirmed, treatment is diuretic management for decongesting. If it is more than 50%, and prior HF or mid-range, we have to move towards a preserved EF, exclude if the mimickers like associated liver disease and renal disease. Once this is done, we have to select the patients. For all the patients with eligible patients, we have to start on RNA, ACE inhibitors, mRNA. Once when this is done with more than 50%, then we have to consider managing all the comorbid conditions as well as the cardiac condition. So the first line of management is SGL2. Apart from that, we can add on a diuretic for decongestion, and the other drugs follows. So diuretics class 1 indication, only 3 class 1 indications: diuretics, dapagliflozin, empagliflozin, as well as management of etiology and comorbid conditions. So these are the drug dosage to initiate it, as well as the target doses for the usual drugs used for management. So management of all the comorbidities is vital: atrial fibrillation, hypertension, CAD, type 2 diabetes, CKD, obesity, and sleep apnea. So major management involves treating all those comorbid conditions. So the last slide of mine is very important here. This is the phenotype wheel, where we are how to manage heart failure, obese, metabolic phenotype, arrhythmic phenotype like atrial fibrillation, hypertensive, and the vascular phenotype. So once this is being taken care, and adding on SGL2, decongesting with diuretics, will be able to achieve most of the targets. Thank you. Thank you for your patient listening.
Thank you for your elaborate lecture on this heart failure with preserved ejection fraction. Any questions from the floor? Already 20.
Thank you, sir. I now request the moderator and Dr. Calvin David Singh, sir, to felicitate the speaker. Thank you, sir. Now I request Dr. Calvin David Singh, sir, to felicitate Dr. Prince Payas, sir. Thank you, sir. We now move on to the final session, session 5 on vascular syndromes or hypertension. We have 4 eminent speakers, and to chair this session, it's my honor to invite 2 esteemed doctors, Dr. Tilagar, sir. And Dr. Mohanadas, sir. Dr. Tilagar, sir, is the Senior Consultant Physician, Nagarkoil, Associate Professor, Department of General Medicine, Sri Mogambika Institute of Medical Sciences, completing both his undergraduation and post-graduation in Madurai Medical College and joining the Tamil Nadu Medical Services in 1985. Sir is an esteemed academician and a respected mentor who has contributed immensely to medical education and clinical expertise. Welcome, sir. And next up, we have Dr. Mohanadas, sir, Senior Consultant and Physician at Calvin Hospitals, Valliyur. Sir has served as Associate Professor of Medicine in Kanyakumari Government Medical College, Asaripallam, as well as Sri Mogambika Institute of Medical Sciences, Kulasekaram. Over to the moderators to welcome the speakers. Okay, sir.
At the outset, I must thank Dr. Colvin and team for allowing me to chair the function. Number 2, hats off to you, sir, for conducting the CME program for the 3 consecutive years. Arranging a CME is not an easy job. Now coming to the CME, the first topic is on hypertension, very common problem and for the budding doctors, and it is going to be handled by Dr. Neelambujan, eminent cardiologist with more than 20 years of experience from Tuticorin. He did his MBS from Madurai Medical College, MD Kasturba Medical College, DNB Cardiology, Sri Satya Sai Institute, and he has so many furthers in his cap. With this brief introduction, the stage is yours, sir.
Thank you, sir. My respects and regards to the moderators, Dr. Tilagar sir and Dr. Mohanadas. My dear colleagues and friends, warm good evening to one and all. First of all, let me express my sincere thanks to Dr. Calvin, and I also appreciate him for conducting this awesome academic excellent program over the last 3 or 4 years. After a lot of high profile talks involving a lot of technical things in the afternoon by Dr. Salvarani ma'am, Dr. Venkatesh and Dr. John involving cardiac CT, we now go on to the very basic thing of blood pressure, which is a very simple thing, and this is something which spans all the boundaries and it cuts across all specialities. A patient with hypertension may be seen by a pediatrician, a physician, a surgeon, a physician, a cardiologist, or a nephrologist. Everybody sees a patient with hypertension. So we need to have a very good knowledge about this particular problem. That's what we are going to do in the next 20 minutes or so. So why do we bother about hypertension? Because the cardiovascular mortality associated with high blood pressure increases with each 20 millimeters hike in the blood pressure, I mean systolic blood pressure, as well as 10 millimeters diastolic blood pressure. It always doubles. Say when the blood pressure is in the normal range, just a minute, okay. When the blood pressure is in the normal range, the mortality is very less. But when the blood pressure goes up to the stage 1, the mortality almost doubles. When it goes to the stage 2, it is almost 4 times, and when the blood pressure goes up to stage 3, it is almost 8 times. Likewise, when you reduce the blood pressure, you get mortality benefit also. Say when you reduce the systolic blood pressure by about 10 millimeters of mercury, you get to reduce the risk of stroke by about 40%. And when you reduce the systolic blood pressure by about 10 millimeters of mercury, you get to reduce the risk of myocardial infarction and coronary disease by about 30%. The benefit of reduction of blood pressure is more with stroke rather than coronary disease. So we need to have a target-oriented reduction in the blood pressure in the management of these particular problems. The prevalence of hypertension is quite high in our population, but the awareness is very less, and the amount of people with controlled blood pressure is hardly 20%, and this is something we need to ponder as clinicians. So let me drive home some points regarding hypertension using a case scenario. So, 38-year-old male presents with vague symptoms like headache, neck pain, and dizziness for the last 15 days. He is also a smoker and a diabetic. His blood pressure is 130/85 on both arms with a pulse of 104 beats per minute. Such cases we keep seeing in our clinical practice day in and day out. Most of the times we are confused what to do with this particular patient, whether to start with antihypertensive drugs right away, or whether we need to follow these patients, or whether we need to inculcate on lifestyle modification, whether it is good enough to control the blood pressure. And if we decide to start these patients on antihypertensive drug, what drug to start? So these are all the points which will be running through our minds when we see such patients in our clinic. So there are some guidelines and we need to know what to do when we encounter such patients. The European Society of Cardiology, the ESC 2024 guidelines, has simplified the classification of hypertension. Previously, we used to have high normal blood pressure, stage 1 hypertension, stage 2 hypertension, stage 3 hypertension. Everything was little confusing. Because this has been totally removed, because there's not much of difference in choosing the drug in different stages of hypertension. So all the stages has been removed. Now it is very simple. You have only 3 categories. Patients with non-elevated blood pressure, when you have the blood pressure of 120/70, the normal blood pressure is no more 120/80, it is 120/70. So when you have such a blood pressure, you call it as a non-elevated blood pressure, and you have a hypertensive level when you have a systolic blood pressure of 140/90. You call it as a hypertension. And in between values, that is elevated blood pressure when you have a systolic blood pressure between 120 to 139 and a diastolic blood pressure between 70 to 89. This is called as non-elevated blood pressure. So when you encounter a patient with non-elevated blood pressure, that is a normal blood pressure, all that you need to do is to inculcate on values like lifestyle measures, and you have to have these patients on follow-up. That means any opportunistic screening is good enough to follow these patients. When you have a patient with elevated blood pressure, that is when the blood pressure is, systolic blood pressure is between 120 to 129, which is quite common in our clinics, all that you need to do is to have a lifestyle measures, and you have to follow these patients annually. That is very important. Every year you have to follow these patients. When you have a patient with elevated, just elevated systolic blood pressure between 130 to 139, and you don't have any high risk markers, we'll discuss what are the high risk conditions, or when they don't have any risk modifiers in their clinical settings, or when the risk of developing a cardiovascular disease is very less. These group of patients again can be followed up medically with lifestyle modification, and annual follow-up is all that needed. But when you have a patient with elevated blood pressure in the systolic blood pressure range of 130 to 139, but when they have a high risk conditions like diabetes, or when they have an established cardiovascular disease, or when they have a familial history of hypercholesterolemia or hypertension mediated organ damage, or when the risk of developing a future cardiovascular disease is quite high, when it is more than 10%, or when they have a risk modifier in their clinical profile, all these patients should be started on antihypertensive drug after a trial of lifestyle modification for about 3 months. So you start on lifestyle modification for 3 months. If the blood pressure is still high, then probably you have to start on antihypertensive drugs. Whereas the American guidelines is very strict. Even in this group of patients, they advocate starting off antihypertensive drug right away when the blood pressure range is between 130 to 139 of systolic blood pressure. When the blood pressure is high, that is hypertensive range, when it is more than 140/90 millimeters of mercury, that is an indication to start the antihypertensive drugs straight away along with the antihypertensive drugs. Coming to the patients which we saw, we had a patient who had a high blood pressure in the range of elevated blood pressure in the range of 130/85, which falls into the elevated blood pressure category, and he was a diabetic. So he should be started on a lifestyle modification initially, and after a trial of lifestyle modification, he should be put on antihypertensive drug. The blood pressure is not coming down. So we have certain guidelines to manage the patients appropriately. So we have to fit our patients in one of these categories and plan the management strategy appropriately. So these are all the high risk cardiovascular conditions which might warrant the starting of blood pressure medication in patients with elevated blood pressure. You know what is called as elevated blood pressure. That is when the blood pressure, systolic blood pressure is between 120 to 139, that is called as elevated blood pressure. In such groups, when they have these conditions, probably you might have to consider starting on antihypertensive drug of a trial of lifestyle measure. So when the patient is having an established atherosclerotic cardiovascular disease like stroke or coronary disease, or when they have a established CKD in the form of a reduced EGFR, or when there is albuminuria which is quite significant, or when they have a hypertension mediated organ damage in the form of LVH, or when they have features of diabetic nephropathy or a retinopathy, or when they have a diabetes, or when there is a history of familial hypercholesterolemia. These are the conditions when the patients present with, and when they have an elevated blood pressure of 130 to 139, you might have to consider starting on antihypertensive drug along with the lifestyle measure. So there are certain risk modifiers which, when patients present with average risk, when they have these risk modifiers, again after a trial of lifestyle modification, you might have to consider starting them on antihypertensive drug, like high family history of coronary disease or atherosclerotic heart disease, or high risk ethnicity, or patients with high stress, or patients with autoimmune diseases or inflammatory diseases, patients with HIV. These are all the high risk modifiers. Whereas there are certain sex specific also, patients with pregnancy induced hypertension, patients with gestational diabetes, patients with recurrent miscarriages. These are all the risk modifiers which pushes the patients with average risk to a high risk, and you have to consider these patients to be put on antihypertensive drug after a trial of lifestyle modification. This is what the ESC guideline says. And what are the drugs which are available? Everybody is familiar with all the first line drugs, the ACE inhibitor, ARB, the calcium channel blocker. The main thing is the dihydropyridine calcium channel blocker, diuretics. These are all categorized as a first line management. In the previous guidelines, in the 2018 guidelines, they were considered as basic drugs for hypertension, whereas in the present guidelines, it has been prioritized as a first line management drugs. And how do you choose these drugs? Ideally, you have to choose the two drugs as a single pill. Dual combination of drug is the treatment which is needed in most of the patients. Either you can start with ACE inhibitor along with ARB and a calcium blocker, or ACE inhibitor, ARB along with the diuretics in the first step. In a dual combination, in a single pill, if the blood pressure is not getting controlled, you can add the next drug. When you had started initially on a calcium channel blocker, you can add a diuretic. When you had started a diuretic, you can add a calcium channel blocker in the step 2, and if the blood pressure is still high, then probably you might have to consider adding a spironolactone. This is how the management of hypertension goes, and most of us, everybody is familiar with. And the NICE guidelines, which has been released in 2025, has given guidelines which tells what drug to prefer in which group of patients. Say when a patient with hypertension and you want to start these patients on drug, divide these patients whether it's a diabetic or a non-diabetic. The patient is a diabetic, then straight away go for the ACE inhibitor or ARB as a first step, and if the blood pressure is not getting controlled, go to the calcium channel blocker or a diuretic. When the patient is not a diabetic and you classify based on the age, if the patient is less than 55 years, then probably you have to start an ACE inhibitor or a ARB, then go to calcium channel blocker or a diuretic. Whereas when the patient is more than 55 years, this is where the differentiation comes. It is not the ACE inhibitor to be started, it is the calcium channel blocker which is to be started in patients more than 55 years, then go on to the ARB or a ACE inhibitor or a diuretic. This is what the NICE guidelines says. So we have some insights into the drug which has to be initiated in different groups of patients based on the clinical profile of the patients. So in the 2024 guidelines, we have the recommendation for other drugs, like if the patient is not tolerating the spironolactone, then probably you can supplement these drugs with eplerenone. And if the patient is having a coronary disease, then probably you can consider using a drug called as beta blockers group of drugs, alpha blockers, hydralazine, potassium sparing diuretics. All these drugs has been included in the guidelines, and we have a big armamentarium of drugs in the management of hypertension these days, which has been recommended by the 2024 ESC guidelines as class 2A. Whereas the American guidelines, which has been released of late, is very strict in the numbers. You can see that the stage 1 hypertension values, the systolic blood pressure of 130 to 139 itself is classified as stage 1 hypertension, and straight away they ask these patients to be put on antihypertensive drugs whenever they have a high risk conditions associated with it. And you can also see that the elevated blood pressure is between 130 to 129. whereas the ESC guidelines is a little broader in the scope. What does the Indian guidelines say? Indian Society of Hypertension guidelines are very vague. It almost follows the American College of Cardiology guidelines. Again, the stage 1 hypertension, again, it is very strict in the numbers. The systolic blood pressure values between 130 to 139 is considered as a stage 1 hypertension, and they have replaced the elevated blood pressure values as a raised blood pressure to reduce the patient anxiety with the terminology of elevated blood pressure. And managing the resistant hypertension is again a challenging problem. Let's see how to go about it. Initially, what is resistant hypertension? Say, for example, if the office blood pressure is 140 over 90 millimeters of mercury, despite using 3 or more antihypertensive drugs and at the maximum tolerated dose, including a diuretic, you call it as a resistant hypertension. In such cases, you have to ensure that the patient is taking the drugs adequately. Patient drug compliance history is very important. You have to rule out pseudo-resistance, and you have to rule out secondary hypertension also by your clinical examination. Once you have ruled out secondary hypertension and pseudo-resistance, then probably you have to think of a true resistance, and you have to increase the drugs. That is, you have to start adding the spironolactone, which is given a class 2A indication. If the blood pressure is still high, then probably you can add a beta blocker, if not added already. Then if the blood pressure is still very high, you have other armamentarium of drugs like centrally acting drugs. We have the alpha blockers, we have the hydralazine, potassium sparing diuretics like amiloride, can all be tried, but all these have a class 2A recommendation. That means it is a quite strong indication. If the blood pressure is still very high, then probably you can consider an invasive therapy like renal denervation therapy, which is class 2B. So this is coming up in a big way of late. Let's see a few slides on renal denervation therapy. So there is a renewal of interest in the renal denervation therapy, which is proposed as a management of hypertension. It is not a first-line therapy for hypertension. So initially, the trial which showed a lot of benefit for renal denervation therapy was the Simplicity Hypertension 2 trial, which showed a reduction of blood pressure of 32 by 12 millimeters of mercury. But the initial enthusiasm was lost when the hypertension Simplicity trial 3 was released, where there's not much of blood pressure reduction between the sham treatment group and the real patient group. Now the second generation catheters have been introduced, where they produce simultaneous and a helical lesion in the renal artery. A good knowledge about the renal nerves, where they have found that the renal nerves are concentrated more in the proximal as well as in the anterior part of the renal artery, so that they can produce a simultaneous good renal denervation, producing a good result, has been studied with the recent trials, and this is coming up in a big way for resistant hypertension. So these are all some of the devices which are available for renal denervation therapy. You can use the radio frequency energy. There is also a device which instills the alcohol in the peri-adventitial tissue of the renal artery, the perigerine tissue. There you can also use the ultrasound through a balloon catheter which is inflated in the renal artery to produce the renal denervation. Different methods of causing renal denervation therapy is available, and various trials like spiral hypertension on medicine trial, which has shown about 9 millimeters reduction in the systolic blood pressure and about 4 millimeters reduction in the diastolic blood pressure of medicines has been reported. And again, one important thing is all these trials has been followed up for long years, and even after 9 years follow-up, they have found that the blood pressure reduction is sustainable even after 9 years. So we have a long-term follow-up of these drugs. A few words about the drugs, newer drugs like SGLT2 inhibitors. Dr. Venkatesh spoke about SGLT2 inhibitors in detail. Hypertension sometimes may be associated with diseases like diabetes, CKD, and obesity. When you have such problems, SGLT2 inhibitor is an excellent adjuvant drug in the presence of diabetes and CKD and in patients with heart failure with preserved ejection fraction. Hypertension is a condition which is commonly associated with heart failure with preserved ejection fraction. In clinics, sometimes you might see patients with hypertension coming with breathlessness. When you do an echo, you might see the blood, your left ventricular ejection fraction is quite normal, and you might be wondering what to do with these patients. You have to ask your cardiologist to evaluate for the diastolic dysfunction, and how to evaluate. Dr. Venkatesh spoke in detail. Cardiologist can really report whether the patient is having diastolic heart failure, that is the heart failure with preserved ejection fraction. And when you find such a condition, the SGLT2 inhibitors are an excellent drug. That is the only drug which has got a proven track in the management of heart failure with preserved ejection fraction, which is a common association with hypertension. It has got a class 1 indication, and everybody should take a note of it and keep using these drugs in patients presenting hypertension and shortness of breath. And this is another drug which is coming up in a big way. Of late, the GLP receptor 1 agonist, the liraglutide, tirzepatide, and the semaglutide. This is an excellent adjuvant drug in the management of the comorbid problems like diabetes and morbid obesity. And when you have these problems, the semaglutide and the tirzepatide has been shown that it is reducing the blood pressure to a bigger extent in all stages of hypertension. And the mechanism of reduction of the blood pressure in this group of patients is through natriuresis, diuresis, and weight reduction. And of course, it has got influence in the RAS inhibition also. This is a drug which Dr. Shivakumar was alluding to in his talk on CKM, the finerenone drug which reduces the cardiovascular mortality and the CKD projection in patients with hypertension without the much incidence of hyperkalemia or gynecomastia. Newer drugs are on the pipeline. The hexacetonone, which is a Japanese molecule which is likely to be introduced shortly in the Indian markets, is also coming up, and hopefully the cost also will be less when more drugs are available and the patency is off, and everybody can use these drugs without the problem of hyperkalemia or gynecomastia. So this is evolving newer drugs. We know the established antihypertensive drugs acts on the angiotensin targets or the mineralocorticoid receptor antagonist targets or the beta blocker, but there are other targets like angiotensinogen. There are other targets like aldosterone where the drug can be used to inhibit the production of aldosterone. There are endothelin like targets. There are targets like angiotensin 3. Angiotensin 3 is something new terminology for so many of people. Let's run through quickly through some of these drugs. You might have heard the inclisiran, which is a drug which is used in the management of LDL. In one of the talks, somebody was alluding to that. And similar to that, we have the zilisbesiran, which is a small interfering RNA, which reduces the angiotensin level by suppressing the production of the angiotensinogen. And this is given as a quarterly as well as biannual injection. But some of the problem with this group of drugs is this produces a permanent inhibition of the RAS system. So whenever the patient is having a hypotension or some form of shock, we never know how these patients are going to respond, because angiotensin and the sympathomimetic amines are the drugs which are really helpful in the management of the initial compensatory mechanism of coping up with the shock. So that is a downside of this particular thing. We need to study all these things. The CRISPR technology is another promising tool, which is a gene editing technology whereby you target the angiotensin gene, and the certain genes when it is targeted off will help to reduce the production of the angiotensinogen. The problem is the off-target lesions effects of these particular drugs, which is yet to be studied, the tumorigenesis and other things, and there are a lot of challenges in the delivery of this CRISPR components to the target tissue. And there are other targets like aminopeptidase inhibitor, which inhibits the conversion of angiotensin 2 to angiotensin 3. Angiotensin 3 is a drug which is a molecule which is increasing the sympathetic tone and enhances the vasopressin release. So when you inhibit this particular conversion of angiotensin 2 to angiotensin 3 with this particular drug, there is a central RAS inhibition, and without the much influence on the renal parameters. Fibrostat is the drug which is studied in the phase 2 trial, and it is awaiting approvals. And this is something which you need to keep into understanding and keep looking forward in the next 2 or 3 years, the aldosterone synthase inhibitors, because phase 3 trials has been presented in the recently concluded ESC and the ACC meeting. The lorundrostat, which is a 50 milligram dosage, which has got favorable effect in patients with obesity and hypertension. So the launch trial is the one which was presented in the ESC, and endothelin A receptor antagonist, which is acting on the endothelin 1 which is a vasoconstrictor, and the zibosentan is the drug which is likely to antagonize the effect of endothelin 1, and this has got additional benefits like reduction of the HbA1c as well as the LDL. So these are all some of the drugs which we need to look for, and I'll rush through a couple of slides. The other newer drugs which are likely to be coming in the pipeline is the angiotensin 2 type 2 receptor agonist. Type 2 receptor is basically a favorable receptor which causes vasodilatation and causes anti-inflammatory response, and when you stimulate these drugs, you have potential to reduce the hypertension mediated organ damage. This is in the phase 2 trial. The NPR receptor agonist, which is likely to act like a ANP or a BNP, causing vasodilatation, natriuresis, and this is going to offer a novel therapeutic target in resistant hypertension and in patients with heart failure with reduced ejection fraction. So we have to look out for all these drugs, and some of these drugs are available in an injectable form, which is going to be really handy for the patients because they don't have to take these drugs daily. Sorry.
Thank you, sir. Very excellent.
Just for final slide. Okay.
Thank you, sir. Now I request the moderators to felicitate the speaker. Thank you, sir. Moving on to the next topic, advances in acute ischemic stroke therapy by Dr. Jason Ambrose, sir. Over to the moderators.
Another from the hypertension to ischemic stroke, another common problem for the practicing physicians, and it's going to be handled by a neurologist, Mr. Jason Ambrose. He's currently working as assistant professor in Tinnevelly Medical College, and his interest in neurology is stroke management, epilepsy, migraine, peripheral neuropathy, and neurointensive care. And he's a member of the So Many Neurological Association. With this brief introduction, the stage is yours, sir.
Good evening, everyone. I'd like to thank the organizers for giving me this opportunity. My topic for today is recent advances in the management of acute ischemic stroke. Acute ischemic stroke occurs when the cerebral blood flow falls below the level required for neuronal metabolism, most commonly due to arterial occlusion by thrombus or embolus. So the normal cerebral blood flow is 50 to 60 ml per 100 grams per minute. When an artery gets occluded, as long as the blood flow is more than 20 millimeter per 100 grams per minute, the neurons function normally. When the blood flow falls below 20, when it is above 10 ml, there is electrical failure in the neurons, but the structural integrity is preserved. This region with 10 to 20 ml blood flow per 100 gram per minute is called the penumbra. It's a potentially salvageable tissue. When the blood flow falls below 10 ml per 100 grams per minute, there is rapid irreversible injury of neurons, and this region is called as the infarct core. So in the infarct core, the cerebral blood flow is less than 10 ml per 100 gram per minute, and there is rapid neuronal death within minutes, and it is irreversible. In the ischemic penumbra, the blood flow is between 10 to 20 ml per 100 grams per minute. The membranes are partially depolarized, and it's potentially reversible. All the goal in stroke treatment is to preserve this tissue, which is the ischemic penumbra. So the timeline in the ischemic cascade, within minutes there is energy failure and depolarization. Within 30 to 60 minutes there is cytotoxic edema. Within hours there is excitotoxic injury to the neurons. And in 6 to 24 hours there is inflammation and blood-brain barrier breakdown. So the goal of treating acute ischemic stroke is to save the penumbra number 1 and to intervene earlier in the ischemic cascade. The decision making in acute ischemic stroke has been evolving over the last 2 decades. To make an optimal decision, we need to know the duration since stroke onset, most importantly, and we need to know the severity of deficit as quantified by the NIH stroke score. And other tools in our use are CT brain, CT angiogram, CT perfusion and MR imaging, which help us to decide the time window versus the tissue window. The decision making in acute ischemic stroke has moved on from time window to tissue window in the recent years, and in the subsequent slides we'll learn how to assess this tissue window. So this is a brief introduction to the NIH score. The NIH score is a detailed clinical score to assess the severity of clinical disturbance, and the various domains assessed are levels of consciousness, gaze, visual fields, arm and leg strength, sensory examination, language examination, and neglect. This takes about 5 minutes to administer, and it is also available as apps in mobile phones for PG students to quickly use. So when the NIH stroke score is less than 4, it is called as a mild stroke. When the NIH stroke score is more than 20, it is a severe stroke. The most benefit of revascularization is seen in the moderate stroke, which is NIH score between 4 to 20. Coming to the plain CT scan, there's something called aspect score. This is basically dividing the MCA territory into 10 parts, and the total score is 10. When the total score is 10, the CT scan is normal. When the score is less than 7, the score is said to be severe. So the important question to answer in any stroke is whether it is a large vessel occlusion or not. The gold standard for diagnosing large vessel occlusion is a CT angiogram. Clinically, if NIH stroke score is more than 10, it's likely to be a large vessel occlusion. Occlusion of ICA, M1 segment of MCA, basilar artery, vertebral artery, and A1 segment of ACA are called as large vessel occlusion. Next is perfusion imaging. Perfusion imaging can tell us in a clear-cut manner what is the volume of the core, what is the volume of the hypoperfused area or the penumbra, and what is the normal area. And there's also a parameter called Tmax or delayed contrast arrival, which also gives us the volume of the penumbra. So briefly coming to the eligibility criteria for thrombolysis, the clinical diagnosis should be stroke. The NIH score should be a moderate stroke between 4 to 20, and the duration should be less than 4.5 hours, and BP should be less than 180 by 110, or it should be controlled and brought below 180, 110. And the CT brain should not show any evidence of bleed, and there should be no contraindications. So this algorithm shows that in suspected acute stroke, rapid assessment and brain imaging should be done. And first we answer the question whether the patient is eligible for IV thrombolysis. If the patient is eligible for IV thrombolysis, we straight away go and thrombolyze the patient. If the answer to the question is no, then we reevaluate the patient whether he is eligible for endovascular therapy or not. If he is eligible for endovascular therapy, then we'll proceed with the endovascular therapy. If not, supportive care will be initiated. The commonly used drugs in IV thrombolysis are altiplase and tenecteplase. Altiplase is a very short-acting drug, so it's given as a bolus followed by an infusion. Tenecteplase is a genetically modified variant which is a little longer acting. The mechanism of action is the same and it has greater fibrin specificity. Another advantage is that it's given as a single IV bolus instead of an infusion. So most of the ongoing research in stroke is about extending the time window for stroke. To extend the time window, we have to quantify the size of salvageable brain tissue. There are various methods of doing that. Three of the important methods of quantifying the size of salvageable brain tissue are assessing the diffusion flare mismatch in plain MRI, assessing the clinico-radiological correlation, and then comes perfusion imaging. So first is diffusion flare mismatch. When the infarct is seen in diffusion weighted images, but it is not seen in flare images, that means the duration is less than 4.5 hours. So this is the most basic method of assessing the tissue window based on imaging. Coming to extended thrombolysis, a meta-analysis of pooled data from several trials have shown benefit of thrombolysis in 4.5 to 9 hours in properly selected patients. So we see that patient selection is very important in any thrombolysis or revascularization decision beyond 4.5 hours. Less than 4.5 hours, it's pretty straightforward, but beyond 4.5 hours, we have to go through a process. And parallelly, technology has also developed for mechanical revascularization. So we'll look at how to evaluate the patient for revascularization in this context. There are two main trials which revolutionized the concept of assessing the patient for revascularization. One is the DAWN trial, which was published in late 2017, and the other one is the DEFUSE 3 trial, which was published in early 2018. The DAWN trial is based on the concept that if the patient has high clinical deficit and a small infarct core, that means he has a high volume of penumbra. Basically, this means the severe deficit is due to a large penumbra. The severity of deficit is assessed by the NIH stroke score, and the infarct core is assessed by the diffusion weighted imaging. Perfusion imaging was not compulsory in this trial. The DAWN criteria are the patient has to have a large vessel occlusion. The NIH stroke score has to be more than 10. That means the clinical severity should be there. And the window was 6 to 24 hours. For patients more than 80 years of age, the NIH score more than 20, the volume they took was, core volume they took was less than 21 ml. And in patients less than 80 years of age, again the NIH score greater than 10, the core volume they considered was less than 31 ml. And in patients less than 80 years of age with more severity, NIH stroke score more than 20, they considered a core volume of 31 to 51 ml. All these core volumes are very small actually. So the DAWN criteria is meant for patients with a small core with a high deficit. So the next one is the DEFUSE 3 trial. There they picked up patients with NIH stroke score more than 6, large vessel occlusion, and 6 to 16 hours time window. In this trial, they took patients with slightly larger score. In DAWN criteria, we saw that they considered very small cores, less than 21 ml, 31 ml, and 51 ml. In DEFUSE 3 trial, they considered patients with slightly larger core, that is less than 70 ml. And they mainly relied on two mismatch criteria, which are perfusion by core mismatch ratio, which should be more than 1.8. And the next one is mismatch volume, which should be more than 15 ml. So the diffuse 3 criteria mainly relied on perfusion imaging. So we'll consider some example case vignettes to illustrate how these Dawn criteria and diffuse 3 criteria are applied in the real world. The first example, there's a 62-year-old male. Time since onset was 10 hours back. NIH stroke score was 14. That means severe stroke, more than 10. Deficit was right hemiplegia plus aphasia. Imaging CT angiogram showed left M1 occlusion. CT perfusion showed a core of 25 ml and hyperperfusion by penumbra of 70 ml. So we see that there is a good mismatch. Coming to the calculations, mismatch volume is 45 ml, which is more than the required 15 ml. Mismatch ratio is 2.8, which is more than the required 1.8. And the core is 25 ml, which is quite small. So the verdict is that it satisfies diffuse 3 criteria, and this patient can be taken for thrombectomy. So the next example, there's a 78-year-old female presents with wake-up stroke. Approximate duration is 12 to 14 hours. NIH stroke score is 18, which is quite severe clinically. CT angiogram shows a right ICA occlusion. DWI core volume is 18 ml, which is quite small. So this is high deficit with a small core. There is clinico-radiological mismatch. So this patient satisfied Dawn criteria and can be taken for revascularization. The third one is a 55-year-old male who was last well seen 18 hours ago, which is a pretty long time. And NIH stroke score was 16. And imaging wise, CT angio showed left M1 occlusion. Core volume was 21 ml and penumbra volume was 85 ml. And as we can see, the mismatch is huge here, even though the presentation was late. Mismatch ratio was 4.25 ml, which is very high. Mismatch volume also shows an excellent mismatch. So the verdict is that this patient is probably a slow processor with good collaterals, and he satisfies diffuse 3 criteria and is eligible for revascularization. Coming to example 4, so 68-year-old female, 9 hours since onset. NIH stroke score is 15. The deficit is severe. CT angio shows M1 occlusion. CT perfusion shows a large core, 90 ml. And Tmax is also a large, 120 ml. So the mismatch ratio is also small. Mismatch volume is also small. Core is very large. So the verdict is that the core is very large and mismatch ratio is small. So the risk is high and the benefit is low. This patient is not eligible for revascularization. Some real world cases may come only with CT scan. 58-year-old male comes in 11 hours. NIH stroke score is 17, which is a high deficit. And non-contrast CT brain shows aspect score of 7, which is borderline severe stroke. CT angio shows M1 occlusion with good collaterals. So even though we don't have all the information to decide on revascularization based on the Dawn and diffuse criteria, most interventional neurologists end up thrombolizing patients like this. Coming to emerging trends, tenecteplase is emerging as a preferred agent relative to RTPA because of the ease of administration and higher fibrin specificity. Trials also show either non-inferiority or superiority. So the major paradigm shift in the acute stroke treatment is that treatment is no longer strictly time-based. Nowadays, it's imaging-based selection. Penumbra imaging, CT perfusion or MRI mismatch guides therapy rather than the clock time. So experimentally, bridging therapy, adjunct intra-arterial thrombolysis and neuroprotective strategies are also being explored. A word about BP management in acute stroke. If the patient is not being planned for thrombolysis, permissive hypertension can be allowed up to 220 by 120 and BP can be controlled gradually in 24 hours. If the patient is planned for thrombolysis, BP has to be brought below 185 by 110 and 24 hours after thrombolysis, the BP has to be maintained below 180 by 105. If the patient is planned for mechanical thrombectomy, before mechanical thrombectomy, the BP has to be brought below 180 by 110. And after mechanical thrombectomy, if the patient has successful revascularization, BP should be maintained below 160 to avoid reperfusion injury. And if the patient had no or partial revascularization, up to 180 by 105 BP can be allowed to open up the collaterals. Antiplatelets like aspirin and clopidogrel are avoided for 24 hours if the patient is thrombolyzed, and double antiplatelet therapy is recommended for 26 days and generally not more than 90 days. Thank you.
Thank you, sir, for your excellent talk on advances in acute ischemic stroke therapy. Any question from the audience?
Thank you, sir. I now request the moderators to felicitate the esteemed speaker. Thank you, sir. Moving on to the last topic of today's sessions, acute limb ischemia, current approach by Dr. Rajesh Kannaya, sir. Over to the moderators.
We have come to the fag end of the CME program, and the topic is on acute management of acute limb ischemia, and the topic is going to be handled by our vascular surgeon Sanada Sahil. Dr. Rajesh is the associate professor and head of department of vascular surgery unit, Tirunelveli Medical College, and he has a so interest in diabetic foot revascularization, varicose veins management, vascular surgeries, management of complex vascular disorders, pioneer in endovascular procedure in South Tamil Nadu. With this brief introduction, I hand over the mic to Rajesh.
Good evening, sir. It's a fag end of the session, and thanks to the Dr. Calvin and his team for this opportunity. And I'm going to talk about a much less often addressed topic, that's acute limb ischemia. What are the current management strategies in this? So what's the definition? It's a sudden loss of decrease in the limb perfusion and potential cost to the limb viability. So historically, the amputation rate is almost 10 to 25%, and also the mortality rate is also very high because the diagnostic error can lead to a loss of limb as well as life. And in this topic, I am going to discuss about only the lower limb ischemia, and upper limb ischemia I am not going to address. The main causes of lower limb ischemia is going to be a in situ thrombus contributes about 40%, and embolism it's about 38%, and a bypass post intervention graft thrombosis can happen, and sometimes thrombus from a popliteal artery aneurysm or a thrombus from an aneurysm of the abdominal aorta can dislodge and cause a acute limb ischemia. So, trauma and iatrogenic causes contributes to about 2%. And newer causes like a post-intervention acute limb ischemia can happen, and also vascular closure device can occasionally cause acute limb ischemia. So, most commonly we encounter cardiac source of embolism either from the atrial, left atrium or left ventricle from the left atrial appendage, or a mural thrombus from a following a myocardial infarction, or even a left ventricular aneurysm can through a thrombus. So rarely a prosthetic wall can cause a thrombus and distal embolization. Sometimes we may encounter paradoxical embolism, like a patient with acute DVT, if they are having associated septal defects, can like a patent foramen ovale or a ventricular defect, they can go through an embolus to the arterial system. And endocarditis and cardiac tumors are fewer causes. And non-cardiac sources like sources from the proximal arterial tree can cause can cause a distal embolization, like a ruptured plaque in the aorta or in the iliacs can cause a embolism to the distal arterial tree. Rarely an aneurysm that I already mentioned, and air, fat and amniotic fluid can also cause acute limb ischemia. So thrombosis, already a diseased vessel, can go for an acute thrombosis, and sometimes a hypercoagulable conditions like an thrombocytosis or malignancy can cause acute limb ischemia. So the clinical presentation is largely depends on the type of collaterals they develop, because in a acute limb ischemia, if the patient is already having a compromised vascularity with a stenosed vessel, the acute limb ischemia will be less severe, rather than if the vessels are virgin vessels, the limb ischemia will be more severe. And in acute limb ischemia, the sensory nerves are affected first. The loss of sensation is the first sign, followed by motor sensation loss, and motor nerves are affected next, followed by skin, and finally the muscles and bones are affected. So this is a classical P of acute limb ischemia: pain, pallor, pulselessness, paresthesia, and paralysis and perishing cold. That's the classical teaching. So this is a classification which we largely follow. The class 1 is the limb is viable, not immediately threatened. This is a Rutherford classification, still it holds good. And sensory loss will not be there, muscle weakness will not be there, the arterial pulse will not be palpable, but you will be able to pick up the arterial signals through the handheld Doppler. So venous signals will be also there. In 2A, the limb is marginally threatened and salvageable if promptly treated. So the sensory loss will be minimal, confined to the toes, and muscle weakness will not be there, and the arterial signals will not be audible, and venous signals will be audible. And 2B, the limb is immediately threatened. Here urgent revascularization is needed and salvageable with immediate revascularization, and the sensory loss will be more profound, and the muscle weakness will be there. Here also the arterial signals will not be there, and venous signals is audible. In class 3, the limb is already damaged, and it will be paralytic, and the permanent nerve damage will be there. So the arterial and venous signals will not be heard. So it's a class 1 ischemia. You can notice some duskiness, but movements and sensation is preserved. So class 2 ischemia, here you can notice the cyanosis of the toes. So typical class 3 ischemia, here you can see the mottling as well as paralytic limb here. So the tissue threshold for ischemia, the muscle can withstand ischemia up to 4 to 8 hours, and now 4 to 8 hours, and fat 12 hours, and for skin it is 24 hours. So whenever the skin changes has occurred, it's a loss site. So the underlying muscle, um, nerve, everything has gone. So after when the skin is discolored, it is not worthwhile to attempt a revascularization. So therefore, a viable or functional limb in the upper threshold is about 6 hours. But unfortunately, our patients will come only after 6 to 12 hours because there will be some diagnostic delays. So investigation we can go about with the handheld Doppler. The signals may be reduced or absent. Color Doppler can be done, but most often if the patient comes with the acute limb ischemia, you have to go for a angiogram rather than a color Doppler. And these are the types of angiogram available. You can go for CT angiogram or a transfemoral angiogram, MR angiogram. Routine investigations like CBC, RFT, PTINR and ABG has to be taken because most patient will present with an acidosis too. And echo is mandatory to rule out valvular heart disease as well as to rule out the cardiac source of embolus. And you have to look for the ejection fraction as well as the regional wall motion abnormality. And CT angiogram, it's a very widely available now, and it is non-invasive, and it can accurately pinpoint the location and the extent of the occlusion and condition of the vessel, and also the distal tree we can see. And diagnostic angiogram is a gold standard. It is now replaced by CT and MR angio. Whenever possible, you can subject them for diagnostic angiogram because we can also accurately detect the lesion, also treat the lesion, treat the therapeutic intervention can be done simultaneously. So this disadvantage, it is expensive, and also it is not previously it is not widely available, and it is also invasive as well as expensive. So MR angiogram, whenever the urea creatinine is high, you can go for MR angiogram or carbon dioxide angiogram. So aortic occlusion, when a thrombus lodges in the aortic bifurcation, we call it as saddle thrombus, and the images which shows thrombus in the aortic bifurcation, the both lower limbs will be paralyzed. And this is an example of iliac occlusion. So coming on to the management option, you have got endovascular as well as open as well as hybrid options, like open as well as endovascular options are available. So for Rutherford class 1, type 1 and 2A, historical trials like Rochester trial and Topos trials are there. More than 1,000 patients are included in this trial. They compared the efficacy of the surgery along with catheter-directed thrombolysis. Catheter-directed thrombolysis, like using agents like altiplase, tenacteplase and all. So the clinical outcomes are similar, and the patients with symptoms of longer duration are better benefited with surgery. So this is a historical trial. So it is applied only for Rutherford type 1 and type 2A lesions. And now newer gadgets are available. If the patient is having contraindication for thrombolysis, you can go for thromboaspiration with the dedicated catheters like export catheters are available, and ultrasound guided ultrasound accelerated thrombolysis is also available. And sometimes the patient is having needs an urgent revascularization, like in a type 2B where the duration is very less. In the catheter directed thrombolysis, we need to give the lytic for almost 12 to 24 hours. See, the acting time will be more. In order to cut short the time and also reduce the loss of thrombolysis, we can go for a pharmacomechanical percutaneous mechanical thrombectomy can be combined with thrombolysis using the newer gadgets like Rotarex and Angiojet that I will come. Yeah. So this newer It's a usage of an angiojet device. Here, this catheter is having dedicated catheter is introduced in the arterial system and used to inject some volume of thrombolysis along with the so this works by a Venturi effect, that it lyses the thrombus by mechanical means and lyses the thrombus, and also the after 20 minutes we can again aspirate this thrombus like this. So it acts very fastly. And another system is a trellis system where you have got two balloons which isolates the thrombus, and a wire here which rotates and lyses the thrombus, and you will be able to suck out the thrombus later on. It's another one device is a penumbra device which works by aspiration alone. So you can see the occluded segment of the femoral artery, distal femoral artery here, and after using a penumbra you can able to see the successful revascularization. So the newer system cut short the time. So there are multiple trials available regarding this use. The PAOL registry, peripheral use of angiojet rheolytic thrombolectomy with varieties of catheter and length. So all these have shown the patients treated with angiojet have a lower lytic dose and shorter procedure and fewer treatment sessions. So previously we used to go for CDT alone. Now with these available gadgets we will be able to do this thrombectomy as a at the earliest and also with shorter duration. So post procedurally sometimes this patient may need a re-intervention like addressing a stenosis, underlying stenosis, and also they are prone for compartment syndrome. So if they after the endovascular procedure, if they are going for you have to watch closely for the compartment syndrome, and sometimes fasciotomy may be needed, and even after a successful revascularization the amputation rates may be after up to 5 years it is about 9%, and 1 year mortality surprisingly it is high because all these patients will be having multiple comorbids. So the mortality rate is always high in acute limb ischemia. So it's a one try. This is a STRIDE trial which which incorporates penumbra. So the limb salvage is almost 98%, and the major bleed is reduced compared to the previous Rochester and Topaz trial. So sometimes you may need an angioplasty or stenting to treat an underlying lesion. So the newer guidelines, ESVS 2020 acute limb ischemia guidelines shows that endovascular and surgical approaches have similar rates of short-term and 12 months mortality, limb amputation, and recurrent ischemia. So PMT is indicated in Rutherford stage 2B. Previously, endovascular option is available only for stage 1 and 2A. Now, with the available newer gadgets, we can extend this for 2B patients also. So this newer ACC AHA guidelines shows that the mechanical percutaneous thrombectomy is equivalent in hospital limb and mortality outcomes compared to open thrombectomy. So the endovascular thing is picking up now compared to the open surgery. So open surgeries has still some role because it is economical, and if sometimes the endovascular approach fails, you can always go for open surgery. So one case we did recently, a case of acute limb ischemia, where you can see the thrombus extending from the common femoral up to the popliteal, and this extension to the profunda femoris artery. So we will be able to do this in a probably half an hour or 45 minutes time. So it is very quick and fast, and also we can give a lasting results with the open surgery. And the cost factor is also very less compared to the newer gadgets. So sometimes even open surgery or endovascular fails, you can offer a hybrid treatment, like even after incomplete thromboembolectomy, you can go for an intra-arterial thrombolysis or thrombus aspiration with the endovascular gadgets. Or sometimes even endovascular procedure fails, you can go for an open and open thrombectomy, or sometimes even open bypass may be needed to salvage the limb. So these are some, so most often after doing an angioplasty or an intervention, we used to close the access site like common femoral with the vascular closure device like newer angio-seal or ProGride. So sometimes it can cause acute limb ischemia when it is not properly deployed, or there is a technical failure. So angio-seal or short close to achieve rapid hemostasis, but it can cause intraluminal thrombosis, or sometimes it can embolize distally. So few examples I have come across that ProGlide which has migrated and caused acute limb ischemia, and sometimes repeated punch can cause acute limb ischemia like this, and we are able to come away with a short bypass from common femoral to superficial femoral. And so one case of acute limb ischemia where we are able to salvage with thrombolysis and again thromboaspiration. So you can see the acute cutoff of common femoral. Conservative management, you can go stage 2A, urgent imaging and selection of endovascular technique like CDT or percutaneous mechanical thrombectomy can be done, or you can go for an open surgical technique. So stage 3, it is irreversible, you have to go for amputation only. So always after endovascular or open surgery, it is better to have a completion imaging, and also you have to address the underlying lesion like a stenosis or by either hybrid, by either endovascular or by a hybrid approach. Thank you. Thank you for your kindness.
Thank you, sir. I now request the moderators to felicitate the speaker. Thank you, sir. I now request Dr. Calvin David Singh, sir, to felicitate our respected moderators. Dr. Tilagar, sir. Dr. Mohanadas, sir. Thank you, sir. As we reach the conclusion of today's academic program, I take this opportunity to express heartfelt gratitude to our distinguished speakers for sharing their expertise, our moderators for guiding these discussions, and all the participants for their enthusiastic involvement, and the organizing committee for their dedicated efforts. Today's clinical sessions have truly reflected the spirit of continuous learning and clinical excellence. Thank you all for being a part of this enriching academic event. We shall now proceed with the postgraduate quiz session, which will be conducted by our organizing team committee headed by Dr. Aibana Jasni ma'am, Consultant Interventional Cardiologist, Calvin Hospitals. Over to you, ma'am.
Good evening, everyone. Welcome to the quiz session. We now request the selected teams.
We have selected 4 teams. We have selected 4 teams. Congratulations to all the 4 teams for qualifying the prelims. Team G, from Thoothukudi Medical College, we have Dr. Ansar ul Haq and Khatija. Dr. Khatija. I request all the participants who are being announced to occupy the stage. Congratulations, Team G. Next up, we have Team F, Dr. Manoj Kumar and Dr. Bavitra from Thoothukudi Medical College. Congratulations, team. Nextly, we have Team B, Dr. Praveen and Dr. Prashant from Jayasekaran Hospitals. Welcome, team. And lastly, Team D, Dr. Narendran and Dr. Sanjay Bharati from Tirunelveli Medical College. Congratulations, doctors. Over to Dr. Aibana, ma'am.
So we have 4 sessions in total. First is the anatomy and physiology session. So each team will be asked a total of 2 questions. So if you answer correctly, you will be awarded 5 marks. If you don't answer, the question will be passed to the next team. And if the next team answers, you will be given 3 marks. And if you don't answer it correctly, no more passes. There is only single pass. Okay. So first question. So you have team A, B, C, D. Okay. A, B, C, D.
Kindly introduce yourselves. Team A.
So we are Team A. I am Bavitra from Government Thoothukudi Medical College, final year postgraduate. This is Manoj Kumar, final year postgraduate from Thoothukudi Medical College.
I am Dr. Narendran, second year postgraduate from Tirunelveli Medical College, and this is Dr. Sanjay Bharati, final year PG from Tirunelveli Medical College.
I am Dr. Mohammad Khadija from Thoothukudi Medical College, final year postgraduate.
I am Ansarul Haq, final year postgraduate at Thoothukudi Medical College.
Hello, I am Dr. Prashant and this is Dr. Praveen from Dr. Jayasekaran Medical Trust, Nagarkoil, final year medicine pages.
Okay, the first question is for Team A. Which of the following is not seen in RA, right atrium? Ligament of Marshall, Eustachian valve, Thebesian valve, Crista terminalis. You can answer within 30 seconds.
Option A, ligament of Marshall.
Okay, Team A gets 5 marks. Question is for Team B. Valve of fusion is present at option A, junction of great cardiac vein with coronary sinus, junction of Thebesian vein with right atrium, anterior middle posterior cardiac vein with coronary sinus, all the anterior cardinal veins with coronary sinus.
Option A.
Yes, it's right. Team B gets 5 marks. Now question is for Team C. Baxman's bundle, all except it connects SA node and left atrium. It is a subepicardial muscle band. It originates in sinus node. Disruption in this pathway can cause atrial fibrillation, which is wrong.
Option D.
D is wrong. D is wrong. D is not the right answer. Team D can answer.
Option B, subepicardial muscle bundle.
Okay, it is a subendocardial muscle band. So team D gets 3 points. Next question is for team A. Team D. H wave in JVP corresponds to isovolumic contraction, ejection phase, isovolumic relaxation, diastasis.
Isovolumic relaxation, option C.
Option C is wrong. D is your team D, no? So now team A can answer. The question is passed to team A. You can answer. Option B. No, you're wrong. D is the right answer. Okay. So nobody gets marks now. This question is so at the end of this round, team A gets 5 marks, team B gets 5, team C no marks yet, team D gets 3 points, 3 marks. Next question is for team A. Feature of unstable plaque, all except thin fibrous cap, large lipid core, high content of macrophages, abundant smooth muscle cells, which is wrong.
Option C, high content of macrophages.
No. Now the question passes to the next team.
Option D.
Okay, you're right. So team B gets 3 marks. Next question is for team B. Lunule with nodule is seen in which of these? Option A, AV valve, semilunar valve, infective endocarditis, rheumatic fever.
Option B.
Yes, you're right. So team B gets 5 marks. Next question is for team C. Cardiogenic shock, which of the statements is wrong? Decrease in pulmonary capillary wedge pressure, inadequate cardiac index, elevated end diastolic pressure, evidence of end organ hypoperfusion. Which is wrong?
Answer A.
Yes, you're right. So team C gets 5 marks. Next question is for team D. Size threshold for prophylactic aortic root or ascending aortic aneurysm repair, all except. So which is wrong? Bicuspid aortic valve more than or equal to 5.5 centimeters. Marfan's more than 5 centimeters. Turner syndrome more than 2.5 centimeter per square meter. In degenerative aneurysm, it is more than 4 centimeters. Which of the options is wrong?
Option D, degenerative aneurysm with more than 4 cm.
Okay, team D gets 5 marks. So at the end of round 1, team A has scored 10 marks. Team A has got only 5 marks. Team B has 13 marks. Team C 5 marks. Team D 8 marks. We'll move on to the second round. pharmacology. So the question is for team A. Ticagrelor, which is false statement. Dyspnea, high dose aspirin is recommended, more potent than clopidogrel, reversible P2Y12 receptor antagonist. Which of the statement is wrong?
Option B.
Option?
B.
Okay, you are right. Team A gets 5 marks. Next question is for team B. Dose modification is not required in renal patients with which of these drugs? Abciximab, tirofiban, eptifibatide, zymalagatran.
Option A.
Option?
A.
Okay. Team B gets 5 marks. Question is for team C. Brugada syndrome, which is false? It is a sodium channel defect, a sudden cardiac death in men while sleeping, idiopathic VF, beta blocker decreases mortality.
Option D.
Okay, team C gets 5 marks. Drug of choice for Wolf question is for team D. Drug of choice for Wolf Parkinson White syndrome with AF with fast ventricular rate is?
Option D, procanamide.
Yes. Team D gets 5 marks. So, next question is for team A. AAV-NRT in newborn treatment includes all except verapamil, vagal maneuvers, adenosine, propranolol. Question is for team A.
Option D.
The question passes to team B. Fifteen seconds for past question.
Verapamil.
Time over. Okay. Next team ku vendanga sir. Andha question. Question is for team B. Following cause QT prolongation except amiodarone, sotalol, flecainide, digoxin.
Sotalol. Option B.
No. Question passes to team C.
Option C.
Wrong. So no team gets marks. Okay, next question is for answer. Digoxin. Question is for team C. Thrombolytic with shortest half-life is altiplase, retiplase, tenecteplase, none of the above.
Option D.
No. Question passes to team D.
Option C, tenecteplase.
No, answer is altiplase. So nobody gets marks for this question. Question is for team D now. Bosentan, side effects all except QT prolongation, liver toxicity, anemia, pedal edema.
Option A, QT prolongation.
Yes, that's right. Team D gets 5 marks. So at the end of round 2, I'm reading out the marks for round 2 alone. So round 2, Team A gets 5 marks, Team B 5 marks, Team C again 5 marks, Team D 10 marks. Next is clinical cardiology. Question for Team A. False about spontaneous coronary artery dissections. Female preponderance, smoking is a risk factor, long-term prognosis is excellent, can present as ACS or sudden cardiac death. Which is wrong?
Option A.
No. Question passes?
Option B.
Yes. There is no traditional risk factor. So Team B gets 3 marks. This question is for Team B. In TOF, RV pressure is suprasystemic, systemic, less than systemic pressure.
Option A.
No.
Option B.
Yes. So Team C gets 3 marks. This is for Team C. PND does not occur with, PND is paroxysmal nocturnal dyspnea, does not occur with LA myxoma, CCP, suprametal ring, ball valve thrombus.
Option B.
Okay, CCP is the answer. So Team C gets 5 marks. Question for Team D. P-wave alterance is seen with pulmonary embolism, SVT, AF, tamponade.
Option D, tamponade.
No. Question passes to Team A.
Option C. A.
Option?
C.
C. No. So nobody gets marks. Answer is pulmonary embolism. Pulmonary embolism, only P-wave alterance is there. Tamponade, there is total alterance. AF, there is no P-wave. No? PSVT, QRS alterance. Okay, next question is for? So round 3, second session. Now Team A will answer. Myocardial infarction, stent thrombosis is what type?
Option A. Type 4A.
Huh?
Option A.
No. Team B?
Option B.
Okay. So Team B gets 3 marks. Next question is for Team B. Hasbled score includes all except hypertension, labile, INR, stroke, elderly more than 60 years.
Option D.
D?
D.
Okay, it is more than 65 years. So Team B gets 5 marks. Next question is for Team C. IAB is not indicated in the following condition. Refractory cardiogenic shock, acute MR, acute AR, acute VSR.
Option D.
D. The question passes to next team.
Option A, refractory cardiogenic shock.
It is indicated, no. So nobody gets marks for this. Answer is acute AR. Next question is for Team D. 4 pillars in management of heart failure with reduced EF. All except beta blockers, AC inhibitors, ARNIs, SGLT inhibitors, diuretics. Team D.
Option D, diuretics.
Okay. Team D gets 5 marks. So at the end of round 3, it is only for round 3. Team A hasn't scored any. Team B gets 11 marks. Team C gets 8 marks. Team D gets 5 marks. So at the end of all the 3 rounds, Team A has scored 10 marks totally. Team B is leading with 29 marks. Team C has scored 18 marks. Team D 23 marks. Okay. Round 4 is buzzer round.
So this is a buzzer round. It has around 20 questions. So the ma'am will read the question, and the team getting the buzzer first will get to answer. You will be awarded 10 marks for the correct answers. If not, there's no skip or anything. You'll be 0. Okay. $20 questions. A trial of buzz. Can anyone like you try it, like if it's actually working, just for a trial. Anga read agda? Read agdilla? Trial if everything is working only. If it, just try once. Okay. Teams ready? Each question is 10 points. Answer carefully.
You can see there also if the image is not clear.
HOCM.
Huh?
Hypertrophic obstructive cardiomyopathy.
No, it
Banana.
is wrong. Pass a line. Okay. This is tetralogy of Fallot. You can see the large VSD here and the aorta overriding the septal defect with RV hypertrophy. Okay.
Be quick with the buzzers.
Okay. We are moving to the next question. What is this?
Buzzer first. Team D.
Team D. You have to answer. You just don't.
Team D quickly answer, or the second one who was press the buzzer will answer.
Spons myocardium.
Okay. Okay. It is LV non-compaction.
Non-compaction.
Next question.
Be quick with the buzzer. We'll wait. Buzzer. 5 seconds. 5 seconds. 5 seconds. Now. So it's only a time span of 5 seconds. Otherwise, the next team will have to answer. So we'll have to have you will be getting a negative mark of -5. So careful with the buzzer. If you're pressing the buzzer, you have to answer within 5 seconds, or else you'll get a deduction of -5 marks. Careful.
What's ready? Ready?
Ready, teams? Buzzer first, answer next.
Correction of aorta.
No, wrong. It is PDA.
Swans catheter.
First cardiac catheterization.
Swans.
No, I want the name of the person only. Times of -5. No, pass, no. Pass, sir. No. He's Werner Forsman. Oh, sorry. What is the diagnosis?
Figure of a TAPVC.
Okay, you're right. So team C gets 10 marks. Mechanism of action of evolocumab?
PCSK9 inhibitor.
Okay, team A gets 10 marks. Next is trials in left main PC all except. Which is the wrong answer? Team B?
Option C.
Wrong. Option is D. Bifid wave is seen in which type of LQTs? What is this?
Mitral clip.
Okay. Prosthetic mitral. Okay. Prosthetic mitral. Prosthetic mitral valve. Bileaflet valve. Sure. Okay, sir. True vascular ring is?
Option B.
No, wrong. Double aortic arch. All others are partial. What is this ECG?
Epsilon wave.
No, it is atrial tachycardia with Wenckebach block. What is this ECG? Okay, team B gets 10 marks. Team B. Who is this? Name this person. Person standing. No. He's Alan Krieger. Tavern, sir.
Epstein and all.
Okay, team D gets 10 marks. What is this? Quite a simple diagnosis.
Pericardial effusion. Tampon. Cardiac tampon.
It is aortic dissection, so nobody gets marks. What is this?
Proximal LAD occlusion.
Left main occlusion. Sir? Okay. So team D gets 10 marks. Diagnosis? Answer should be, diagnosis should be, there should be one diagnosis, not many split diagnoses.
ASD.
Complete diagnosis. No.
With cushion defect. Endocardial cushion defect.
Okay, AV canal defect. Okay, it is AV canal defect. There is primum ASD along with common AV valve, along with inlet VSD also. So team 10 points for team D.
Option D.
Option C. C is the answer. Sorry, last question. Sir, last question. Last question. You வந்துட்டு இல்லை சார் முடியுது சார் கொஸ்டினை போட்டுட்டேனே சரி
You have one more question, but as of now, know your status. You just declare your marks as of now.
So we have displayed 19 questions for round 4 till now. Team A has scored 20 marks, Team B 20 marks, Team C 10 marks, Team D 30 marks for buzzer round alone. So far, the total score is 30 for Team A, 49 for Team B. Team C gets 28 points. Team D is leading with 53. ஆமாம் சார்
Final question. Buzzer, please. Buzzer first.
Final question.
Team B has the buzzer.
It is macrosomia. Warfarin causes microsomia.
That's it. End of sessions. So by the end of all the 4 rounds, we have, I'll just announce the total marks and then we'll. So I'll just announce the total marks for all the teams after the 4 rounds. Team A has secured 30 points by the end of 4 rounds. Team B has secured a score of 49 points. Team C has secured secured points for 28 points, and Team D has secured the maximum of 53 points. I thank all the participants for the enthusiastic participation. Congratulations, all doctors. The second prize is backed by Tirunelveli Medical College by Dr. Narendran and Dr. Sanjay Bharati, which is Team B. Congratulations, doctors. I welcome Dr. Aibna Jesni ma'am and Dr. Calvin David Singh sir to award the winners. Second place, Dr. Narendran and Dr. Sanjay Bharati from Tirunelveli Medical College. Coming to the winners, it's Team D from Jayasekaran Hospitals, Dr. Praveen and Dr. Prashant. I request Dr. Calvin David Singh sir and Dr. Aibna Jesni ma'am to award the winners. Congratulations, doctors. Dr. Praveen, Dr. Prashant. Thank you, dear participants. Can we all raise for a photograph, please?
Good evening. We have come to the final part of the session. We thank everyone for participating and making this program a grand success. So first, initially, we like to thank our own team, our own cardiologist, Dr. Aibina, for supporting in the topics and for conducting a beautiful quiz. Thank you, Dr. Aibina. We thank Dr. Pragati for speaking wonderfully with lot of annotations and making the choreography a great success. Okay, then we thank our team, basically our managers, the reception people, and everyone for making this a grand success. We thank the pharma companies. We thank the pharma companies. Basically, we thank the Sun Pharma. We thank the Ranmark company. We thank USV and everyone for contributing and for making this a great success. So we would like to call Dr. Pragati to come over the stage. Mariappan from Sun Pharma. He was the one who arranged the speakers. So a great thanks to you, sir. Velu from Ranmark. Ranmark people can come. USV, Vinod, Gopal. Balaji from Medchronic. Isakimuthu from Lupin. Lupin team can come. Sun Pharma, Naveen, and Sun Pharma people. Ramamurthy, United Biotech. Intas, முத்துக்குமார் இருக்காங்களா? சரி. ஆ ஆ அவ்வளோதானே? வேறு யாராவது இருக்காங்களா? ம் சரி. We thank everyone for making this a wonderful CME. We call all the duty doctors to come forward for a snap. Duty doctors, Dr. Pragati, Dr. Aibina, to come forward. Doctors, retired doctors, everyone can come.